Hello, hello. हो गया स्टेबल हुआ हो गया ना?
ठीक है आओ बाहर।
इधर से हो गया ना? हेलो हाँ जी सर मतलब फोन इधर ही होता है इधर भी माइक है ना नहीं सर नहीं चल गया सर
यूट्यूब तो ना खुली हुई है
खुली है
कहाँ खुली हुई है नहीं सर इसको बंद क्या रहा है आवाज़ आनी नहीं चाहिए
इसकी वजह गाड़ी
हेलो मेरी आवाज़ नहीं जा रही ना
खराब है डिस्टर्बन कहाँ है सोने बुला उसको
बाहर आपने बुलाया ना मनदीप सर बुला दे सुमित तो बाहर बैठा था
बेटा पीछे क्यों बैठ रहे हो आगे आओ इस इन चेयर्स पे आओ सोफास पे भी आ सकते हो आप
ये नहीं एक बंदा था है बंदा था
इको बिल्कुल करना है। Good morning, everyone. Good morning, everyone. We start day 2 proceedings. Sessions have to begin at 10, but we will be starting with Jyoti Prajwalan and a talk by Ms. She is an energy healer, and this is an alternative system of medicine. Well, I welcome our guest of honor, Mahant Rajinder Nath ji from Pirko Temple, Jammu, who has been kind enough to come here for Jyoti Prajwalan and to speak a few words about him, that he helps cancer patients, whosoever goes for financial help. Always been a patron of our trust. Thank you, sir. So, I request Secretary Trust Shashi Khajuria ji to escort him to the, and Dr. Satyankar to kindly.
Stage. She is presently working at Pranikta. They work at alternative therapy. They help doctors to heal the patients fast. Mrs. Anu Sharma, please.
Good morning, everyone. I'm from Jaipur and I'm a pranic healer. I came here yesterday and I saw doctors talking so much about healing and environment, and I was so much impressed. Many doctors talked about as to how we can reach to more people, and I am also into that. I'm into a healing modality which is a no touch therapy. Actually हम heal करते हैं बिना touch किए, and what a coincidence that I'm very thankful to the organizers of the event, first of all, who have invited me to give a talk here, because we also more people to know about this alternative therapy which is there in our Upanishads, in our Vedas, and not known to many people. So with the help of doctors and with the help of healers, we can create wonders in healing. So what doctors do? Doctors, what they do is they heal the physical body, and we focus on energy body. I have read somewhere in the books very long back that what if doctors and the healers, they work together, they can do wonders. When there is a breast cancer, how much trauma is there for the lady, right? So as a healer, what can we do? We can, like, as a pranic healer, I work on the physical body also for he was based in Philippines. His mother was Buddhist and father Chinese. He was a very good pranic healer. He invented this therapy. He told that these are the teachings of the ancient times which are lost somewhere. So he invented this. He was a businessman. He was a chemical engineer. And still he managed to bring all these teachings around. And what he says is that what a man needs a good health, happiness all around, good relationship, and money to survive today in this world. So he and we have so many centers worldwide. Our Philippines, of course, so this is posted all over the centers that we have not only doctors, but we have all help of doctors to come forward to help us to know better the physiology of the man so that we can now our goals are to provide health of family healing ailments, including physical ailments, and also physiology of the physical body, but energy body, there are nadis, there are meridians, there are chakras which we work on, because chakras are connected to your internal organs. And nowadays there is a bio-based camera where you can do the scanning and you know how the chakras are working in which area. So we have many bio-based cameras in all over the centers in India and worldwide where you can go and have it checked. With the what we see, the colors we see in that, we can tell you which ailment you are going through without you telling us. But we don't diagnose like doctors, and but we don't give any diagnosis and any medicines. We just do energy healing. So pranic healing may, what we do actually is we work on treating energy, body, and chakra. So in the ancient times, we know we had 7 chakra systems, but we in the pranic healing work on 11 chakra system, and all the chakras are connected to your internal organs. And when we scan a chakra and understand the chakra, we know how we have to work on. Here we need the help of doctors. When a patient comes, we tell them to have a scan, have a talk with the doctor. If any tests are needed, they go there, they do that, and we know that where we have to work on. And then as this talk is on cancer. So when I was thinking of that, when a lady is suffering from breast cancer, lot of trauma is there, the health as well as trauma. So we work on emotional body and the psychological level to make them calm. So we give a meditation also for that. So we help to increase the willpower of the patient to fight with the cancer. So that is what is needed. The foremost thing needed is willpower of the patient. If patient doesn't have willpower, no one can heal that person, right? And by increasing their connection to the main source of energy through the meditation, we help them to have a calm and serene life. Now, helping cancer patient, how we can heal their ways? At the physical level, healing are done by healing the specific part where the cancer is. Like in the breast cancer, we heal the breast. We see the reports of the doctor and we go to that particular part because we are not touching anything. We are just trying to manipulate the energy of that part. So when we maintain the energy of that part, the healings are very nice. The doctors' medicines, they work better. Now, psychologically, that person is down, so we help them improve their functions, their psychological level, their energy body, their health rays, their meridians, their nadis are cleaned by the healing. And meditation on twin heart, there are a lot of research on meditation of twin heart, where they say that this twin heart meditation, it increases melatonin up to 300%. And there is a research, and the patients who have greater melatonin level in the cancer patients, they heal faster. If I'm wrong, please correct me. You are doctors, you know better than me the physical ailment. The stress level and depression through the meditation is decreased, and willpower to fight, because you all know, like maybe you don't know, but I know that the chakras are there at the forehead center, which increase willpower of a person. So we work on those chakras to increase the willpower of the patient. There is a research work. If you type on the Google pranic healing and cancer research, there is one paper that is put on our WPHF portal, which is showing that pranic healing, Jyoti, it was done on as a complementary therapy in stage 4 metastatic cancer, or the results were very wonderful. 4th stage, maybe the patient was very fast. And there are many more stories that you can search on the Google, and you can see our work done over there. I don't know about this statistics, whatever is given, because I'm not a doctor, but you know better that how much how much healing was done, and the results were shown in 15 to 20 days exactly. So medical help assisted by pranic healing thus helps to heal fast. If the doctors come forward and help us in doing this, there are many hospitals where we are trying to open the pranic healing centers so that meditation can be taught, because twin heart meditation is very good advanced meditation to heal the stress level and psychological level. We heal relationships with the physical ailment. Thank you so much for listening to me. I am here, and I'm open for all your questions. Whatever you want, you can come the whole day. You can come and ask me anytime. Thank you so much, Aarti Madam.
Thank you, Mrs. Anju. I feel privileged to extend my warm welcome to all presentees here. I invite guest of today's function with a request to come on the position and occupy the distinguished chair. I invite Dr. Anita Malhotra. Please come on the stage. Dr. Anita Malhotra. Thank you, ma'am. Now I request Dr. Kunal Sharma to grace the dais.
Yeah, ये वो उसमें नहीं होता।
चल रही है पूरी ना चल रही
So a very good morning to all of you, and I hope the first sessions are always a little less populated, but I hope we'll have quite an exciting round of discussions. Lung cancer, as we all know, has been a prototype for the advent of oncology from broad spectrum chemotherapy to the targeted and immunotherapy era of medicine. So without much ado, I would like to proceed with my talk. A little bit of introduction on lung cancer. As we know, lung cancer remains the leading cause of cancer-related deaths in most countries. Not all, but most of the lung cancers we know are associated with cigarette smoking or tobacco in some form or the other. The problem with lung cancer is that we do not really have a very good advanced screening test, unlike cervical cancers and some of the other cancers. There are studies about role of low-dose, high-resolution CT. But we are still at a time when most of the patients present to us in very late stages. Smoking related carcinomas, as we know, usually develop in based on an oncogenic driver mutation, which results in the neoplastic transformation in the pulmonary epithelium. And targeted therapies that we have today are directed against these oncogenic driver mutations. So we all know historically lung cancers have been classified into non-small cell and small cell categories. The non-small cell categories usually have the adenocarcinomas, the squamous cell carcinomas, and the small cell carcinoma is a neuroendocrine carcinoma variety. And we also have the large cell neuroendocrine carcinomas. Now, the importance of morphology even today, we have a lot of people who say liquid is the new solid. But I definitely don't agree with that because, liquid biopsies are usually indicated in later stages. We do not have relevant adequate ctDNA present in early stage of the disease. Plus, we still need the morphology because it tells us what further testing needs to be done. For example, your molecular testing in a small cell carcinoma is absolutely redundant, but molecular testing in an adenocarcinoma makes all the sense. So, whenever we get a core biopsy in our center of excellence, what we do is we usually divide the cores. Let's say if we've got 4 cores, so we'll put them into 2 and 2. While 2 cores can go for the histopathology and IHC diagnosis, the rest of the 2 cores can go for your molecular evaluation at the same time. We always say that in lung, tissue is the issue because you usually have CT-guided biopsies, which are very small in size. And, tissue gets depleted fast as we process for the further testing. So we have the immunohistochemistry markers in which TTF1 and napsin are for adenocarcinomas, P40, P63, and CK5/6 are for squamous carcinomas. And we have the neuroendocrine markers, which are synaptophysin, chromogranin, CD56, and INSM1, which is one of the more recent IL markers. So the importance is that sometimes morphologically, we don't know what type of cancer we're dealing with. So in those cases, these IHC markers are very helpful to typify which cancer it is. And sometimes all of these markers are negative. In that case, we call it a null immunophenotype. Now, there are certain terminologies that we have for your resection specimens and small biopsies, which are different. So you never give a diagnosis of adenosquamous carcinoma in a small biopsy, because for giving any component, you have to have at least 10% of that component. So if you are seeing both adenomatous and squamous cell patterns in a small biopsy, you will say that this looks likely to be an adenosquamous carcinoma, but correlation with your resection specimens is mandatory. So in resection specimens, you have the small cell carcinoma, the large cell neuroendocrine carcinoma. There you can give adenosquamous carcinomas, and you have also the pleomorphic, that is the spindle cell carcinomas and the giant cell carcinomas. So adenocarcinomas are of various types. There are the lepidic, papillary, acinar, micropapillary, and solid adenocarcinomas. These are just, the types of different adenocarcinomas. Lepidic are usually the most low grade. Then you have the acinar, papillary, and the micropapillary and solid adenocarcinomas are the ones which are the higher grade. Now, if you see this solid adenocarcinoma, this almost looks like a non-keratinizing squamous cell carcinoma. So to differentiate a solid adenocarcinoma from a non-keratinizing squamous, you need your IHC markers. So as I told you, for adeno, you have TTF1 and napsin. So this tumor beautifully lights up for TTF1. Now, coming to squamous cell carcinomas, they can also be of three types. One is the keratinizing, then is in which you see nice keratin pearls, like, these rounded keratin pearls. Then you have the non-keratinizing, in which you don't see keratin. And then you have the basaloid squamous cell carcinoma, in which you have a basaloid appearance. Now, just focus your attention to the middle picture here. That is the non-keratinizing SCC. And to this lower picture here, they look similar, right? So that's what solid adenocarcinomas and non-keratinizing SCCs are again a bone of contention. And this is again where your IHC is definitely needed. Then you have the neuroendocrine tumors. You have the atypical carcinoids, you have the carcinoids, atypical carcinoids, the small cell neuroendocrine carcinoma, the large cell neuroendocrine carcinoma. And you should always remember that you can have mixtures. You can have non-small cell lung cancers along with neuroendocrine carcinomas. So those have to be diagnosed very, very carefully. Another issue that we usually face is that there are a lot of mimickers. That means that you can have neuroendocrine tumor expression in non-neuroendocrine tumors, and you can have, and the other way around is also true. That is, neuroendocrine cancers can express non-neuroendocrine markers. For example, for adenocarcinoma, I told you the marker was TTF1 and napsin. So those markers can be expressed in a neuroendocrine carcinoma. And for neuroendocrine tumors, the markers are synaptophysin and chromogranin. They can be expressed in an adenocarcinoma. So what I'm trying to tell you is that, all this needs to be looked at in a very pragmatic fashion. You need to go very, very carefully about these cases. Another thing is that there are entities like SMARCA4 deficient undifferentiated tumors, which are very commonly present in the thorax. We need to understand that more than 70% of these are positive for neuroendocrine markers. And very often we see when cases come to me for second opinion, that they have been diagnosed as a small cell carcinoma or a large cell neuroendocrine carcinoma. And these are actually SMARCA4 deficient thoracic sarcomas. Then you have the basaloid squamous cell carcinomas. Another thing we need to remember, especially the pathologists, is that in a neuroendocrine tumor, especially in a non-smoker, a low-grade neuroendocrine tumor can show extensive crushing. So it can look like a small cell carcinoma. So that's where Ki-67 is indicated, so that you know that where the grade lies. So I'll just show you one example of such a case. We had this case, which was called as a large cell neuroendocrine carcinoma, that came to me for second opinion because the patient wasn't responding. And we did a synaptophysin, which came strong. So somebody would have probably done the similar markers. But we also did a marker of germ cell origin, that is SAL4, which came positive. And also we did a very special marker called BRG1, that is SMARCA4. So when we did this, we knew that we are dealing with a case of SMARCA4 deficient sarcomas, which are very, very different from a case of neuroendocrine carcinoma. Now, without going more into detail, I will come straight to the molecular pathogenesis. The importance that you need to understand is 50 to 70% of Asian and 30 to 40% of non-Asian populations have an oncogenic driver mutations. So mutations can happen because of loss of function mutation in a tumor suppressor gene or gain of function mutation in a proto-oncogene. So what happens is that the normal cell, it becomes insensitive to inhibitory signals and it starts growing on its own. So the current era in which we are going, chemotherapies are broad spectrum, right? They will target every dividing cell. But targeted medicines are different. They will only target the cells which have that underlying mutation. So it's important to understand what mutations does the cancer have. So when we look at the non-small cell lung cancers and we divide them into squamous and adeno, you will see that most of the cases still have unknown mutations. We don't know, but there are variations. For example, in India, EGFR mutations are very common in adenocarcinomas. In squamous, mutations are present, but we still do not have very good targeted treatments. So the most common mutations seen in squamous are FGFR and PIK3CA. Now I'll just briefly highlight the important molecular mutations that we see in lung cancers. Even the oncologists will be very, very interested because it is when we detect these mutations that the respective antibodies are given. So KRAS is a mutation that is usually seen in smokers. KRAS is the most popular mutation in adenocarcinoma, but predominantly in the Western world. In Indian, I told you, or in Asian, we usually see the EGFR mutations. EGFR, ALK, ROS, and RET are lung adenocarcinomas, which are usually seen in non-smokers. I've already told you that Asians usually show a higher incidence of EGFR mutation. Another thing is, if you have a squamous cell carcinoma case of lung cancer and somebody has given an EGFR mutation, most commonly it is a misdiagnosis that has happened. The two major EGFR mutations that we have are in-frame deletions of exon 19 and L858 substitutions in exon 21, which are usually seen in the elderly. Then coming to ALK and ROS, these are respectively seen in about 5% cases show ALK mutations and about 1 to 2% cases show ROS mutations. The important thing is that they show genetic homology. That means the same drug can be used, as we know, crizotinib is also an ALK inhibitor, and it is also used in cases of ROS because ROS and ALK show genetic homology. So these are just some in-house cases in which you see beautiful ALK expression and beautiful ROS expression. Now, the thing about ALK is that IHC is a very good test for ALK, whereas for ROS and other tests, you usually need FISH or further advanced sequencing. Then BRAF mutations, these are the most easily targetable mutations because they usually fall in the common locus, that is BRAF V600E. These are seen in about 1 to 2% of adenocarcinomas, and a single agent usually results in rapid resistance to the MEK pathway. Therefore, we go for combined therapy. Exon 11 mutations are rarely detected and they are non-druggable. Coming to MET, we know that MET exon 14 skipping mutations are the most commonly. And again, these can be targeted with crizotinib, capmatinib, and deptotinib. Then are the RET mutations, which are seen in about 1 to 2% of non-squamous, non-small cell lung cancers. A very new target that we have is the NTRK. Now, this is a very common hot topic of discussion because, like your MSI, there are variety of tumors that show NTRK. And NTRK, we have 3 types of NTRKs: NTRK1, NTRK2, and NTRK3. The important thing is that these are targetable through your entrectinib, which is a drug that you can target whenever you detect NTRK mutations. And IHC is available for NTRK, so you can screen these cases very well. IHC usually gives you a result in 1 to 2 days, whereas molecular sequencing will take about 10 to 14 days. So IHC is a very good test to detect NTRK mutations. Now, wherever I go, people usually ask me, which modality should we use, for what case? So whenever you have a high volume sample, any type of test can be done. But in a low volume sample, you need amplification. So something like a ARMS is what we usually look at. And when your mutation type is known, for example, you know that you're suspecting EGFR mutation, you go for something like a PCR. And when your mutation type is not known, that means you don't know what you're looking at. You go for a broad spectrum sequencing like a next generation sequencing. So this is a very clinico-pathological chart that all people can take home. This just shows you the most common mutations which are seen in lung cancer and what all other drugs which are available for them. For EGFR mutations, you have the tyrosine kinase inhibitors. They are the first, second, third generation TKIs. Whenever a patient relapses on EGFR, you usually have the T790M mutations, In those cases, you give osimertinib. If patient has relapsed on osimertinib, then you give, the broad spectrum chemotherapeutic agents. For ALK, I told you alectinib is there, and then there are the ALK inhibitors like crizotinib and ceritinib. ROS, again, you can give the ALK inhibitors like crizotinib and ceritinib. For BRAF V600E, we go for dabrafenib and trametinib. For NTRK, I told you the drug is entrectinib. For RET and for MET exon 14 skipping mutations also, we have their respective drugs. Now, there are certain new mutations which are on the block. There is the KRAS G12C mutation, for which we have a drug called sotorasib that has been FDA approved. Then there are the HER2 mutant lung adenocarcinomas, for which you have a drug called pyrotinib. And then coming to, one of the last and the most modern ways of treatment, that is the immunotherapy. So in lung, immunotherapy is very well indicated. Wherever you have a lung cancer which expresses PD-L1, there are different immunotherapeutic agents which are available, and these are companion diagnostic assays. So that means that you have a common platform, you have one clone, and you give that particular drug. So if you're doing 22C3 testing, you give pembrolizumab. If you're doing SP142 testing, you give atezolizumab. So basically what happens is, whenever a lung cancer expresses PD-L1, it evades the immunity. When our immune cells try to attack that cell, it evades it. So what we do is we block this pathway by giving anti-PD-L1 drugs. So this is just one of the lung cancer cases which shows you a very strong PD-L1 expression. This is the NSCLC panel that we have in Agilis. It covers 14 genes, and these are the DNA and RNA genes respectively. Now, the most advanced modality of testing, I will just briefly tell you, that is the liquid biopsy. And liquid biopsies actually detect the circulating tumor DNA which are present in the blood. So you do not need a solid tissue biopsy. Okay, you can take the blood sample and you can see whether cancer cells are there, and you can do mutation studies on them and give the respective agents. Now, there are certain advantages that a liquid biopsy has over tumor biopsy. The advantages are, of course, it is easier to do. In a relapsed case of lung cancer, you usually don't find the tumor. So doing a CT guided biopsy can be very difficult. The other thing is that liquid biopsies usually address the topic of tumor heterogeneity. You can have a variety of mutations in the same tumor, which you cannot detect from a solid biopsy, but you can probably detect very well with a liquid biopsy. Also, in cases of tumor biopsy, a limited tissue may be obtained, but in cases of liquid biopsy, only few copies of ctDNA are sufficient to give you the whole picture. Plus, as I told you, the compliance is very good with a liquid biopsy, unlike a solid biopsy. But like every technique, it's important to know the limitations. You will have the pharma agents, and you will have, the various corporate giants infusing you with certain tests, but you should know their limitations. So liquid biopsy is not indicated in an early stage, because in early stage, the bloodstream will not have sufficient ctDNA. The other thing is, the presence of normal DNA hinders with the circulating tumor DNA. So that causes certain confusions. Also, the sensitivity of ctDNA is lower. That means that if you don't see a mutation, it doesn't really mean that there is no mutation. And detection of mutations at very low levels requires a very strong, sense of validation across different laboratories. So this is the liquid biopsy test that we have in Agilis Diagnostics. This is just for, the clinicians and the pathologists, a very simple way of understanding how we go about testing. If you have a patient of squamous cell carcinoma, the most important test is PD-L1. If you have a patient of adenocarcinomas, then you go for the variety of molecular mutations that I've told you. And if you have availability of NGS, you can go for a broad spectrum NGS. Otherwise, you can go for the most common mutations. That is EGFR, ALK, ROS, RET, and MET. And these cases also need PD-L1 testing. A very important thing that I would like to tell the clinicians and the oncologists is, whenever you send a case for lung cancer molecular testing, your PD-L1 report will be available in maybe 2 days, but your NGS panel takes time to come. So before you act on your PD-L1 report, make sure that you get your NGS report also. Now with that, I would just conclude my talk with a few very, very interesting cases that we had. We know that the proof of pudding is in eating. So let's have a look at some of these cases. This is the first case, 59-year-old male who presented with pain in the chest and difficulty in breathing since 3 months. The patient had few episodes of hemopsis. I would like to have everyone's attention because, then it becomes more interesting. The patient had lung mass of 4 into 3 centimeters with multiple pleural-based nodules. And this was reported as metastatic colorectal adenocarcinoma in another center. But the point was, when colonoscopy was done, there was no lesion in the colon. So this patient came to me for second opinion. And when we saw the PET CT of this patient, we saw that there is a huge lung mass. And also along with that, there are pleural nodules. When you see the histopathology, this looks like a colorectal adenocarcinoma because you see dirty necrosis in the lumen and you see a lot of mucin in these cells. But the interesting point was that there was nothing in the colon when colonoscopy was done. And when we did the IHC, CK7 and CK20 came positive. In lung, you usually don't have CK20 coming positive. The lung adenomarkers, as I told you, are TTF1 and napsin, which both came negative. Okay. And the GI markers are CDX2 and SADB2. So while CDX2 came positive, SADB2 came negative. So again, are we really dealing with lung or are we dealing with metastasis from the colon? But again, nothing is there on the colon. So what do? We also sent this patient for molecular profiling and we got HER2, KRAS and BRAF mutations. EGFR was wild type. Now KRAS, as you know, is seen in lung. It is also seen in colon. So what are we dealing with here? So this was a case of pulmonary enteric adenocarcinoma. These are lung cancers which show you IHC profiles of colon cancers. So these can very commonly be misdiagnosed as metastasis from the colon, but this is where your tumor board setting or a good clinico-pathological correlation is needed. Coming to case number 2, this is a case of a 65-year-old male, heavy smoker, presented with cough and weight loss. There was a large central mass with metastasis in the liver. When you see the histopathology, you see that this is a very poorly differentiated tumor and it's a very high-grade neoplasm. You see a lot of mitosis. The pathologist would be able to appreciate it better. A lot of mitosis is there, and there is no specific pattern to this tumor. CK was negative. Synapto and chromo were positive. This was also negative for CD45, that is no lymphoma. SAL4, no germ cell tumor. Desmin, no rhabdomyosarcoma. Synaptochromo, no neuroendocrine. NUT1, again, no NUT carcinomas. CD30, INI1, BRG were retained. CD30 was negative. So what was it? Was it a poorly differentiated carcinoma? We could not put it in adeno, could not put it in squamous, could not put it in neuroendocrine. So we did a very special marker called RB1, which showed loss. And we did another marker called INSM1. So if you remember the table, which I told you about lung markers, correct, Sarah's diagnosed it. So INSM1 is a neuroendocrine marker. So many a times your neuroendocrine carcinomas might be negative for your usual neuroendocrine markers, synaptochromo 56. So this is where an advanced setting usually helps you. This was a case of small cell lung cancer. And let's look at our last case for the day. This was a middle-aged man who was a smoker who presented with persistent cough and dyspnea. The patient had a large peripheral mass with nodal metastasis. This was the histopathology. Now, I'll tell you a very interesting thing about this case. This came to me for a second opinion and I was asked, is TTF1 positive or not? And if TTF1 is positive, let's go ahead with the lung cancer panel, right? So this looks like an adenocarcinoma. You see a little bit of lumen formation. And when we did the IHCs, TTF1 was positive. So should we go for lung cancer panel? Napsin was positive. And if you remember, I told you TTF1 and napsin are adenocarcinomas, right? So something that looks an adenocarcinoma is positive for TTF1 and napsin. Let's go ahead for lung cancer panel. But there was something in this morphology which was bothering me, and that is, if you see down here, you see a lot of pink area, that is the necrosis. And when you see a lot of necrosis in a large cell, non-small cell cancer, you must always be a little careful. So I also decided to throw in my neuroendocrine markers, and all three came positive, synapto, chromo, CD56. So this was a case of large cell neuroendocrine carcinomas with adenocarcinoma-like features. And you see that your adenocarcinoma markers can come positive. So napsin A can come positive in a neuroendocrine carcinoma. So this was a case of large cell neuroendocrine carcinomas. And why is it important? Because LCNECs do not need a molecular panel. Whereas for an adenocarcinoma, your molecular panel would be needed. So the point that I want to drive home with my talk today is that diagnosis today is not just about telling you which tumor it is. It is also about giving our clinicians the support to tell them what molecular mutations are present and what kind of therapy could be instituted in these cases. So this was an article which I had written for ET Health World. Today's diagnosis is beyond diagnostics. This is just some of the pictures from various talks that we have undertaken. And this is one of the meetings where I had met Satyankar sir in Srinagar earlier this year. And this is my team at Agilus Center of Excellence. I thank you all for a patient listening. And if there are any questions, I'll be happy to take them. Sure, sir. Sir, sometimes, so first thing is the data on treatment of these is very limited because these are very rare mutations. The other thing is there is a paper I'm presenting where I got the similar combination of EGFR and ROS1. And what I have seen, like it was Dr. Rena's patient in fMRI, and they went ahead with the tyrosine kinase inhibitors in the first chance. But when they relapsed, now they're probably analyzing crizotinib. But again, from what I have read, the studies are very, very limited. And maybe there is some complex pathway wherein both act as the driver mutations, So we don't really know. We are still analyzing these kind of cases. Pleasure, sir.
Thank you, Dr. Kunal. Thank you very much for such an elaborative talk. And as a pathologist, I feel that, clinicians should not be in a hurry and they should get a biopsy of lung cancer, especially wherever possible, because FNSEs have a lot of loopholes still. And clinicians are always in a hurry. If you write suggestive of so-and-so, that means we are also in a problem. There are some gray areas. So I would request everybody to
I think
take care of that.
ma'am
Thank
has
you very
raised a
much.
very significant point. Dr. Paras, please come forward. That FNACs have to be done away with now in all the malignancies. So may I now invite Dr. Rajinder Singh, sir, as the chairperson. Dr. Pradeep Garg, the chairperson, that way. Yeah, that way, chairperson, that way. And may I have the privilege to welcome Dr. Harshvardhan Puri, our own, student from Jammu, and he has done great, he's earned a big name in the field of robotic surgery. He's currently practicing at Medanta. So thanks, Dr. Harsh, for coming. So the dice is yours. Just one small announcement. Poster and abstracts are ready. So I think we can start at 10:30. They can go. So you can, those who are, here for poster and abstract presentation, you please go there. Morning, ma'am. So may I invite the panelist, Dr. Abhinav Chaudhary. He's a surgical oncologist at SMVD Narayana, trained at Apollo Delhi. He also hails from Jammu. Please give him a big round of applause. Dr. Paras Khanna, we all know. Anita ma'am is there. Wherever you feel comfortable. How are you? I'm good.
Hello. So good morning, everyone. Jai Mata Di. So basically it will be a discussion between. I have a panel of pathologists. Ma'am has taught me pathology in my early days in MBBS, and we have two surgeons, one pathologist. Sir is there as respiratory and radiation oncology. So we'll just run through the slides. I'll be asking few questions, and then discussion is open to the hall. So early lung cancer management, I'm Dr. Harshvardhan Puri. I'm a senior consultant thoracic surgeon in Medanta, the Medicity. So greetings from Medanta and Institute of Chest Surgery and Lung Transplant from Medanta. So why are we talking about lung cancer, and what is actually early lung cancer. So definition is not very specified, but yes, T1, T2, N0, N1 are the diseases which are classified in AJCC as early lung cancer. And why are we talking about it? Because if you see 100 cases of cancer in your OPD today, 5 years later, only 35 to 55% of these patients who will survive, who need management at this juncture, at this point, is early lung cancer, that is stage 1 and stage 2. So what are the presentations of early lung cancer? I would like to Dr. Rajendra Singh to answer, because most of these patients who are early lung cancer present to the OPD of respiratory physicians or pulmonologists. So what are the most common presentations you have in your OPD?
In our OPD, most of the times, these patients come with cough is the main symptom. And then occasionally they get mouth-ptosis, whether sticky or sometimes sudden also in large amounts. And then pain chest is another important complication or a symptom presentation where we suspect that he must be having something inside. Then loss of weight and appetite, of course, they are general symptoms. They do come with that. But main is cough, pain chest, and hemoptysis are the 3 symptoms with which patients come most of the time.
Sir, whenever you see a patient of cough or hemoptysis in your OPD, how many times this patient has come from periphery and misdiagnosed as tuberculosis in a country like India?
I would say in 99% of patients,
Yes.
they are diagnosed as tuberculosis. And when they come, they have already taken anti-TB, maybe for 1 month, 2 months, 3 months. And sometimes they develop this hepatotoxicity to anti-TB drugs, and then they stop.
Then they turn up to
They stop it, and then they come.
So this is a very important point I want to share, because ma'am also told in the beginning, you need a diagnosis to start a treatment. Even if you're giving a single tablet to a patient, it should be evidence-based, not on the whims and fancies of the physician. So as sir said, the presentations may be screen detected. This thing is new now. The low-dose CT is there, and a lot of institutions are going to the protocols for early screening of lung cancer-related patients. Incidentally detected is a very large part of early lung cancer. You get a chest X-ray done for something, and you just find a lesion there, and then the whole process starts. And symptomatic patient, as sir has said. So presenting the case scenario, the case I'm presenting is a 64-year-old gentleman, incidentally detected lung lesion. He was a hypertensive male and a reformed smoker with 135 pack years abstinent from the last 2 to 3 years. And for some reason, this chest X-ray done. If there is any radiologist in the sir. So this kind of X-ray comes to your OPD.
There is a opacity in the right lower lobe, and it has some breakdown in the center. Around which margins are round, and we will suspect.
So
what was the age of
slightly
the
speculated
age of the patient?
suspicion 135 pack years.
How about age?
65.
We will, and he was smoker.
Yes.
Suspect malignancy in this case.
So what would you go for? The next
will be CT scan.
Okay. So now my question open to the houses. We are 2 surgeons here. We have a pathologist. What upfront CT or HRCT and PET CT or CECT? What would be your investigation of choice? Dr. Satyankar, you can also come.
Upfront, I think HRCT is sufficient, in my view. PET CT, we can only start looking after we have a biopsy diagnosis and all. But upfront, it is sufficient to have a HRCT.
And Dr. Satyankar, would you like to add something like?
I will
Either contrast CT or HRCT.
I will do CECT, because when we are suspecting from the shadow in the X-ray that there is some malignancy, then maybe if CECT is done, we can see the mediastinal glands also.
So most of the oncology centers these days, what the practice is now are going for PET CECT. What my radiation oncology or medical oncology friends or the tumor board says, that if you have to go for a single investigation and money is not a restraint, even PET CTs are done with good amount of acquisition in cheap prices now. Should you go for a PET CT or not directly upfront?
I think considerations of price and availability are still lower down in the priority list. Let us first answer the questions which we want to answer for the patient. The first question would be characterization of the lesion, assessment of the mediastinum. So saving about another 2.5 to 3.5 thousand for a CCT and jumping directly to a PET CT. While logistically and financially it would make for a strong argument, I still have pretty old school in that let us answer the pertinent questions first and then move on stage wise to the next investigation.
Okay.
We are not losing time for the patient. We're not losing time by
And
this.
time is a constraint. And
Definitely, but we're not losing time with these investigations. They can be done
Sure,
in a day's time.
so, what usually is done in oncology center is a contrast enhanced PET with an HRCT chest film, because as a surgeon, I would like to have a segmental anatomy. As you said, we are running against the time in the cases of lung cancer relationship with the vessels. And if I'm planning a segmentectomy, then definitely an HRCT is required in these cases. So I'll just run through the this CT run of this patient. Dr. Vivek, sorry.
Dr. Vivek, the studio surgeon, sir has just joined. So can we sum up the case?
The basic background is a 64-year-old gentleman which presented to the OPD, incidentally detected middle lobe lesion in the chest X-ray, and he is a reformed smoker, 135 pack years, no much symptoms, and he is being evaluated for further. So the CT scan, as the panel told, should be the first investigation. This is a CT scan of the patient. So all suspicion now on malignancy, speculated lesion, 65-year-old gentleman, 135 pack years. So what would be the next investigation of choice? Would you like to go for a PET CT at this juncture, or would you like to biopsy the patient first?
Definitely biopsy.
Biopsy.
Let's answer, as Dr. Paras said, let's answer the question, settle the issue. We have a biopsy diagnosis. Then we can tell the patient, now we have to see whether there is metastasis or not, and plan the treatment accordingly.
So we have the PET CT run of this patient also. I'll just like to show it to the panel. Actually, Medanta being a tertiary care center, we already have all the investigation with the patient. He just comes with a bunch of things to us, our face, and treat. Yes, I know. I agree. So all these big corporate hospitals which are coming up in Tier 2 cities also have all the facilities now, and the patients are already being worked up and sent to the centers like them. So we have a speculated lesion in the middle lobe, and PET, according to the PET, the mediastinum is still negative.
Yeah, I haven't seen any nodes in the mediastinum, so we can classify it as.
That like Dr. What biopsy? What kind of modality you will use to biopsy this patient?
I think CT guided FNA can be done, and we can even go for bronchoscopic bronchoscopy, and if possible, the biopsy can be taken.
So as sir has told, there are 3 or 4 modalities of bronchoscopic. If there is central lesion, we can go for radial EVAs. The FNA, it can take a biopsy also. Then the most common is image guided biopsies like ultrasound or CT guided, especially for the long, small lesions which are detected incidentally. Now comes, if everything is in dilemma, we can go for VATS and take the biopsies of this patient, and EBUS comes at the end. We'll discuss it in further slides. So the CT guided biopsy was done, which showed non-small cell lung cancer, TTF1 positive, P40 negative. What would be the approach of the panel? I would particularly ask the surgeons to answer it. How would you proceed now?
Metastasis. So now it all comes down the performance status, etc.
So you would directly like to prepare the patient for surgery.
Yeah. So in this case, that is
any role of mediastinum staging in this patient, because it's a 3.2 centimeter lesion according to the CT scan.
So you are asking about mediastinoscopy, or
Staging.
so we've done the PET. It's negative. So I don't think there is any need to do a specific staining in this case. If there was something avid on the PET, we could have gone for E-buzz.
Sure. So staging has to be done in all cases of lung cancer. The whole body PET scan with IV contrast, CECT, as our already told, should be done. What about MRI? Would you like to go for an MRI?
Meet the criteria yet for a brain. Asymptomatic patient, early stage lung cancer, SCLC, it's not mandatory to do a brain.
It's not mandatory, and the only indication would be if he had some neurological symptom.
So if you go to the industry and ask the PET people, they say that the PETs these days are good enough to take the lesions of the brain. But according to the literature, most of which I was studying, there is 17% loss of brain lesions if you go with PET findings only. So all the stage 2 patients above stage 1 should go for an MRI. Is the latest recommendation by ESTS also, and I think by ICLC group also. All stage.
Dr. Harsh, I just wanted to make one comment.
Sir.
In the previous slide, you asked whether we should do a mediastinal staging
Yes.
in this patient or not.
Sir, I want.
Because look, this is the peripheral region.
Yeah.
Had it been the central region,
Yes.
then definitely you would have before going for a radical stage surgery.
So
Mediastinal sampling was definitely required, but the probability of having a false negative PET in a peripheral region early stage is just about 10%. So
less than 10%
this particular.
in this country. So
And sir, I just had, so one was this exactly point that I wanted to raise. The other thing was we are treating this now as an adenocarcinoma,
yes, we are
right?
treating it.
So
as
I just wanted to make a point that I showed you cases where TTFN and P63 are not enough.
yes.
TTFN can come in neuroendocrine tumors and we can see a lot of overlaps.
So because of the mixed audience here, I'm
Possibly of-
just,
no, that's
showing
fine.
the
That's fine.
more basic things.
That's fine.
Yes.
That's fine.
So fitness assessment as told by the surgeon. So we go for a PFT with DLCO, with functional testing, cardiac assessment, maybe CPET, and optimization of the medical comorbidities. What would be your approach for the mediastinal lymph node evaluation? Mostly in this case or the other cases, the ESTS says if the PET is negative and the lesion is peripheral, less than 3 centimeter, no need for any mediastinal staging. If PET is positive, the lesion is central or greater than 3 centimeter, you should go for mediastinal staging in all the cases. So what is the modality you would like to, Dr. Sanjeev is here, what kind of modality would you like this mediastinal staging to happen in the present era? Would you send the patient to me or keep the patient with yourself? Sir, very, very nice modest answer because the surgeon is standing on the moderate front. See, the ESTS 2014 guidelines say that if you do a good EBUS plus an EUS, which is known as medical mediastinoscopy, you can skip the surgical mediastinoscopy. I haven't done a surgical mediastinoscopy from the last 5 years now because my respiratory people, the EBUS people, and my EUS suffices for the mediastinal staging. Only possibility is if you have a PET positive mediastinum, you do an EBUS EUS, you have a negative result, always complement these results by doing a mediastinoscopy or a VATS biopsy is the recommendation. I'll just ask the surgeons.
Thank you, Dr. Harsh, for bringing that up. It's very important to understand that when the mediastinum is clinically negative, and we're talking about the PET is also showing no uptake.
Yes.
The patient mandatorily should undergo some kind of a biopsy procedure.
Yes.
And we are lucky in Jammu to have pulmonologists who are routinely doing EBUS.
Yes.
So that's very important.
About mediastinoscopy, I think it should only be done by a person who knows it. Yeah. It's a little difficult. It's tricky, and you can even injure the vessels there. So either a CTVS surgeon or somebody who's apt to do it should do it.
Somebody who's doing high volume lung, what is your idea, personal idea? How do you position mediastinopy as against VATS? Because VATS is something which we are doing routinely.
Sir.
Our degree of comfort and the delivery is better.
Sir.
Do you still hold the dogma that the mediastinoscopy comes higher up in the algorithm before VATS?
Sir, my say is no, not at all. So
That's very important.
That's what I was telling you. From the last 5 years, with the advent of EUS and EBUS, I'll stop doing mediastinoscopies. Even if a lymph node is sent to me that you have to sample this lymph node, I will preferably do it with VATS. because I can do it with VATS in 1 hour. The mediastinoscopy, I've seen all kind of complications in the world, as icons going, SVC going, pulmonary artery going, and you don't have that window. You just have to do a sternotomy, control those things. So I'm not inclined, and I'll just like to show you a paper that unforeseen N2 disease. The mediastinoscopy and the endosonography results fairly are comparative to each other, with an advent that 6% complication rate is higher in mediastinoscopy. So this 6% is significant, and we are talking about the centers who are high volume centers. Which were doing mediastinoscopy in and out. And in a peripheral center with people who have not done mediastinoscopy, it can cause havoc at the tables. I think Dr. Vivek also will agree with me.
One more point, Dr. Harsh.
Sir.
Sorry. In complicated cases where you have too much dicing, whether it's connected, the sensitivity and the specificity of combined US and US is, I think, 95%.
Is much higher than
So
only US or only US.
Combined.
Yes. So that is why it is known as medical mediastinoscopy now.
I think Dr. Harsh, one point I think Dr. Satyankar also would agree is
Sure.
that in this subset of T2 patient, it is very important to identify whether the patient is node positive, because the approach is going to change from upfront surgery to neoadjuvant chemo. So that is why the whole effort has to go into document if there is any PET-avid mediastinum. But in those cases, I still believe that the percentage result of a positive PBUS, when you compare it to a VATS procedure, is very high. By VATS, we can deliver that staging very confidently so that the patient can be handed over to you for a neoadjuvant protocol.
So always failed EBUS, failed EUS, we do a VATS instead of doing a mediastinoscopy. That is the consensus of the house.
I think mediastinoscopy is pretty outdated today, and
Love to have more sample with them.
The tissue is an issue for every always an issue. So what modalities of treatment we have? Now surgery is the standard of care. Now comes early lung cancer and radiotherapy. Would you like to have your 2 cents on this?
We then went to the SBRT and the IGRT. So we are here. And the results are also comparable.
Yes.
But more thing is
So the results, all the results, the 2021 consensus statement shows that SBRT is here. It's growing also, but it should always be given to patients who opt out of surgery or are medically inoperable. I think
yes,
we have
that is the consensus.
Yes.
Those who cannot tolerate surgery or refuse surgery, that is when we should consider.
So, resectable, medically operable, surgery is the standard of care. Medically inoperable, we have alternative chemo, radiotherapy, SPRT, or if now comes whether we should go for a segmental resection in these kind of cases or a lobar resection. So what does the so what we did actually was a VATS right middle lobectomy with SMLND. The intraoperative finding was 3 into 3 centimeter lesion right middle lobe, no other nodule, no pleural pericardial nodules, no effusion. 2 to 4 hour dissection, 7, 10, and 11 were taken out. So my surgeons are here. What is your take on mediastinal lymph node sampling versus taking out these nodes while doing a VATS or open surgery?
Irrespective of the surgical approach that you're choosing, if you have decided based on the position of the tumor and size of the tumor, then there has to be a proper systematic dissection of the mediastinum. It is no longer an option to do a cherry picking.
Definitely. So CalGB 05.
Yes, I think I also agree that one point I would like to make that there are not many nodes here anyway. Sampling and difference between sampling and actual dissection is not much. It's just 2 or 3 nodes. So I think you have to do full dissection.
As the surgeons are becoming comfortable with doing VATS, and it's for the young public sitting here, mediastinal lymph node sampling is out of question now. It should be systematic mediastinal lymph node dissection, taking out all the lymph node station. Minimum 3 lymph node stations should be taken out for when you're doing a VATS lobectomy or open lobectomy. Now comes the question, what all surgical approaches could be given to the patient? So we have thoracotomy, we have VATS, uniportal, multiportal, and robotic. So there is a Violet trial which shows now that comparing thoracotomy to any form of minimally invasive surgery, which is showing reduced post-operative pain, reduced hospital complication, shorter hospital stays, better quality of life, and oncological equivalence has been shown now because this Violet trial has shown of VATS as well as thoracotomy. So what is the role of segmentectomy these days in early lesions, like a 1 centimeter or 1.5 centimeter lesion right upper lobe? Would you like to go for a segmentectomy or a lobectomy?
Thanks to the increased awareness in the public and the other physicians post-COVID, there is a big percentage of patients which are incidentally detected.
Yes.
This is not an insignificant proportion.
Yes.
A lot of patients are coming with 1 centimeter, 2 centimeter, and then we have a cross-referral with the radiotherapist who would want to offer these very patients SBRT.
That is the issue exactly. So
Becomes an issue.
because of the availability of SPRT, this question is a bit tricky to answer now, because if you are doing segmental, then you might as well do SBRT in that patient. So that is the problem.
So what most of the trials are showing, if you compare a lobar resection vis-a-vis a segmentectomy vis-a-vis SPRT in a medically operable patient, lobar resection always will fare better. Sublobar is the second one and SPRT is third one. If we compare everything, we are comparing the oncological outcomes, we are comparing the long-term survival, disease-free survival, and so lobar resection for medically operable patient, yes. For a borderline patient, segmental resection should be offered to the patient. If the yes, please. So the Mumbai comes in. 100%.
There were comparative results, but because of number of patients, for whatever reasons, surgery remains the standard of care in medically operable.
Patient.
But there is no randomized controlled trial so far to suggest that it's after lobar resection, it is sublobar and then SBRT. We need a randomized data to prove that,
Yeah, it would be very difficult to do a randomized trial, but yes, meta-analysis are showing this.
So lobar resection is standard of care. Sublobar versus SBRT,
Definitely.
there's a lot of data generating.
Sir, so to the audience, the radiation oncology has a role now. They are coming up in a big way. The machines are getting better and better, and definitely medically inoperable borderline patients, SPRT has an option. Yes. Sir, everything was fine because obviously SPRT is a better option. So this pneumothorax in the apical area was post biopsy. It was not, these are not bullas. So this is not a COPD patient with a very good PFT reserve. So what are the surgical principles we follow when we do operate these kind of patients to the surgeons?
Absolutely. I think you summarized it correctly.
So anatomical lung resection.
The parenchymal resection, the mediastinal resection, and the bottom line is to achieve a R0 resection. So it becomes pertinent. Actually, this question I wanted to put to you. In this index lesion, it was, I think, well away from the fissure so that you could confidently go about doing a middle lobectomy. It is those regions which are riding the fissures when it becomes an important decision to make, whether we are taking just a segment of the lower lobe or we are contemplating a bilobectomy.
So whenever
there is one example I want to give. There was one patient where they were not able to biopsy it, and it was always coming negative. But they said the cellularity is not sufficient. So what we did a VATS. It was very peripheral and small. So we did a VATS segmentectomy. And it came out to be a carcinoma, adenocarcinoma, but the margins were clear. And the patient was subsequently given chemotherapy based on tumor board, and the patient is still doing fine. So there are some indications, some situations where you can do a segmental resection.
Definitely. So basically, the CalGB trial shows it should be anatomical resection. If they have defined VATS also, the incision should be less than the largest incision should be less than 4 centimeter. And because your question is if it is very near to the fissure. So yes. So what we are doing these days, we are doing a lot of uniportal VATS now. So what we are doing is fissure last approach. So we are taking the vein first, the bronchus next, the artery next, and then the fissure. So we can take a segment of the lower zones also. If you are doing an upper lobectomy, we can take the lower zone also. So now most of the centers are resorting to, if it's not very difficult, fissure last approach, because it reduces the post-operative air leaks and all those stuff also. So that's why we are doing, most of these lobectomies are being done now as facial last approach.
As the transition is happening towards more VATs,
Yes,
I think it is more easier for the surgeon to go for the structures first and then go for the fissure,
definitely.
because the traditional fissure first approach was catered to the
To the open surgeons, because they were directly seeing the fissures in front of their eyes. The VATS has given you that vision, that credibility to play with these structures. So fissure last approach is becoming almost a standard of care in, because uniportal is coming in a big way in the VATS also, in robotic areas also. So people are trying to do fissure last approach in those cases also where the lesion is slightly closer to the fissure.
Exactly. So I think this is basically how the surgical approach is now dictating.
Changing. Yes. So this is the patient. We usually keep these patients on negative suction. This is the first post-operative day. The sixth post-operative day, the drains were removed on second. Patient was discharged on the third post-operative. This is the final biopsy report. Invasive adeno-CA, moderately differentiated. I'll just like Dr. Rahul to put his 2 cents on this report. Would you like to go for a sorry, Dr. Kunal. Would you like to? Now, would you like us to do a NGS panel or molecular markers in this patient?
So that is something that you will have to tell me.
See.
I am the guy who runs the test for you, but I don't think it is indicated right now is what I feel. Maybe Satyanka sir, if you can.
Early
throw
lung
some light.
cancer, sir. We have operated the patient. This is a report in front of you. Would you like your surgeon or the panel to go for
At least
NGS markers?
EGFR testing, because I have.
EGFR,
seen
yes,
the
TKI
surgeons,
can be.
they-
Or the minimum,
If it is adenocarcinoma, they put the patient on geftinib or rotinib, and they've been taking for years together, and nobody dares to stop that. So maybe minimally, at least EGFR can be done.
EGFR can be tested.
I think EGFR, ALK, and ROS1, these are the most basic,
Most commonly,
basic now
yeah,
being done in all the samples.
Absolutely.
I don't want you to go for a complete NGS panel 152 or something like
Correct.
that, but at least EGFR, ROS1, and ALK should be done.
Right.
So in the absence of high risk features, are we going to go to do these tests, or are we going to plan for NGS in these patients?
So for a surgeon, it's very easy to say just do the biopsy and come out. But my medical oncologist always says that please go for at least EGFR, ROS1, and ALK in these patients, and if and maybe PDL1. So I don't know, that's a question I would ask the medical oncologist. Dr. Vad is sitting on 11th floor on my head, and he says, please, Harsh, do these tests.
I think in the absence of high risk features, we can omit to do this EGFR testing.
Sure. Okay, so adjuvant therapy will be decided by the medical oncologist now. So obviously, you have told me that EGFR has to be done. So all of this patient clinically, radiologically, what kind of follow-up would you do in early lung cancer? PET CT? No. Just a clinical examination? Then a CT scan. So take-home message is surgery is the standard of care in early lung cancer. Lobectomy still is the gold standard. And who can tolerate lobectomy? Intraoperative systematic lymph node dissection has to be done. Anatomical segmentectomy should be considered for lesion less than 2 centimeters. SBRT is here. Alternative treatment option should be discussed with the patient who are unfit, borderline, and unwilling to go for the surgery. Thanks a lot. Thank you for the panel, such a distinguished panel and a great discussion. Thanks a lot, sir. So any question from the house to the panel?
Any queries? Any questions? In early lung cancer? Thank you, sir. Coming to the next lecture of this session, Dr. Kaustav will be taking you the class on the SBRT in CA lung.
He is a leading radiation oncologist from Mumbai. Welcome, sir.
Thank you. At the outset, I would like to thank the organizing committee and especially Dr. Deepak for this opportunity in this wonderful city of Jammu. You know, we all know surgery has been the gold standard in the treatment of early stage lung cancer. Surgery has been the gold standard in the treatment of early stage lung cancer. Having said that, SBRT has emerged in a big way, and we need to know the evidences and situation for the same. So before getting on to SBRT, as this is a crowd which has medical oncologists, surgical oncologists, pulmonary physicians, what is SBRT? So Astro, ACR, CARO, and AAPM, they all define and agree upon that SBRT is a method of external beam radiotherapy, which accurately delivers a high dose of radiation in one or few treatment fractions to an extracranial target using tumor site specific imaging modalities. Do we have a pointer, please? Is there a pointer? Laser pointer. Why SBRT? Because although surgery is the standard of care in early stage lung cancer, a lot of patients are not medically operable. And that is when the lot of patients have comorbidities, lot of patients have old age, and that is when the SBRT developed. NCCN guidelines from 2018 have established SBRT as a definitive modality in the treatment of early stage lung cancer when it's medically inoperable. We have to understand that currently it should be offered to all patients who are medically inoperable or whose surgical risk is less than 1.5% of mortality as per the Astro American Society of Thoracic Oncologists guidelines. So let us first get through how SBRT came into the picture. So there were two trials. One was Stroke Chisel trial and one was a space trial, which initially evaluated the conventional radiation to SBRT. Conventional radiation meant delivering radiation over 6 weeks to a dose of 60 gray or above. The Stroke Chisel trial saw that there was a betterment in outcome and in progression-free survival in the SBRT arm. And the space trial showed that although there was no improvement in survival outcome, the toxicities were lesser in the SBRT arm in early stage lung cancer. And that was the genesis of definition of maybe we should move away from standard fractionated protocols into SBRT. Early evidence, Dr. Robert Timmerman, he started in early 2000. He delivered 3 fractions of a dose of 20 to 22 gray to peripheral lesions. His local controls were to the tune of 90%. And then he tried the same dose fractionation in the central lesion. So to define central lesions, central or ultra central lesions are defined as lesions which are within 2 centimeters of the proximal bronchial tree. To Dr. Timmerman's surprise, in late 2000s, he saw the great benefit he saw in the peripheral lesion for the same dose fractionation. He did not see the same benefit in the ultracentral lesions. The toxicities were to the tune of around 37% as compared to 17% in the peripheral lesion. From there, various studies, RTOG 0916, RTOG 0812, many trials took place. There were single arm studies. There was a meta-analysis. There was a systemic review. So the systemic review results showed that SBRT in stage 1 and stage 2 had local control rates to the tune of 85 to 90%, around 91 to 92% in stage 1, and around 85 to 92% in 85 to 90% in stage 2. So all this while, which were the patients who were receiving SBRT? It was the group which was medically inoperable, who had comorbidities, who were older age. So a randomized trial was formulated. Dr. Suresh Senan's group in Europe and the US group. So STARS was the US trial and Roselle was the Amsterdam trial, which was conducted almost around the same time. And they had matched, the patient scores were matched. And unfortunately, although the accrual was supposed to be of around 250 patients in each trial. They could enroll 31 patients and 29 patients in the surgical arm and the radiation arm combined together. So both the trials failed, the STARS failed and the ROSELLE failed. However, a pooled analysis was published in the Lancet Oncology. So what were the findings of the pooled analysis? The surgical arm had 5 deaths out of those 30 odd patients as compared to 1 death in the radiation arm. T1, N0, M0 lesions had equivalent overall survival and progression-free survival. T2, N0, M0s had equivalent overall survival and progression-free survival. And when the analysis was pooled, it was the SBRT arm tend to do better than the surgical arm. It was badly criticized because the median follow-up was only 34 months. All of the 500 patients who were supposed to be accrued, they could publish data of only 60 patients, and surgeons said VAX was never used. So VAX is the way to go in lobectomy, and surgeons were not happy that VAX was not used and conventional techniques were used. I met Professor Sanan also, and we had discussed this trial in detail. So a revised STARS was published with propensity match scores. So revised STARS, all these flaws, all the revised STARS patients had undergone VAX. All of them had undergone the correct doses of SBRT, and it was a propensity matched analysis. And what were the findings? Surgery were equivalent to SBRT, no arm fared superior to each other. Having said that, although there are more takers for SBRT, Sabertooth is a study where it closed because patients' preferences towards SBRT. Sabertooth was a trial which was designed in the UK, and the patient said, no, we do not want to undergo the knife. If there is an option available without undergoing the knife, we want to enroll. So it was a patient preference for which the trial was closed early, Sabertooth. But having said that, let us as radiation oncologists be very clear that the current guidelines say for all medically operable patients, surgery should be offered and not SBRT. Don't pick up all patients who are fit and start offering them SBRT. For medically inoperable patients, comorbid patient, high cardiac risk patient, or patients who have a defined mortality, probability of mortality of more than 1.5%, in a multidisciplinary team, the ASTRO says that SBRT should be given an equivalent option as to surgery. We have had talks about sublobar resections. Sublobar resection is also coming up in a big way, but as I had said from the floor also, we need, to establish equivalence, we need studies. So currently, the equivalence of SBRT to sublobar resection, there are studies which are taking care of that. So what are the ongoing trials? Sabertooth, which has failed. Valor is a study which is undergoing, which is SBRT versus surgery, and it is expected to accrue till 2027. We are going to have some results. I think they have accrued around 150 to 200 patients in Valor. So this is the space of SBRT, and the take-home message from SBRT is early stage T1, T2, N0, M0, certain T3, avoid nodal stations, high dose in the peripheral lesions, moderate to low and more protracted course doses in ultracentral lesions. What about the combination space? This I have talked about only SBRT versus surgery. What about the combination space? The combination space is iSaber. There's a study called iSaber, which is looking into the combination space. So they did a phase 1. Now they have done a phase 2, randomized with nivolumab, that is SBRT alone versus nivolumab and SBRT. And the nivolumab arm did not have, it's a phase 2, did not have more toxicities than the SBRT arm alone. And iSaber non-randomized trial has defined to do SBRT depending on the size and volumes of tumor. So if the size and volumes of tumors are very less, they deliver 25 gray in single fraction. Whereas if the size and volume of the tumors are less, they have divided into 3 groups: newly diagnosed, old cases of primary lung cancer, and the third group is metastasis. So by doing dose defined, volume defined SBRTs, they have found that all the 3 groups have fared reasonably well. That is, all the groups, the outcomes are to the tune of around 90%. In terms of immunotherapy, there is a lot of combination space trials which are going on with Atilo, with nivolumab, and I think we are going to have a lot of data and results coming in the next, say, 5 to 7 years. So this is all the slides that I have talked about all the evidences. So now, just few words, because there are few radiation oncologists, few words about the techniques, and then I will conclude. So this is the eye saver I was talking about. This is our study in 2018. This was the largest clinical data from India. We had published data of around 30 patients, where most of them were primary tumors, few of them were metastatic tumors, and our results was 1 year local control was to the tune of around 85 to 87%. Toxicities were minimal in the primary and the metastatic. Talking about the techniques, you have to, the planning process has to have for patient comfort, reproducibility, and treatment accuracy. Target delineation, you should define the GTV primary in the CT pulmonary windows and soft tissue windows with contrast to avoid inclusion of adjacent vessel and atelectasis. Whenever possible, do a ITV. What is ITV? ITV is internal target volume. How do you contour or draw the ITV? You do a prospective phase-based binning or a retrospective phase-based binning. What is binning? You have a 4D CT where the patient is breathing and you are acquiring the CT scan. Once you have the whole image set, you 10 inspiration, 80 expiration, 20 inspiration, 70 expiration, 30 inspiration, 60 expiration. Like that, you have 9 bins. So that data set of 10 inspiration and 80 expiration, all the images go on to one bin. Then 20, 70 goes on to another bin, 30, 60. And then you reconstruct there is something called a maximum intensity projection. I'll not get into it, but for lung, what you should use is maximum intensity projection, because the value between the surrounding lung and the tumor, there is the contrasting images, where is the contrast part, the contrast between the image set of the surrounding lung and the tumor is very high. In liver, it's the average intensity projection or minimal intensity projection is used. So like after binning, the software, your planning system software, have a way to generate ITV. Ideally, you should see the range of motion to deliver SBRT. SBRT is just not do a CT scan and start delivering your beams, because lung moves, unlike brain. Brain is a fixed linear structure, whereas lung is a mobile structure. So motion management is the key in performing SBRT. Be careful about the proximal bronchial tree. These are all the components which should be used in contouring the proximal bronchial tree. I'm not getting into the details of contouring because that's a class in itself. Next is dose fractionation. The dictum is peripheral lesions which are neither close to the ultracentral structure nor very close to the ribs. You can deliver high doses to the tune of 60 grains, 3 fraction. Some centers are doing 16, 5, and there are some centers in Portugal and all, they have gone up to 32 grains single fraction. For ultracentral tumors, of course, you should protract the course and your dose equivalent should be little lesser to avoid toxicity to your great vessels. This is a document everyone should read, ASTRO-based, evidence-based guideline for SBRT lung. So all these, when to offer SBRT, what is high surgical mortality risk, what is standard operative risk, where surgery only should be offered. They have clarified what should you do in a synchronous primary, what should you do in a metachronous primary. All that has been well defined. This we have talked about. Proton therapy is coming in lung cancer, but again, with proton therapy, motion management is going to be a major key. So we have to be careful about that. So take home messages, SBRT currently is the preferred option for medically inoperable early stage lung cancer. Ongoing trials are evaluating its equivalence in medically operable patients. Studies are evaluating the combination of systemic therapies with SBRT, and these are exciting times ahead for SBRT in early stage lung cancer. Thank you.
Thank you, Dr. Kaustav. You have explained beautifully all the history from the origin of SBRT till the, any questions?
That this beyond this, don't take the patient for SPRT. So what is
So-
that?
Is T1, T2.
Fine.
Okay. In T3, if suppose, I mean, say it's a 6.2 centimeter tumor, well placed peripherally, not very close to the rib, not very close to ultracentral structures, and you have, no other options left for the patient. You think the patient does not have any other normal lung comorbidity, you may decide to take it. But as per definition, T1 and T2, M0, AJCC8.
Thank you. And what will be your margins from like to take CTV from
No
GTV?
CTV.
GTV to PTV?
So
What is the
often
margin?
mistakes that we do is we try to draw CTVs in SBRT. SBRT, as I said, avoid nodal station. So you are only doing the primary tumor. If you have a respiratory management system, if
Right.
you are gating in a particular phase, then your margins will be very tight if you have already drawn an ITV. So in our center, where initially we have done everything. I mean, we have done ANZI-based ITV generation, we have done Calypso-based ITV generation, we have done gating. So if you have already drawn an ITV, our margins was to the tune of 2 to 3 millimeters only. But if you
Okay.
are not drawing an ITV and you are doing deep inspiratory breath hold, I think you should draw around 5 to 6 millimeters. ITV, the generation of PTV depends on your departmental margin. That is based on your Van Hertz and Strum's formula. So you should have a departmental class solution for your PTV.
So is the
Typically around 5 centimeters,
Five-
5 millimeters.
up to 5 is the maximum. So is the patient treated daily or do you have an other regimen also?
Either it should be alternate day or maximum 4 a week.
Okay. And what is the normal constraint that you give to the same ipsilateral lung, the dose constraint that is followed in this?
Data which have decided is V5 more important, V20 more important, or V30 more important. From pneumonitis and long-term fibrosis viewpoint, V20 is your most important parameter, and you have to control your V20. So when you are trying to control your V20, so V20 is your volume receiving 20 gray. V5 is your volume receiving 5 gray. You have to ensure that there is no spillage of V5 into the contralateral lung. That's your first goal, because you don't want to expose both the lungs to pneumonitis. V20 is your hardest endpoint for pneumonitis and fibrosis. So I try to keep the volume receiving 20 gray less than 20% of the ipsilateral lung volume if it is a small tumor. But you can exceed up to 25% if it's a large tumor. And then there are various other parameters of quality assurance. There's something called a T2 centimeters. Dose received that it's not only V20, it is dose received at 2 centimeters, your gradient index. So to decrease your gradient index, what you do is instead of prescribing at 90%, you prescribe at 80%. So suppose you have to prescribe 60 gray in 5 fractions. And your periphery has to receive 60 gray. So when you are doing 60 gray, you decide whether your isocenter will be receiving 90%, whether 60 gray is 90% of the isocentric dose or 60 gray is 80% of the isocentric dose. If your 60 gray is 80% of the isocentric dose, then the gradient fall off into that normal lung will be much lesser.
Thank you, sir.
Thank you, sir. So Dr. Satyankar.
So few of the consultants have to leave early, so there will be no tea break. So tea will be served right here. So before I begin my talk, Rajinder sir, you've been practicing. Rajinder sir, your attention, please. So you've been practicing this respiratory medicine for decades now. So what is your take? What do you think? Lung cancer patient with brain metastasis, what is the average survival? Anyone of you, sir? Anyone? Lung cancer patient with brain metastasis, though asymptomatic. So what is the average survival? What is the, the patients keep asking this question.
Both of us are not indulged into malignancy actively
Yeah.
these days.
Yeah.
Our role is just confined to diagnose and then refer to people like you to take care of the patient. We are not taking a follow-up, but definitely we have an idea that this is having a very poor
Very poor
poor prognosis once the brain metastasis comes into play.
Yeah. That's very
That is
true.
our notion today. Maybe we'll become more wiser after your
That is why this session has been put up. So normally lung cancer with brain metastasis, what the Devita says, it's just about 3 months. So, but yes, as conditions apply, we are talking about ALK mutated non-small cell lung cancer. Okay. So in this subset, the median progression-free survival is close to 4 years now, sir. Without giving chemotherapy, without giving immunotherapy, just with tablets, the patients won't progress for even 4 years. And this is what the data is. So it is so astonishing. So with this, I begin my talk. So this is raising the bar for ALK positive non-small cell lung cancer. ALK is anaplastic lymphoma kinase. So this is the journey timeline of ALK inhibitors. So ALK mutation was diagnosed in 2007, and we developed ALK inhibitor, the first generation ALK inhibitor in 2012. And then second generation ALK inhibitors were developed in 2015, 17, and 18. First, they were approved in second line and third line, but then they were approved in the first line. Until 2019, when Pfizer came up with this third generation ALK TKI, tyrosine kinase inhibitor, lorlatinib. Now, this is US FDA approved in 2021. So there were few unmet needs in ALK positive non-small cell lung cancer. ALK positive non-small cell lung cancer, the incidence is around 4 to 5% patients in the general population. So median age is a little less, 51 years. Mostly patients are non-smokers or light smokers. CNS metastasis, just similar to HER2 positive CA breast, CNS metastasis eventually happen in most of these cases, and around 20 to 40% patients will have brain metastasis upfront, and it portends a poor prognosis. So what were the treatment challenges, even with the availability of second generation TKIs? So ALK resistant mutations, CNS metastasis, durable control of brain metastasis. So these were the problems. So there was a definite unmet need for an additional ALK inhibitor that prevent emergence of resistant subclones in untreated patients. And if it wasn't very hard to choose among the various first generation, second generation, third generations, so we currently look up to progression-free survival, the response rates, the CNS activity, what's available in the second line, and questions like this. So this is the large phase 3 CROWN trial, which supports the use of lorlatinib in the first line of ALK mutated non-small cell lung cancer. So the key eligibility criteria was only stage 3B and 4 patients were included, no prior systemic chemotherapy. Mostly patients of ECOG performance status 0, 1, and even 2 were permitted, and asymptomatic brain metastasis patients were included in the trial. As high as 25% patients had brain metastasis upfront. So they were equally randomized into lorlatinib versus crizotinib, which was the then standard of care, and stratified by the presence of brain metastasis and ethnic origin. The primary endpoint of the trial was progression-free survival, which was blinded independent committee review, and there were key secondary endpoints as well, like PFS, which was investigator assessed, overall response rates, intracranial overall response rates, duration of response, overall survival, safety, and quality of life. So baseline characteristics in both the arms were equally matched. Here, if you can carefully see, ECOG performance status 0 and 1, most of the patients had ECOG performance status 0 and 1. All races were included, slight female preponderance as expected for an ALK mutated patients. Mostly patients were never or previous smokers, very few current smokers, and mostly patients were 3B and 4. So histological types, 94% patients were adenocarcinoma. And most importantly, the brain metastasis, almost 26 or 27% patients in each of the arms had brain metastasis upfront. Now, this is the data. Initially, we had 18 months data, and now we have even 36 months data. So 18 months, if you see the curves, they separate quite early, and the delta is quite significant, wherein there at 18 months, the median PFS was not achieved, not estimable, versus crizotinib just 9 months. So even at 36 months, that is 3 years, the delta is still persistent, and median PFS not estimable versus 9 months, and hazard ratio of 0.27. Now, more importantly, if you see patients with or without the brain metastasis, the patients with baseline brain metastasis, the median PFS not reachable, and with without baseline, even that in that case, median PFS was not estimable, and hazard ratios were 0.21 and 0.29. We need to say that patient, irrespective of the fact whether the patient has brain metastasis or does not have, lorlatinib, acts very well. Meaning basically the reason is that it has 75%, almost 75% of the drug penetration in crossing the blood-brain barrier. Subgroup analysis, if you see all the subgroups were benefited with the lorlatinib arm as compared to the crizotinib arm. Now, although cross trial comparisons are not the usual practice, but this is a slide which would show that lorla versus crizotinib and the as compared to briga versus crizotinib and alectinib versus crizotinib. If you see, the median PFS is not reachable in the lorla arm, whereas it is 24 months and 25 months in the Alta 1L and the Alex study. Now, coming to time to intracranial patients. Now, those patients who do not have baseline metastasis upfront, you see only 7 patients progress. Oh, sorry, 9 patients, they had an event and they progressed. So median time to progression was not reachable. So time to intracranial progression was significantly longer with the lorla arm as compared to the crizotinib arm. Now, what about the patients who did not have brain metastasis upfront? So only 1 patient progressed. So it's the top line is almost flat. So out of 112 patients in the lorla arm, only 1 patient progressed. So if the patient does not have brain metastasis upfront, so look at the benefit we can derive out of this drug. So similar things have been shown in the same slide. So this is the summary of overall intracranial response. The complete IC response, intracranial response, is around 72% with lorla versus just 7% in the crizotinib arm. Now, summary of adverse effects. So no drug comes without adverse effects. So this drug, if you see treatment-related grade 3 to 4 adverse events, there are around 63% in the lorla arm versus 38% in the crizotinib arm. So adverse events are slightly higher, and adverse events leading to dose reduction is 21% versus 14.8%. But adverse event leading to permanent drug discontinuation are lower in the lorlatinib arm versus the crizotinib arm. The main reasons that most of the side effects, adverse events, are grade 1 and grade 2, and almost 52% will settle down without dose interruption. I'll be coming to that slide subsequently. Now, coming to safety profile, in the lorlatinib arm, mostly the metabolic side effects come over. So it's edema, hypercholesterolemia, hypertriglyceridemia, slight diarrhea, less than the crizotinib arm, peripheral neuropathy, and the cognitive side effects. So this, this is a class side effect. The cognitive side effects we'll be discussing in subsequent slides. Now, how to manage hyperlipidemia? So hyperlipidemia can be safely managed just with addition of a simple lipid lowering agent, nothing to panic about. So even if the patient has severe grade 3 adverse event, that is serum cholesterol rising as high as more than 400, we can introduce a lipid lowering agent when we don't need to even interrupt the lorlatinib, we can continue the lorlatinib. Only when it is life-threatening, we can withhold or do some sort of dose reduction by just 25 milligram. Now, this is another part of the same trial, intracranial efficacy, the same data. So now, how to manage the incidence and prevalence of the treatment-related CNS adverse events? If you see on the left side, less than 6 months, 6 to 1 month, 1 to 2 years, and 3 years and beyond, the treatment emergent CNS adverse events, they keep on reducing, and mostly are grade 1. Whereas the prevalence of treatment, they are like that only, but patients do well with the therapy. So no grade 4 CNS adverse events, and incidence of CNS events progressively reduces with time, and predominantly they are grade 1. Now here, without interruption, we can see 59% of the patients, these CNS adverse events can be managed. Only 2 patients had permanent treatment discontinuation because of the emergence of the CNS adverse events. Now coming to dose modifications, again the same CTC adverse event criteria, grade 1, grade 2 or 3. In grade 2 or 3, we have to withhold we should withhold the drug and reduce when it when the adversity reduces to grade 1, and dose reduction of just 25 milligram. Now these are the NCCN guidelines. They all first line preferred therapy, alectinib, brigatinib and lorlatinib, but I would personally prefer lorla. Now this is a network meta-analysis to show the PFS advantage. Here also we can see crizotinib as compared to briga, alectinib and lorlatinib. PFS favors lorla, and that is the key point. Now resistant patterns. So when we analyze these crizotinib resistant specimens versus ceritinib and alectinib resistant specimens, we can see the emergence of compound mutations and the monster mutations like G1202R mutation. Lorlatinib, why it is so efficacious? If you can see the IC50 less than 50 nanomole, so at the standard dose, we can achieve this IC50 less than 50 in most of the mutations, and that is why it is targeting all the mutations. So lorla exhibits broad spectrum activity against most known ALK resistant mutations, including ALK G1202R. Now, another practice by most of the clinicians is that they sequence the drugs. First give crizotinib, then make use of ceritinib or alectinib, and then use lorla. So this slide is basically trying to show that if you use lorla in 2 or more than 2 and then more than 3, the PFS advantage will decline. So again, the sequencing, as more generations of TKIs were sequenced, more monster ALK resistant mutations will be appearing. So what was the rationale of upfront use of this pan inhibitory agent? So this is a pan inhibitory agent. If you culture these F3 cells and you give them treatment with ENU based treatment, these are mutagenic drugs. So mutations will be induced, and then you randomize between lorla and crizotinib. So then we can see with lorla just about 1 to 2 mutations will occur, but with crizotinib you have a whole plethora of mutations. So this is the same. Just one point regarding the variants. So we have EML ALK variants, variant 1, 2, and 3, and P53. So P53 mutated and the variant 3, they are bad, but still in P53 mutated and the variant 3, it is better than alectinib. So this is the final slide. Here we can see these are the various slides, drugs, crizotinib, ceritinib, brigatinib, alectinib. So lorlatinib is running quite fast, and it is the drug which is achieved the highest PFS. And even if now the 4 years data is coming, probably it will be presented this year. So even if we progress on lorlatinib, then we still have the option of chemotherapy, immunotherapy, and radiotherapy, and so many things. So ALK mutated non-small cell lung cancers are living longer and living healthier. Thank you. Thank you so much. Any questions, sir?
Thank you, Dr. Satyankar. Any question in the hall? By this, we end our session on the lung cancer. So thank you, organizers. Thank you, everyone.
I have an important announcement to make. All the faculties who are doing presentations or chairpersons or moderators can collect their mementos from Lajwanti Bhagatnath Radiation of Hope stall, just left hand corner from the main gate.
Ravindra.
Thank you, Dr. Satyankar Gupta. Thank you so much for your words of wisdom. Now I would like to call Dr. Shamim Ahmed to grace the chair. Dr. Shamim Ahmed, please come on the stage. Now we have Dr. Jagdeep Singh from Ludhiana with us. Sir, please.
Good morning, all. So I would like to request Dr. Sandhya, can she chair the session? I think some of the faculty people are there a bit late because of some congestion in the traffic. So thank you, Satyankar, for giving me this opportunity to speak on this topic and your this CRABECON. So not taking much of time, I'll start. So why this third generation EGFR osimertinib should be a treatment of choice in the patient who are advanced NSCLC. So this is the first line treatment for patient who are metastatic NCLC. And this was from the phase 3 trial FLORA, which established that osimertinib is the standard of care in the first line treatment for all these patients. And the overall survival benefit in the FLORA were also statistically significant. If you see on this Kaplan-Meier curve, they are very well separated between the first generation TKI and the osimertinib. And see the table, it clearly shows that osimertinib, the PFS and the OS benefit are statistically significant as compared to the first generation TKI. So why this osimertinib is the first line EGFR in the NCLC? So if you go through this slide, you will see all the first generation, second generation, that is jeftinib, erlotinib, docomatinib, and this afatinib. In all these, the PFS ranges in between 8 to 12 or maximum 14 months. As compared to the comparative arm was, of course, the chemotherapy. So the majority of the patients who were treated with this first generation or second generation TKI, they ultimately progresses and the PFS is close to 18 to 14 months in these patients. So we are just confused what to choose. I mean, shall we choose the first line TKIs or we should choose the second line? Means we are not very sure. And it is always difficult to get in between this. So now comes the answer to this, that when we have this osimertinib, that is a third generation TKI, definitely is the standard of care. And it was compared with the other first generation TKI, that is jeftinib, which showed that with the osimertinib, the PFS was close to 18 to 19 months as compared to jeftinib, which is close to 10 months. So this trial answered that the first generation TKI should be the osimertinib if affordable. So these are the other studies, that is with the afatinib and with the erlotinib and the docomatinib. And this, I'm not going to detail of all these topics. So this clearly states when we use the third generation TKI, that is the osimertinib, is a standard of care and it shows a significant PFS benefit as well as the overall survival benefit. So it showed a better PFS and OS in the advanced metastatic non-NSCLC, the patients who are offered this. So this is the NCCN guidelines, which clearly states the patient with EGFR mutation, that is del19 or L858R, the first line preferred drug is the osimertinib. Other drugs recommended can be either afatinib, docomatinib, or can be the jeftinib or erlotinib. Similarly, the ASCO guidelines, they also state the patient with the stage 4 NCLC means having this sensitive mutation, that is either del19 or this L858R mutations. So the strong evidence of the osimertinib which maintains a strong recommendation as the first line setting. So as compared to the other drugs, which are the moderate recommendations in front of the osimertinib. Similarly, the ASMO guidelines, later they also point that osimertinib should be the standard of care in the patients who are having this metastatic NCLC as standard of care in these patients. So this is what we have to choose the best when we have all the drugs with us, rather than going for the other, which we are still confused, which is a better PFS. And why this osimertinib will work in this real world setting. So there are a lot of data to support all this. So there are some trials, that is Flower, that was an observational trial, but it was a prospective trial, which showed that PFS was approximately 18.9 months. And again, TDT, that time to treatment default was approximately 25.3 months. And again, time to failure was again in OSI factors close to 19 months. So all these data, these were in the real world data, this showed some were the retrospective, other were the prospective observation studies, that the osimertinib is the standard of care in the patient with the metastatic NCLC with EGFR mutations. So this showed a similar outcome in a real world studies in older patients who are having a poor PS and having a brain metastasis. So this becomes a drug of choice in these patients. So the next very important question is the patient who are a metastatic NCLC, they are going to have this brain metastasis. Approximately 30 to 40% of the patient, they will be having brain metastasis in future. So how this osimertinib will be a better choice in these patients? So it was seen that EQ5D score, which was basically based on the scoring on the metastasis, the patient with the lung cancer, it was showing the patient who had an adrenal metastasis, they do better as compared to the patient who had a brain mass. Similarly, if you see with the liver or the contralateral lung or the bone, they are all fairly do better as compared to the brain mets. So patient with a single brain metastatic site, they experience the greatest decline in the quality of life compared to the patient who are having other sites of metastasis. So these are pictures which are showing that the brain penetration of the osimertinib in the preclinical trials. So this led to that patient who have either stable CNS metastasis, they can be a better option for those. This can be a better option in those patients. So brain penetration was a better observed with the osimertinib as compared to the other first generation or second generation TKI. And this had a good brain penetration in a human study, and the concentration increased over the further future days when we have given the drugs. This is the CNS analysis in the Flora trial. And if you see all the patients who were, there were approximately 128 patients who had this brain metastasis, and close 60% patients received the osimertinib, and 67 patients were in the comparative arm. So all the characteristic features of the patient were well matched, and it showed the patient with known or treated CNS metastasis who received osimertinib, they do a better PFS as compared to the patient who are receiving the comparative EGFR. And if you see the PFS is approximately 15.2 months versus 9.6 months with a hazard ratio of 0.47. So in the same way, without known or treated CNS metastasis, again, the osimertinib did a better job as compared to the other first line or second line generation. Similarly, in this, the hazard ratio was 0.46. So this CNS events occurred in approximately 8% of the patient who received this osimertinib as compared to the 15% patient who received this comparative EGFR TKI. So the patient who received this osimertinib had a fewer CNS progression. So if you see in this chart, the patient who received osimertinib close to that, in this approximately 20% of patients had CNS progression other than the death, while in the EGFR, that is first line or second line, it is approximately double, that is 39%. Similarly, the progression due to a newer CNS lesion is approximately 12% in the patient with the osimertinib, which is just even less than of that with the EGFR TKI comparator arm, that is 30%. So fewer patients experience CNS progression who receive this osimertinib as a first-line drug, and fewer patients progress due to this new CNS lesions with osimertinib treatment compared with the EGFR comparative arm. So if you see this graph, the patient who received osimertinib, in 22 patients, approximately 5 patients had a complete response, while 15 had a stable disease, and just 1 patient had a progression in this. If you see the other in the patient who are receiving the first or second generation EGF comparator arm, so none have the complete response in those patients. And the median best change percentage from the baseline in serious target lesion with the patient receiving osimertinib is, you can see it is close to -64% as compared to -45% patient who are receiving the first or second generation TKI. So it says that a majority of patients on osimertinib had a partial response along with complete response in a few patients who are receiving this osimertinib. So why patients receiving osimertinib will have better quality of life as compared to the other TKIs? So basically, there was some changes from baseline in global health and functioning course of that time, either in the first generation or second generation or in the third generation. But if you see the patient who received this osimertinib, the emotional functioning and the social functioning, they did a better as compared to the EGF comparator arms. So this improvement in this emotional and the social functioning were significantly greater in these patients who were receiving this osimertinib as compared to the first or second generation. But the cognitive function remained stable with osimertinib, but deteriorated in the patient who are receiving either the other EGF or TKI comparative arm. So there is an improvement in the quality of life, improvement in the symptoms, the patient who are having either presenting with a cough dyspnea. So either of the EGF or either first generation or second generation, but it is better with the patient who are receiving the osimertinib. So if you see in all these trial, Flora, Lux, Lung, Archer trial, the patient who received this osimertinib, which is just it's a cross trial comparison. If you see the patient who received this osimertinib, there were less side effects as compared to the patient who receiving the afatinib or dacomitinib. This I cannot compare, but still, whatever the evidence or data available with us, you can see the patient receiving osimertinib had less of rash or paronychia or stomatitis, or they further even regarded less dose reduction as compared to the patient who are either in the dacomitinib or in the afatinib. So this osimertinib should be preferred upfront therapy over the sequential, or shall we go to the first generation, then to this second or third generation? So if you see in this is just a comparison in a patient who see the osimertinib, the first line drug. So PFS is close to 19-20 months. The patient received the first generation TKI. It is approximately the PFS is close to 8 to 12 months. Then the patient further goes to third generation TKI, that EGF TKI, that is osimertinib. The next PFS is again 10 months. So if you see overall, the patient who are receiving either single agent osimertinib at the upfront or first line EGF TKI followed by this osimertinib. So approximately the patient who had this first line, they did better as compared to the sequential therapy. Similarly, in the overall survival, the patient who are receiving this either first generation or second generation TKI and then followed by this osimertinib. So in those also, the patient who received the single first agent, this osimertinib, they did a better as compared to this EGF TKI first generation. And the overall survival is close to 34 to 36 months in those patients. So whether we require only single agent osimertinib or we require any combination, because there was some data which showed that jeftinib when compared with the chemotherapy did a better as compared to a single jeftinib. So PFS was better in those arms who were received jeftinib along with the chemotherapy, but of course it is associated the more grade 4 or 3 or 4 toxicities. Similarly, the patient who received the ramucirumab along with the erlotinib or erlotinib with the bevacizumab, the PFS was some better, but it was always associated more toxicities. But if you see the osimertinib, the patient who received this a single agent drug in the first line setting, the PFS did a fairly better with a good overall survival benefit, and with the grade 4, 3 or 4 toxicity are very less as compared to the patient who are getting either combination of these TKIs with the drugs. So this combination increases the PFS, but at the cost of toxicities, and these may require more of hospital visits, and they may decrease the compliance of the patient who are receiving this combination. So osimertinib should be a drug of choice in metastatic NSCLC having the EGFR mutation. Upfront provides us possibility of overall survival benefit close to 36 to 38 months in all the patients comparatively with a few adverse events. And approximately 7 by 10 patients get tested for the second line treatment option, because in those close to 30% did not see a second line treatment. And the T790 mutation positivity in second line is only seen in 40 to 50%, because some patients prefer not to go for the rebiopsy. And the yield of this liquid tumor testing, if you do, it's close to less than 20%, 20-30% as compared to the biopsy. So this osimertinib has shown a better efficacy in brain metastasis as well as delays the CNS progression. So I think this is a very old topic which I covered Because now we are moving into the adjuvant setting of the osimertinib, the patients, rather than just talking of the metastatic settings. And the overall survival benefit, that is the latest, this results has been matured in the ADORA trial, which has shown that it's close to 85 to 88% patient who receiving this osimertinib in even in the stage 1B, who were having poor high risk features. So maybe it's time to wake up and to see for the next line. We just discussed in the previous discussion that it should be tested in the patients in stage 2 to stage 3A, 1B if having the poor feature high risk features. Thanks for your patience.
Benefit with CNS metastasis, brain metastasis. Did your results show any difference in the patients with single or multiple metastasis? Was there any difference in progression or response?
Metastasis, a metastatic usually at the baseline when we have a MTD discussions, means we tend to go for some sort of radiation therapy or that. But if you take into account either LIGO or multiple sites, osimertinib will have a better edge on those patients.
So how do you schedule with the radiation therapy if whatever it is required?
Not going to give any difference. Like usually when we give a chemotherapy, we don't give a radiotherapy along with that, but osimertinib can be given to the patient who are receiving radiotherapy. So presently, I had a patient who received alectinib. So she had a multiple. She basically presented with the altered sensorium, and we gave radiation therapy. And along with that, started with alectinib, and now she has a performance status ECOG 1. So it can be scheduled. There is no such contraindication of not giving this osimertinib in the patient who is receiving radiation.
Thank you. Any questions from the house? Please?
Yeah. Thanks, Dr. Jaddeep, first for coming and delivering such a nice talk. So I have just two questions for you. One, with this current NGS testing, we are currently seeing double mutations. Just last week, I had a patient who was EGFR mutated, this exon 19 deletion, plus he had TP53 mutation. So is in
so data is very sparse. It's scare how to decide what to do. But definitely when you have some targeted mutation, you have to target. I have seen a patient with the ALK positivity and EGFR 18 positive.
18. Okay.
EGFR 18 positive, 18 mutation. So in that patient, I have given certinib. I remember the patient is approximately PFS close to 2.5 years. So for the things which we don't have any target, and we know that they are going to tend to behave poor, we don't have a data. It is just an extrapolation from the some anecdotal studies or case reports you can do. But when I will choose, I will choose if some targeted therapy is available.
And what about role of osimertinib in some rare mutations?
To the T53 thing. Hi. To the question of T53, the only thing that will happen is it is a poor prognostic marker and patient more likely fail the targeted therapy. So you won't change anything. You'll still give a TKI, but the chances of that corresponding to someone who does not have a T53 will be bad. So that is the only thing. You don't change. But if you have a complex mutation, a compound mutation like a ALK or EGFR, let's say, that's more pertinent now, then there is nothing as a standard of care. People follow it sequentially. Some give EGFR, see the response, some then follow it up with progression ALK inhibitor, or go otherwise, or some combine both the things. But what we do normally is we look at the allele frequency. Whichever is the higher allele frequency, I'll target that first. If it does not work, change it. So that is not a standard. But for your case, the target is the EGFR, but a T53 coming up is showing that the patient is not likely to respond very well. That you can discuss with the patient when you start. That's the only thing.
I've seen prescriptions from TMH with this EGFR mutated patients. They combine chemotherapy with the Jeftinib or.
He's speaking on a sponsored talk, so he has his own compulsions. So I don't have. So
some compound mutations are.
No. He is speaking of why in TMH people are still giving chemotherapy with Jeftinib for EGFR positive patient. That's his question.
At that time maybe, I don't
No,
know.
I'll tell. To be fact.
Osimertinib.
No, he showed it in his slides. I think he was so much focused on osimertinib, we missed that. We have a very good data, at least 3 data is coming up. One from TMH, they have presented it in JCO. One from China, one from, if I'm not wrong, Japan. So both the 3 data have shown that in a first generation TKI, like gefitinib, it is not good enough. You need some muscle to it. Chemotherapy, when you add to gefitinib, is superior to gefitinib. And all the 3 trials have shown that. So in today's era, if anyone practices chemotherapy and has a EGFR positive, gefitinib alone is not a standard of care. It is option, but not a standard of care. If you're using a first generation or second generation TKI, mainly first generation, add chemotherapy to it. And that is pemetrexed cisplatin, and that is proven 3 trials that it has a survival benefit over gefitinib. Osimertinib contrast is a TKI versus TKI, third generation versus the first generation, and it has shown a OS benefit. But osimertinib, only Astra is available. It's a costly drug. And what can people afford it? So if they cannot, instead of giving gefitinib, add chemo to gefitinib, stop chemo at 4 cycles, give pemetrexed maintenance, and continue with the gefitinib till progression. Side effects, to be fair,
They're really high on those patient getting.
I again disagree. I do quite a bit of the combination. These, if you look at it, there are side effects. You would not give to a performance 3 patient, as you told, a sick patient, bedridden, you won't give a chemotherapy gefitinib. Osimertinib can be given. But if you give it to a PS1/2 patient, I don't think less than 5% will not be able to tolerate. 90-95% will tolerate, do very nicely, and have a very good response. So it's a doable thing. Paper toxicities are there, but it is not that you cannot do it. It is same as chemotherapy. Just look at some skin toxicity and some lung toxicity. That's it. Gefitinib does not give anything.
So one thing more that that would none of the patient on this osimertinib required any dose reduction. So doing pretty well. So miss even you even need not to stop also if you require. That's why. So that's a very good drug deal, I think. The only thing is the financial toxicity is one of the main things when you are planning. The number of patients are very few, maybe 6, 7, which I'm treating at present, honestly. So, but this is what data is.
Thank you. Thank you.
Sir, Satendra sir is.
So regarding dose reduction, I think one of my patient was not able to tolerate. She was a young lady, 30, 32, brain metastasis, and she's surviving till now for 3 years on osimertinib. But with 1 tablet on day and 2 days off. 2 days off because of severe rash all over body. So she was not tolerating one. I don't know about the particular trial. What was the lowest dose? I don't know.
That's why I said.
As Dr. Saud told, most of the patient do tolerate, but but I have seen one patient really intolerable.
I did not uncover this, honestly.
So this is prescribe those what you're telling, but we have patients who do it. But I had a patient who actually has a possible Steven Johnson with osimertinib. So that cases will happen, but very rare. It's very, very rare. So only take home messages whenever you give any drug, you should be careful for the rare and very rare side effects.
So
But it is,
if that dose or
but osimertinib, all to fairness, is a beautifully tolerated drug. That's.
Thank you.
Thank you all. I think that was a wonderful interactive session. So in the end, I would say that yes, progression-free survival is one thing, toxicity, but we should not miss the financial issue when using these latest molecules. That is one of the very important as well. Thank you so much. Thank you, Dr. Jagdeep.
Thank you, sir. Now I would like to call Dr. Danny Gupta on stage to grace the chair. Thank you, sir. I would like to invite Dr. Rajat Rathan from Chandigarh on stage to share their thoughts.
Greetings, everybody. It's good to be back to Jammu. It's the place where I started my MBBS. And thank you so much, Dr. Satyankar. You're somebody we studying in Udhampur always looked up to. You, Dr. Priyankar, Dr. Agni. So I've been asked to debate in favor of the use of neoadjuvant chemoimmunotherapy followed by surgery. And it's a difficult job because I have to sort of dethrone an established modality of treatment, which is concurrent chemoradiation followed by durvalumab in stage 3 carcinoma lung. So let me try my best, but it's a difficult question to answer. I must start with saying that because we don't have a direct head-to-head comparison, and I don't think it is possible to actually have a direct head-to-head comparison between the two modalities. Chemoimmunotherapy as a neoadjuvant in lung is a relatively new concept, but having said that, neoadjuvant chemotherapy has been tried in stage 3A lung cancer with variable results. Stage 3A lung cancer is also a heterogeneous group of disease. You have various T stages and various N stages. So it is difficult to sort of club everything into stage 3A and define the results. And not all patients in stage 3A are eligible for the desired modalities. We know patients are not fit for sometimes surgery, sometimes concurrent chemoradiation and all that. But let's try and break the answer into different groups. Let's see what the efficacy, the results of the efficacy of the neoadjuvant chemoimmunotherapy are. Let's see what the efficacy of the established concurrent chemotherapy followed by immunotherapy is. And let's also look at the toxicity and the tolerability profile. Let's look at what the data says. This is the major trial that actually got everyone in the medical oncology community excited. It was the use of nivolumab plus chemotherapy, and it was compared with chemotherapy followed by definitive surgery in patients with resectable non-small cell lung cancers. So it's a 3-year update that has been presented recently, the Checkmate 816 trial. It was a phase 3 trial and had a very select eligibility criteria, ECOG performance 0 to 1 with a resectable stage 1B to 3A non-small cell lung cancers, of course, with no EGFR ALK mutations. Patients were divided into chemoimmunotherapy with nivolumab and the conventional chemotherapy versus chemotherapy alone, followed by surgery and optional adjuvant chemotherapy or radiation. Primary endpoints were the PCR and EFS rates. There were secondary endpoints like time to distant metastasis and overall survival. And around 180 patients were there in both the arms, and about 149 from the chemoimmunotherapy underwent surgery, which was a little higher as compared to chemotherapy, which was 135. Some of them did not undergo surgery. In the chemoimmunotherapy arm, it was 30, and in the chemo arm, it was slightly higher, 40. But all these characters were well stratified between the groups. And coming directly to the result, the event-free survival, as you can see in the graph, the chemoimmunotherapy did got us all excited because even after a median follow-up of around 41 months, we still did not have a median EFS in the chemoimmuno arm. However, in the chemotherapy arm, we did have a median EFS of around 31 months. Time to disease, time to distant metastasis is another important feature that is considered in carcinoma breast. We know that post-surgery, the most important cause of mortality is the metastasis. Even this time to distant metastasis was lesser with Nivo plus chemo arm as compared to chemo. Nivo scored higher in terms of in other patients also who did not undergo surgery, who could not undergo surgery because of various reasons. And just to reiterate how many patients did not undergo surgery in the neoadjuvant group, it is always an important question that we have to answer. So the tune is about 5% of the patients in the chemoimmunotherapy arm did not undergo surgery because of disease progression, which is very well within the limits that we see in carcinoma breast, in carcinoma urinary bladder, or other areas where we use neoadjuvant approaches. So nothing out of the ordinary was seen. And coming to another important analysis, which was the safety data. whether giving chemoimmunotherapy did impact our surgeries or did impact our adverse effects. So this table very beautifully explains that even in those patients who underwent the doublet therapy with nivolumab did not have an increase in the surgical related adverse effects, which was initially presumed because the phase 2 part of the Nadeem trial did show us some increase in the surgical morbidity, but it was reassuring to see that giving chemoimmunotherapy did not have any adverse effects out of the ordinary, and surgery post chemoimmunotherapy was feasible and done in majority of the patients. There are other trials also in the chemoimmunotherapy space. Most of them in this table are the phase 2 trials. What is essentially important to understand is that not only is there a benefit in survival or its various other surrogate markers, you now have a sort of a position where you can identify patients who have a complete pathological response. Something which was a little unheard in carcinoma lung, something which sort of gives us vibes of carcinoma breast. In carcinoma breast, we also talk about pathological complete response to the tune of around 50–60%. And now with the use of chemoimmunotherapy, we are looking at pathological complete responses to the tune of somewhere around 50–60%, which was unheard. And just last trial in this regard was the perioperative use of pembrolizumab in early stage lung cancer. It also did show a good event-free survival. Why I have this trial in my slide is because we also have an overall survival advantage, which was not seen in the previous trial because it was not mature. We know that giving pembrolizumab before and after surgery does lead to an increase in the OS. Again, with the use of pembrolizumab, there weren't adverse effects which are out of the ordinary. All were manageable. An important question that needs an answer is whether there are any problems doing surgery post neoadjuvant chemo approach. There was this trial by from China published in the Frontiers of Oncology in 2022, which very beautifully explained that even doing a radio-assisted thoracoscopic surgery or a VATS post neoadjuvant chemoimmunotherapy had a very good quality of life and post-surgery morbidity rates and mortality rates, which were comparable to what we see in upfront settings. A length of stay of around 6 days post-surgery is something that we all aspire to get in our clinics as well. So conclusion of neoadjuvant immunotherapy, the data, yes, it's a little early. There are no direct comparisons, but we do have high pathological complete response rates, better EFS, better OS. The regimes are well tolerated with no new safety signals. And surgery post chemoimmunotherapy shows no increase in complications. But what about the other aspect? We still have concurrent chemoradiation followed by durvalumab. What is the evidence? We all know the Pacific trial published in NEJM in 2017. Majority of the patients here were stage 3A. Yes, there was progression-free survival.
Dr. Rajit, you have 2 minutes to go. Sorry to interrupt.
We do have a PFS-OS advantage, but why surgical approach may be better is surgery always remains a more pragmatic approach in terms of it gives you a more accurate histopathological assessment. It confirms your stage. Surgery is usually a definitive treatment and there is less use of any adjuvant therapies and lesser time in the treatment modalities. Giving neoadjuvant chemoimmunotherapy does also have a benefit in understanding the in vivo chemoimmunosensitivity, and future risk assessments can be done in this regard. Although it should not be done, we still tend to do cross-trial comparisons in our clinic, which seems to actually favor the neoadjuvant followed by a surgery arm, and EFS not reaching even after a median EFS not reaching even after 54 months of chemoimmuno arm was something which was not seen initially. It's something which we should keep in mind. And just the last few slides about pathological complete response. It could be a new biomarker. Patients who have a complete pathological response or even a major pathological response tend to do well. And as you can see in this graph, a 90% event-free survival in patients who have a complete pathological response post pembrolizumab even after 54 months, gives you good, sort of exciting results. In comparison, Pacific trial did not have so many complete responses, and there were few toxicity concerns as well. And also the question of whether the concurrent chemo radiation may not be an ideal treatment for all the patients in stage 3. Some of this times we have to go for sequential approaches, and we don't know whether this is helpful in our patients or not. Just to conclude, neoadjuvant chemoimmunotherapy followed by surgery seems to have a good EFS benefit, a good benefit in terms of time to progression. OS survival benefit is seen in keynote trial. It did not impact the feasibility of surgery. But it goes without saying that before understanding the need for neoadjuvant chemotherapy and surgery, we need good established surgery units with good infrastructure, good manpower. And it's a team effort. Surgeries are not easy. There are a lot of rehabilitation procedures. Therapists are involved, pulmonologists are involved. Something that we need to get before we actually make that jump from concurrent chemo radiation to sequences. Thank you.
So question answers we can take later on. We call the next speaker.
Since it's a debate, so question and answer afterwards. Now I invite firebrand radiation oncologist Pooja Nandwani Patel to counter Dr. Rajit.
Good afternoon, one and all.
10 minutes.
At the outset, first of all, I would like to thank Dr. Deepak and the entire organizing team for inviting me here today. I am going to speak against the motion. Can I have a pointer?
Dr. Pooja, welcome. So the time is 10 minutes for the debate.
So we radiation oncologists always stand very timidly in front of the medical oncologist, and especially someone like Dr. Rajit, where he himself is not just a medical oncologist, but also a radiation oncologist. So with 2 degrees, he's saying he's more powerful. So yes, of course he is, but I would say he is very humble and polite. When I said, Rajit, let's have a talk, he very gracefully agreed. So let us now understand what we are going to debate upon today. So the sentence given to us has 2 basic components. The first is the group we are talking about, the stage 3. So it is a group which comprises of 15% of the tumors. It's a very heterogeneous group. He very politely agreed on the very first slide also. That's a very heterogeneous group. It's not just the T1, T2, N2, but also T4, N0, N1, and T3, N1. And the second very important part is the neoadjuvant CT. So somewhere we are trying to facilitate surgery. So when we are thinking about doing a surgery, the second question or the very immediate question comes to our mind is how many of these patients are operable? Because if you see this group, it's a heterogeneous group. Let's understand one by one. Now my friend has left radiation oncology. So his Bhagavad Gita has changed from the Perez to Devita and NCCN. So I will give him some references of the NCCN for a better understanding. The NCCN says the role of surgery in this subgroup of N2s is controversial. There are 2 randomized trials, one in the National Cancer Institute. Both say that there is no overall survival benefit in the use of surgery, especially in the N2s I'm talking about. However, it's a heterogeneous group, and the panel do believe that these trials have some nuances present, and there can be some subgroup into these N2s also who can be likely benefit from surgery. So if you see the NCCN very clearly shows for the N2, it's a category 1 recommendation, definitive CTRT followed by durvalumab. So there is no question about it. Now the other subgroup is the T4, N0, N1. So what is this T4? It is not just dangerous in the terms of size, but also dangerous in the terms of the critical structures it involves. Right from mediastinum, heart, blood vessels, trachea, recurrent laryngeal nerve, esophagus, vertebral body, carina, separate tumor nodule in an ipsilateral lobe. So what the question I'm trying to put here is, how much confident or convenient or easy for the surgeon is to operate these type of tumors. So probably the answer would be a MDT for such clinical situations. So then probably we are left out only with the last small subgroup of T3 and 1. Now, if I see the NCCN, it also says that for the stage 3 T4 N0N1, it is only for the operable where you can give the option of surgery, but for the otherwise inoperable, definitely it is again definitive CTRT followed by durvalumab.
Just a breast board नहीं होता तुम्हारा.
And only in the small segment of T3 N0N1 where we can say that neoadjuvant definitely has a role to play. So now again coming back to the NCCN more in detail, when I said that N2 the role is controversial, but I want to say that yes, there can be some specific N2 which can be definitely taken for the surgery and of course followed by the pre-op CT. So why? So in that case, MDT is very important because we have enough evidence to know that whatever review, MDT decisions have been taken, they really improve the quality of life, survival, and the quality of care for these type of patients. But at the same time, we should understand that the presence of the N2 lymph node substantially increases the likelihood of positive N3, number one. Number two, when you're trying to operate this N2, you have to be pretty much sure, and that is why pathological evaluation of the mediastinum is must, and that is why medianoscopy has to be done. Being an invasive procedure, now there is a trend of getting for non-invasive procedures like an EBUS or a EUS. But at the same time, it is difficult to do a repeat also. So most of the times what happens is people do a EBUS or a EUS at the first onset. And then after giving neoadjuvant CT, they reserve the medianoscopy for the second one. But when I talk about all these fancy EBUS and EUS, that means definitely we are talking about a center which is highly equipped and higher expertise is required. A very interesting, Dr. Rajat, if you see, there was a questionnaire being given to the NCCN members and they had to answer some questions, and what the conclusions were that all NCCN members, they agreed together that they will be selecting only selective N2 group of patients, that is single station, non-bulky N2 for giving this neoadjuvant for CT followed by surgery option. Majority of the NCCN believe that yes, we have to do EBUS for initial mediastinum staging, reserving the medianoscopy for possible restaging. 2/3 of the NCCN members agreed to give induction chemotherapy, but 1/3 also give chemo radiation. I will talk about the chemo radiation also. But what important to see is approximately 3/4 also give adjuvant radiation for the positive residual N2, and even 1/4 would like to give radiation even when it is an N2 pathological complete response. So friends, it means it's an overtreatment. We give neoadjuvant CT, we do surgery, and then give radiation also. My friend primarily was a radiation oncologist and he was really very intelligent. That's why he went to the DM also. But I am sure he would have read the Perez also, where they were very important two trials, the SWOG study and the German lung cancer cooperative group study, which clearly said that there is no role of pre-op CTRT. Why? Because in the SWOG, the first initial study, which started with 100+ patients, of course, the results were very promising with a 3-year survival of 26%, which led to the further intergroup randomized phase 3 study. But the most important thing was the significant toxicity of the right-sided pneumonectomy after induction chemoradiation therapy, and that is why the role remains unclear. Even the German lung cancer cooperative group with 500+ patients said that there is no PFS benefit, and the pneumonectomy of the CTRT is higher mortality rate than the CT. Now, I know when we are talking about so much about the neoadjuvant CT, what is wrong with CTRT, especially when my friend himself showed that the game has changed with the role of immunotherapy come into practice. Especially when we talk about these stage 3 tumors, radiation chemo followed by durvalumab has really very good results. This is a very good paper published in the NGM, and where if you see the results, they have tremendously increased with the median progression-free survival rate increasing from 5.6 months to 16.8 months. The 12-month progression-free survival rate increasing from 35% to 55%, the 18-month progression increasing from 27 to 44%, and the response rate also being higher from 16 to 28.4%. Even if you see the median time to death or distant metastasis was longer with the durvalumab as compared to the placebo, that is 14.6 months to 23.2 months. My friend very excitedly said, Dr. Pooja, it is not just the CTRT followed by durvalumab, even there's a role of nivolumab or these immunotherapy in the pre-op setting, which he was trying to show. Because now we know that it is mandatory to have this PDL1 EGFR ALK rearrangement testing right from day one. And there's really exciting time ahead when we are trying to use the immunotherapy in the pre-op setting also. And he showed this paper very well, which was published in the New England Journal of Medicine. It was a phase 3 trial with stage 1B to 3A patients where the nivolumab plus platinum-based chemotherapy or the platinum-based chemotherapy was being compared. What was to be studied was the event-free survival and the pathological complete response. It did show that, yes, the pathological complete response was very good, 24%, as compared to only 2.2%. And even the grade 3 and 4 events, which he said they are not very much high. So yes, definitely nivolumab or these immunotherapies in the pre-op setting definitely has a role to play. But my dear friend, this paper had stage 1B to 3A. So it's a very different group we are talking. We are not talking just about stage 3. But I do agree humbly with him that yes, we are moving to an era of paradigm shift, where initially in the past, we were just giving the neoadjuvant chemotherapy or the neoadjuvant chemoradiation, where we are looking to the future, where we are having the possibilities of neoadjuvant immunotherapy, neoadjuvant immunoradiation therapy, or neoadjuvant chemoimmunoradiotherapy. And today at the present, we both are debating, though we both are being a very good friends and colleagues. But I would say, yes, change is very important. And that is what Charles Darwin also said. It is not the strongest of the species that survive, not the most intelligent, but the one who is most responsive to change. But as I mentioned from on the day one, or from the day's first slide also, he's a very humble colleague. I don't think he will mind when I say that, of course, proper selection of patients is important. MDT is the key so that we have better defined treatments and better results and quality of life. And I think he would peacefully agree with me to say that not the neoadjuvant CT, rather, he would say neoadjuvant CT and CTRT, they both are equally good options. Only the decision should come patient to patient, expertise to expertise, center to center. That is all I want to say. Thank you all for your patient hearing.
Thank you, Dr. Pooja. That was a wonderful debate with both of them.
Dr. Ajit, if you want to counter,
Okay.
you have 2 minutes. Very well put by my colleague there. Yes, I think the initial slides about NCCN trying to tell us that concurrent chemoradiation is the modality of choice in stage 3A. There is no denying that, but I think that space is now being eroded, and that's why we're having this debate, because the consensus is something else, and now we have certain data which tells us that, hang on a second, we can actually give these patients neoadjuvant chemotherapy followed by surgery and have exciting results. So yes, NCCN does say it, but that doesn't mean that it cannot be changed. Number one. Number two is very well sort of addressed the issue of concurrent chemoradiation followed by nivolumab being sort of having a better results than the conventional CTRT regimes. A couple of important points I would like to make here is that, number one, in our practice, we often have situations where we don't use concurrent chemoradiation, and we sometimes use them sequentially, because giving concurrent chemoradiation, cisplatin, etoposide, or even whatever regimes you want to choose, has its own side effects as well. And we don't know whether giving sequential chemoradiation followed by durvalumab actually has a benefit or not. Nobody has sort of told us that as yet. Number three is that, yes, initially chemotherapy followed by surgery did not have the desired impact. There were few set of patients who actually used to do well, but if you take in terms of intention to treat population, the results were not that exciting. That's why we had to sort of give this space to concurrent chemoradiation. But now the fact that we have higher response rates, higher PCR values, and higher number of patients who actually do well on the neoadjuvant therapies, surgery for those who are operable, I think, is something that we should now be considering more often than just starting the patients on concurrent chemoradiation. Just purely on the basis that we now have more sort of response rates as we had with just chemotherapy. But wonderful presentation. I agree with you. Till now, CTRT, I may also sort of lean towards CTRT. I think the times sort of changing.
So, Dr. Ajit, we agree that CT followed by NACTRT is a standard of care for such patients. But with the changing trend, of course, the treatment changes. But there, I would like to know, what are those few subset of patients whom you think are the perfect candidate to be enrolled with NACI followed by surgery? And what is your criteria for like response assessment that the patients are fit for surgery?
I think if you specifically ask in terms of those with stage 3A, I'll just stick to that group of population. I think we don't have a real biomarker in terms of what tells us that which patient will respond well
to the chemoimmunotherapy or not. The only thing that I can say is that those with EGFR ALK mutation positive will not be obviously getting the neoadjuvant approach. But PDL1 negative, PDL1 less than 1%, more than 50%, it actually, in these trials, it hasn't shown that much difference. So I think, yes, you can actually have a talk with the patient that here is this approach. I want to give you neoadjuvant chemoimmunotherapy, but it's a decision that I cannot take by myself only. I have to sort of involve the whole team. My surgeon has to sort of comply. The patient has to agree. There have to be certain factors which you take into account. I don't know whether nodal burden might actually be of any value in that, because now that the response rates are pretty high. And I'll tell you one very peculiar thing about the use of neoadjuvant chemoimmunotherapy approaches is that even sometimes when a PET scan shows that post the neoadjuvant chemoimmunotherapy, there is a progression. There have been certain instances where surgery in those patients have actually led to us to see actually that they were actually complete pathological responses. So PET may not be an ideal way to sort of tell you that, look, this has responded to chemoimmunotherapy or not. So it's a space where a lot of research still has to go, and we still have to sort of sit and decide and make a consensus.
Dr. TP, sir.
Yeah, for the debate, to be fair, all fairness, we have to step back, go one step back. The inclusion criteria for both the patient groups are different. So first thing is 3A, what I feel is the role of neoadjuvant chemoimmunotherapy only comes in when the multidisciplinary team tells that the surgeon feels it's operable. So the subset is different. So we are talking and comparing lemons with oranges here. So these two subsets, like for the Pacific, very clearly they were 50% were 3A in Pacific, and those 50% were considered inoperable in the multidisciplinary meet. So I would not consider a neoadjuvant chemoimmunotherapy for someone in a multidisciplinary team if my surgeon there tells it is not operable per se. So the intent in these trials for neoadjuvant chemoimmunotherapy was never to make an inoperable operable, but only to increase the PATH-CRs so that we could get the survival benefit. So that was the intent, because these were all operable cancers. So it was not that the surgeon could not go in and not operate. So I think the inclusion criteria is too different, and that is actually no debate, because a patient who is operable per se in a multidisciplinary team does not go into Pacific. It has to go for a neoadjuvant chemoimmunotherapy, and then only the patient should be intended for it. And why? Because the Checkmate 816, which you quoted, is a beautiful trial, 2 to 3 cycles of Nivo plus chemo, and the PATH-CR rates increases by around 25 to 30% in that trial. And if you look at Nadeem too, it is 70 odd percent PATH-CR, and PATH-CR does have a survival benefit. So basically I spend approximately 3-4 lakhs for a sure shot 1/3 patient going into a PATH-CR. I'll take it any day, although it's still not a standard of care. For the Pacific, yes, you cannot give a EGFR positive or ALK positive, even a Durva in the Pacific. The patients did not do well. So these patients never do well with immunotherapy. That's all said and done. So that was my small point which I want to make. There's no debate at all. We are now comparing lemons with oranges. Pacific has its position, and it has actually consolidated the benefit. The graphs are separating very, very nicely after 4-5 years now, 6 years now. And Checkmate 816 is a different trial, 1B, 2, 3A. And if you look at AGN, which is the Durva, again, it is also included some N2s, quite a big of 25% N2s. So I disagree purely on madam with that part, that in India, we might not have the centers who routinely do N2, but the centers are increasing day by day. I think we need to look at N2s differently now. Single station N2, multiple station N2s. It is a surgeon domain to tell it's operable or not. That's my small take on this whole.
Thank you, Dr. Sam.
Similar is the take with me. I'm a thoracic surgeon. So let the resectability be decided by the thoracic surgeon first. Whether he will be able to take out that lesion purely, surely. And the other thing is, with advent of minimally invasive surgery, the whole thing has shifted now. The previous trials, all studies were done when thoracotomies or pneumonectomies were, as you showed in one. So we are going from pneumonectomies to subsegmental resections, minimally invasive uniportal resections. So things are going to change in maybe next few months, and resectability post immunotherapy or even before going for these trials should be a surgeon's domain to see whether he will be able to take this single station or a multi-station N2 or not. The one of very common question which is asked is after post immunotherapy, does do you have see any fibrosis, any problem with the operability? And we have done 3 cases post immunotherapy of PGI group, and all 3 of them VATS. It's not there. The fibrosis, anything is not there. It's very easy to operate these patients as an emergent patient of CA lung. Thank you.
Thank you. One question, Dr. Harsh. So, what exactly are you doing currently? So, if you get a operable stage 3A CA lung, so are you subjecting routinely to immunotherapy because the PAT-CR data?
Sir, basically it's an MDT decision mostly. We give the option to the patient, but if I see if it is a straightforward operable patient, we operate them. Pathological complete response, sir. I think it should give it a disease-free benefit and a survival benefit to the patient. So now we are shifting. Now our medical oncology teams are shifting to newer things also.
Thank you, sir. Thank you so much.
Thank you very much. It was wonderful listening to this debate. I think take-home message is that if we have to change the trend from one treatment to the other, it should always be a multidisciplinary approach rather than jumping over the conclusion that this treatment is better than the other. So I think all the teams should sit together and then make a plan which one is better than the other. Thank you so much.
सर ने बड़ा अच्छा समाप्त किया।
Thank you, sir. Thank you, ma'am. I would like to invite Dr. T.P. Sahu from Bhopal for discussion on first-line immunotherapy. Also, I would like to call our panelists on stage to grace the chair. Dr. Nadeem Shaukat, Dr. Lalit Sharma, Dr. Rajiv Saini, Dr. Kunal Sharma, Dr. Parveen Jain, and Dr. Arjun Chib.
Good afternoon, everyone. Thanks for the invite, and my first time in Jammu. So now we skip gears and from operable lung cancers and the concurrent. So we will move to the first line immunotherapy, and here I was told to stick to the stage 4. That's why I am sticking to stage 4. The only one thing is there, what we could add to the debate is now, if it is something like a stage 2 or 3A, now the surgery, before surgery, do consider the neoadjuvant treatment. That is the in thing now, and that is something we should consider. That's why multidisciplinary team, as the chairperson told, should be the way to go forward. So now we just shift gears and let's in half an hour finish off the topic given to us. So we'll be speaking on the non-driver mutation, non-driver metastatic non-small cell cancer. So I'll go to a case, and 55 years old man, former smoker, businessman, has pain in the left thigh with history of cough, mild shortness in breath, and the ECOG is PS1. So good ECOG. Has a central tumor in the right hilum. Left thigh has metastasis. There are bony metastasis, but has a single liver metastasis. The lung biopsy is adenocarcinoma. Pretty sure a stage 4 lung cancer, which is NSCLC. So anyone in the panel, I'll come to my pathologist after what they tell. So you as oncologist, what would you suggest as a markers after this? Do you do immunohistochemistry and ask for TTF for a definite report of adenocarcinoma, still very, very clear cut written by pathologists routinely?
Yes, we do routinely ask for a IHC.
So you ask, every one of you ask for IHC in a classical, clearly reported adenocarcinoma?
Sir, if the report is adenocarcinoma on histopathology clear cut, then we'll go directly for the molecular test.
Okay, so that's what I do. If it's a very clear-cut case and the pathology pretty sure has not written poorly differentiated variety, I would still be very comfortable going ahead and not wasting the tissue, because the tissues always are very, very small. But people do IHCs, and the pathologists in many centers routinely, per se, because of their SOPs, they run the IHC. But in our center, we just hang on. If there's a clear-cut case, we just let it be there. And if it is fitting into the criteria, I feel IHC is not going to help us much, but if someone does IHC, well and good, that's nothing wrong about it. So now next, from there itself, we can start from the extreme. Multi-gene assay versus a single limited gene you want a limited panel, or you want a comprehensive, or you want to go sequentially? How do you want to do your mutational analysis?
I think if I know it's a driver mutation negative,
No, you don't know anything.
I don't know about it. So I would actually go for, in my setting, what I usually do is we don't have the capacity to do NGS.
That's
So
okay.
we
What
do.
would you order?
I
That's
would,
fine. Most of the
the
centers
usual
order.
driver mutations, IHCs and PCRs for the driver mutations and PDL1 testing.
So you look for the known mutations, you run a limited panel.
A
you
limited
run
panel,
the
definitely.
PCR thing.
Yes, yes.
Please, next.
First of all, I'll discuss with the family and patient what they have, then so okay. Then I go to multi-gene assays, sir, upfront. Yeah, definitely.
The NGS for the comprehensive.
Yeah, definitely. That's
Okay, for the which PDL1 do you ask for? Because most of the labs
Yeah.
have a PDL1 written to it. They don't run all the markers together. So what do you want?
that is TPS score, and that depends on the, like, if I that SP 263
You want
140.
SP260. Fair enough.
That's
Can I ask that?
263.
What is the PDL1 marker you would be comfortable?
I think SP1, 263, 142.
140, anything is
Anything.
okay with. So you are getting a lot of questions. Yeah, please. Next. What is quickly? Which one?
So it depends on what is the TAT for my CGP or a single gene based assays. So if it is 3 to 4 days for single gene based assay, so I'll first like to go ahead with the single gene based assay.
Sequential one.
Yes, the sequential one. So, but ultimately, I'll be keen if I do not get any oncogene in single gene based assay, I would like
So
to do
basically you will go
CGP.
sequentially for the
Yes.
commoner things. If you get negative, then you will go for NGS. That's what I'm for.
Yes.
Please, we will move on.
I used to do 9 or 12 NGS gene panel.
So the limited panel, the
Yeah.
coupon one which you are getting. Okay, so you want to do that. Okay, that's fairness. So what I want to express, and I'll come to pathologists on it. So there are two things that are coming out. There are a lot of people still, half of the panel still feels that they would like to go for a limited panel, or even people are still going for the sequential one, which we used to do a few years back. It is not that they are wrong, but this is something you have a concern with. Now, point number one. Point number two, what is your preferred take on a comprehensive versus a limited panel? Can you take that first, and I'll come to PDL1 after this.
Sure. So sir, I will, try and represent what happens in our center, which is one of.
What should ideally happen?
So I think ideally, a comprehensive genome profile would probably be the best way to go forward.
Why?
Because we also know that, there are multiple combinations of mutations that we are seeing these days. And, treatment alterations might vary in those kind of settings. If we just go for, let's say, an EGFR AL cross, we might be missing some other common mutation that might come along.
Okay.
So that is the
Okay.
answer to that question.
Okay, and the PDL1, can
So-
you tell us
so,
what
sir-
are you comfortable with?
Yeah.
And there are some people who still feel anything is okay. Is anything really okay? Or do you feel there is a set which is little superior, the confidence is much more better between them,
Right.
and the others are out? Can you tell them?
So to be honest, sir, I think Tecentriq has specific indications. So SP142, which is PDL1, is a companion diagnostic assay. We use it on one particular platform with one clone and one antibody that needs to be given. So SP142 is for Tecentriq, that is atezolizumab, which has specific indications.
And I agree, but on a reporting, do you ask your oncologist then, Dr. Saab, what do you want to give, and then you run it?
So mostly, sir, what happens is I get a requisition for a particular clone because I have all of them available.
Okay.
But having said that, to be honest,
the maximum requisitions I get in a setting like these are for 22C3, that is for pembrolizumab.
Okay.
And there is a question that some people ask me, if SP263 and 22C3 are similar, there are various studies which show that, concordance is up to 94-95% in early, a recent block and also in higher TPS scores. But when we come to borderline scores or lower scores, concordance starts changing.
Okay. So there are two things which is very, very clear. I wanted to make out that do not waste much of your tissues on a sequential at this point, not wrong, perfectly in line. Because the small tissues, you want to run it. And second point, if you look at it, the TAT for NGS, if you do it is around 14 to 22 days, depending on the lab which you do. In-house lab, you might get 2-3 days, 1 day or 2 days earlier. That's the only difference. The third thing is that there's not much of a difference in cost between the limited panel, except you are getting on a coupon, versus if you run a large panel. The cost difference is around 5,000-10,000 rupees. I'll come. The second point on the TPS score or the PDL1 is important for us to know, because that is where the real game starts. Very rightly, the companion test, if I want to do a pembrolizumab, it is 22C3, that's done. Can I interchange if I have something like, let's say 28.8, or let's say I have a SP263, can I do still a pembrolizumab? Yes, you can do it. Idealistic speaking, no, but there is concordance, very good concordance in the Blueprint 2 study that the 22C3, the 28.8, which are both DACO platform, and the Ventana platform SP263, all the three really do well on the tumor cells. The problem starts when the immune cells get started staining, which is where the SP142 gets over, because that is atezolizumab. If you look at the data, it also, if there's more than 10% staining in the immune cells, it is called IC3. There is a high score for them, and 50% in tumor or 10% immune cells. So my point of taking is SP142 is little bit not so good. The confidence is little inferior, but it is the standard companion what we do see for atezo. But if you look at other threes, SP263 or the 22C3, which is very common because of the Pembro data, mostly we use that, or 28.8, these are probably concordant on tumor cells. Is that fair to conclude? Okay, so as medical oncologists, I feel, or as oncologists who practice immunotherapy, we should be pretty sure what we are ordering. I would not let my lab decide what I want to do. I will let the lab do what I want to do. I can discuss with them. They can advise me. So this is something which I wanted to ask you. But to all fairness, to my friend who told limited panel, because there are a lot of coupons, because company wants their benefit. They give 8 or 10 panels plus PDL1 in 5,000 rupees, 8,000 rupees. You can do it. Why? Because there are only drugs approved for those 8 mutations. Others are still out there, not approved. So for that reason, I think that is also a fair point to do it. And the method is still NGS. But the problem with those of the methods are most of them have known mutations. You would not, for the comprehensive panel, you also can get rare unknown mutations because it picks up the whole. So that you won't get when you are running a panel which is limited for limited mutations. And this is especially true when you look at exon 20. When it comes to the large panel mutations, having more than 90 to 100 mutations, exon 20. There you miss a lot of times if you're doing a limited focus PCR. So that is why if people do it, NGS is the way to go forward. Logistically, you have to work it out. PDL1, I told that. If you want to say. Okay, thank you. So now we move forward. Now the real thing, because this is the starter which I wanted to give, and next 20 minutes will be very clear cut. And there are 3 situations which I'll do. Scenario 1. PDL1 by 22C3 60%. Perfect. EGFR mutation is positive for DEL90. And this is a common scenario. You would see a lot of EGFR mutations coming with high PDL1. What do you do? What is your treatment option? Can I start from here and go there? Can you speak into the mic?
EGFR mutation takes precedence over this PDL1.
Okay.
So my first choice will be to go with this TKI.
So you will go with the TKI alone, or as per what is the standard of care for a TKI? Osimertinib versus Jepi plus that can do. Anyone wants to go with him, or someone wants to differ from? No? Okay. Yeah, please. You want to say? No. So this is something which I wanted to pick up because this is now getting accepted And never ever try immunotherapy in such patients because the PD-L1 is high. Don't do that mistake for two reasons. You have a drug, you have a target, you have a drug, the toxicity is much lesser, the response is much better, and you normally patients do much better. And immunotherapy, the responses are poor, and actually it has shown it is detrimental probably in a lot of the patients. So that is case scenario one. I come to scenario two, which is much more a typical case. Same thing. No targetable mutation from the extreme side. Please, sir. Same patient. What we saw, one single liver met, multiple bony mets, one thigh deposit, adenocarcinoma. Now we have a PD-L1 of 60%, and there is no driver mutation by NGS.
I think when the PD-L1 is more than 50% and the tumor disease burden is not that high, I'll be very comfortable in ICI alone approach.
So your choice will be a checkpoint alone. Can you be more clear about what would be your preference if you are to choose? I'll give you the options: Pembro, Atezo, and the Nivo. There is one more, but let's stick to these three which are available.
I think Pembro alone.
You will go for Pembro.
Sir, I will go with Pembro single agent in this case also.
Anyone differs here?
So both are option, chemo IO combination also and the IO also. I'm not a very big fan of IO monotherapy. So, but because the patient is smoker, so see, there are certain factors which we have to consider when we are going ahead with the monotherapy. So first of all, if patient is a non-smoker, so I will not be keen in going ahead with the monotherapy. The second thing, if the burden of the disease is quite high or it is there in the critical locations, I don't want to go ahead with the monotherapy.
Any specific reason for not going forward in this subset? Which
So, sir, the response rate with chemotherapy IO combination is close to 70%. And if we see IO alone in the high expressor, so it is 45%.
Okay.
So then I'll be more comfortable in giving few initial cycles of chemotherapy along with IO. And the third place where I won't use monotherapy. So, so like we already know that if any oncogene mutation, because EGFR we are pretty clear.
It's not.
So then these are the factors.
Anything to add to what you told?
No. Only the patient has poor PS, a patient has low burden of disease. I'm happy with the IO alone. Otherwise, IO with.
And in fact, if the patient is very symptomatic, then also I would like to consider.
So the panel is much on the target. So if you look at what are the options, actually chemo plus immune checkpoint is the option. Immunotherapy alone is the option. IO combination is also an option. Plus minus chemotherapy. Which immune checkpoint will you not give? Can I ask in a different way? You are not those who are talking of a single agent immune checkpoint. Which one would you not prefer, or anyone is okay? Any reasons for that? Yeah, you want to please. Yeah.
Durvalumab is altogether not because that is not be given in a metastatic.
Okay, you will not give Durvalumab.
Other than that, rest all this immunotherapy agents.
Okay, you feel all can be given. Anyone wants to concur with him, or there's a discordance in this?
So I would like to differ. So Nivo, there was a trial in high expression and it was a negative trial. So I think Atezo and Pembro, so they are the options.
So this is something you need to remember. If you are doing it more than 50%, point number one, platinum doublet alone is the option, is not the best option. It is not wrong if you do it. It's only for those cases who cannot afford immune checkpoint inhibitors. Chemo with immune checkpoint is a very valid option. Immunotherapy alone is a valid option, and IO, EP, Nivo is also an option. Nivo alone is not an option. That we need to remember very, very clearly, and I'll tell you why. The Checkmate 026 trial has shown that in that limited data which we have, more than 50% of the trial, if you look at that, more than 50% in that patient data set, they found that nivolumab is not doing anything better than chemotherapy. It was a subset analysis. It is not that the population was only more than 50%. The population was actually more than 5% CPS score. So in that trial, they told that Checkmate 026, the Nivo probably is not doing as good, and the other drugs which you can give is Atezo, you can give Pembro, you can give the Nivo EP. Even there is some data developing from the Durva, but it's not that the data is there, it's not in the recommendation, but Nivo is not to be given. Should I give an immune checkpoint and chemotherapy alone? In which cases the panel was bang on target. For bulky disease, critical structures nearby, there's a lot of disease. Do not try immune checkpoint alone, avoid it. For the reasons of not a response, for the reasons that 40% of this patient have progression of disease on single agent immune checkpoint. Around 30 to 40 will progress actually, if you're giving only immunotherapy in this high subset of patients. So those might lead to deterioration. If you give chemo plus immune checkpoint, the progression is less than 10%. So that is one of the major reasons, and other reason are rightly told, the responses are much superior, but there will be added toxicity. And that's why the panel was perfect. Frail patient, and someone rightly told smokers. If I have a frail patient or not a frail patient, less bulky disease as the patient is a smoker, very likely I will go for immune checkpoint inhibitor alone. But if it's a bulky disease, non-smoker, I'm little skeptical. I might add chemotherapy for the first 3 to 4 cycles. So that is what is it for this. I'll skip this. I'll just go to the salient points of these things. So are all immune checkpoint the same? No, we saw that Nivo data is not correlating with the other immune checkpoint inhibitors. If I go back, this is the first trial, Keynote 024. It did show a superiority over chemotherapy in this subset of patient. This is the drug which is not available, the semiclimab. It is a drug that has consistently shown results, and again the same results that the single agent of this immune checkpoint is also superior to chemotherapy. And one more thing, it tells you that in this data, that if the PDL score is more than 90%, very high PDL score. If you look at it, the responses were not that great, but sustaining the response was excellent. So more than 50% also, if you look at it, 50 to 60, 60 to 90, more than 90%. The more than 90% patient, the sustenance of response was very, very large. And the median overall survival was not reached. The hazard is the best seen 0.46. Normally the hazard is around 0.6 for this subset of patients. Okay, so I'll just skip this. I'll not go into any one of this. I'll go to the second subset of patients. This is the trial which I spoke of, the checkmate 026, which was showing that the last one, more than 50% PD-L1 expression, there is not much of a benefit of Nivo better than chemotherapy. The reasons are very few. Some people told that the markers which they used was different from the Keynote 024. The second, the never smokers were more in 026. Radiotherapy was used in 37% of 026, was not used in Keynote 024. Would that have played a role? We don't know. The last point was, in Keynote, they allowed new metastatic biopsy and allowed 1 month time before randomization. So patients who were aggressive could have progressed and they could have out of the trial. Did that do? And again, if you look at the trial of this one, more than 50% were more towards chemotherapy, but not to Nivo. And females were more in the chemotherapy arm. Liver mets were more in the immunotherapy arm. So basically, it was loaded against nivolumab is the thing, but the data tells you do not give nivolumab just because you're getting it cheaper. That is not to be given in this subset of patients. That is the take home. Okay. So I'll skip this. In the next scenario, 10% 22 C3 PD-L1 score. Now, what are your options and what will the panel do? Quickly. 10. You will give combination chemo. I will just add to that single agent pembrolizumab is approved more than 1%. So why not give only single agent pembrolizumab for this subset? My question is very, very pointed, because pembrolizumab is approved for more than 1% as a single agent. Please speak into the mic. Yeah, you're worried about the initial
drop in the Kaplan-Meier.
You're worried about the curve, how they're separating, and the drop and the progressions that are happening.
Yeah.
That's your point.
As we said, we have the data regarding the TPS score less than 50 or more than 50, and there is a lot of there is a lot of discussion on that. If a patient is a high volume disease and the patient is young and fit, then I go with combination chemo plus immunotherapy. But if patient frail, like patient is old age, it's not able to tolerate chemotherapy as well as per me, then I go with single agent immunotherapy also in this case.
Any difference? Why would you not use the single agent immune?
Sir, I'll use monotherapy only in those patients who are not candidate for chemotherapy or who are
Who
not
are very
willing for
fit.
chemotherapy. Yes.
Okay.
So because most of the benefit which we saw with more than 1% PDL1, so it was driven by the high expressors.
Okay. So if you look at this again, what are the options? Number one is the option anyway, always. Chemo with immune checkpoint is the most valid option probably. Immune checkpoint alone is legally valid. That's the point which I want is legally valid. Someone does it, he or she can fight it in the court of law. No one can challenge that person. Now I'll come and dissect the data for you. Any other option, the IO-IO combination is a superb option. The best thing about IO-IO combination is the plateau of the curves. In the IO-IO combination, after 3 years, whoever does not progress, rarely progress after that. There's a beautiful plateauing of the curve with the Nivo-IP combination, and that is around 30 to 35% of patients. That is something which you don't get even with immunotherapy and chemotherapy. That is one basic point for the IO-IO, but it is not the most chosen one. It is one of the options, not the preferred option, because of the only one trial has looked into it. The point that I want to make is this one. This data. This is the data that what our panel, one of the panelists rightly told. Although the data is positive for more than 1%, when they looked at the data, look at this curve, more than 1%, if they look, the Pembro is better than chemo, perfect. Now they've divided into 1 to 49% mein kya hota hai? And look at the curve that side. There is no difference of the chemotherapy and immunotherapy versus chemo. So the take home is the benefit which immunotherapy alone was doing was because of the high PDL1 of more than 50%. That was driving the benefit. And when you subset it to around 1 to 49, the chemo is equal to chemo plus immuno. So that is one of the major reasons why I think probably if it is below 50%, although legally you are valid because the primary endpoint of the trial was more than 1%. But science tells you that do not waste money on pembrolizumab for this subset of patient till you have a really frail patient. You're very, very skeptical. But in that patient also, I will give little lower doses of weekly chemotherapy plus immune checkpoint. And if the GC improves in 1 month, I'll go for proper chemotherapy. So this is one take-home message we wanted, the panel wanted to tell, and the panelists picked it up very nicely. This is, again, can we go for the single agent versus the combination? Yes, you can go for it. The toxicity is a little more. That's why the panel told frail patients they will avoid. But is there a comparison of trials? There are 2 trials which will be coming out this year or maybe early next year, which will tell us that in 1 to 49, which is the real patient, which is the best drug. The next, the best we have is this one, which is the FDA pooled analysis. Again, telling you the same thing, that in the 1 to 49, chemotherapy plus immune checkpoint is better than immunotherapy alone. So again, we go back to, this is a pooled analysis. We had the 1 to 49 subset also. So again, the take-home message from the panel and me would be, do not waste your money on immune checkpoint for this subset of patient alone. Add chemotherapy to it. That's what I want to say. Okay, now the last one, less than 1%. What is the option? Quickly from there. And we'll finish the panel.
For me, sir, less than 1%, if there is an option, then I go with the 4-drug combination therapy, like chemo plus amino plus bevacizumab, if patient is fit and the high volume disease. Bevacizumab, yeah. As a atezolizumab. Yeah. Yes, bevacizumab.
And do you feel there's added advantage of adding bevacizumab? 2 questions.
Rather, I will go with the chemotherapy only, and I will reserve.
You will go for chemotherapy only. Okay.
Chemotherapy alone.
Alone.
Less than 1.
So regarding the ABCP, so the comparison of ABCP versus ACP was not there. So we do not know whether the bevacizumab added to some of the advantage to that. So here, the choice is going to be either chemotherapy with immune checkpoint inhibitor.
Which one?
Or it will be either, because it's an adenocarcinoma, atezo, paclitaxel or pembro, pemcar, both are option. Apart from that, checkmate 9 L8 option is also valid.
So here IO comes in nicely.
IO plus cycles of initiation.
Okay.
I think
Any-
IO is something I would be excited about, yes.
So here the preference change in the panel. Suddenly the IO combination comes into our mind much more earlier than the others. This is one subset with IO plus 2 cycles of chemotherapy initially in the trial. I'll tell you, they gave IO, Nivo-IP plus 2 chemotherapy in the first 2 cycles. Why? Because if you add chemotherapy to the first 2 cycles, the progressors are out. You will have more responses. And then you take out chemotherapy, not 4 cycles, just 2 cycles, stop chemo, and then go for IO, and the plateauing of the curve is seen. And this trial showed that less than 1%, the IO combination is active both in squamous and non-squamous. Even the Nivo plus chemotherapy was also active, but the IO combination is superior to Nivo. That's point number 2, which I wanted to make. For my friend who's telling that adding a bevacizumab, I don't do it personally for reasons which was pointed out. It is toxic, it is costly, and there is no trial to show me that bevacizumab added anything. The trial was addition of atezo to the triplet. Is it okay? And I will only use the bevacizumab combination probably after failure of a EGFR TKI. If there's nothing left, I will then add in the EGFR positive immunotherapy. This is the trial which has shown that in a failed TKI EGFR positive, you add atezo, pacli, carbo, bev, the responses are decent. That's where the only indication comes in. So I think this is what it is. And if you look at the keynote 189, it again tells you that chemotherapy plus pembro less than 1, more than 1, the benefit is similar. But look at the IM power, the atezo benefit really shrinks. The atezo benefit less than 1% is not as great as the pembro benefit. So this is my preferred chemotherapy will be, immunotherapy will be pembro or the IO combination, which was told to us by this trial, which is the CM9LE. The 2 cycles of chemotherapy to IO combination, if you look at it, the graphs nearly are equal for less than 1%, more than 1%. So I am coming to the last part of it. The only take home last I could add on to is post progression of a IO, what you can feel is you can still use the standard platinum doublet as a second line, which you cannot use if you're using chemotherapy in the first line. You will use a docetaxel alone because that is the preferred thing. That's the last point. IO can be given if you want to give a chemo free to the patient, because the immunotherapy plus immunotherapy, there is nothing as a chemotherapy, but you also can add 2 cycles of chemotherapy to take care of the progressors that is happening. So before I conclude, anything in the panel would like to add to what we have already told? No? Okay. So this is my concluding slide, and I hope the panel concurs with it. Before the take-home message, I wanted to again come back to the pathologist and reiterate to all of us that what he told, that the comprehensive multi-gene and the comprehensive NGS is better, but others are not bad. They can still be done. The point number 2 is the PDL1 marker should be dictated by the drug which we have in mind. And also we should know that the 22C3, the 28-8 and the SP263 look similar on the tumor cells, not immune cells. 142 is little inferior, the concordance is not there, but immune cells still very good with 142. That's the take home from the pathology side. From the treatment side, that for PD-L1 positive, that is high is more than 50%. Single agent immune checkpoint inhibitors remain the mainstay of treatment. Nivo is something which we will avoid. Chemo IO combinations are also valid. Where the panel doesn't want to give the IO is non-smokers, bulky disease, critical structures, nearby critical structure, you have a lot of disease. Try to avoid single agent IOs that might be 20, 30, 35% progressors, which might lead to trouble. So add chemotherapy to those patients. Otherwise, this is valid for the other thing. The next option is the IO combination also has similar responses, but it is not the preferred, it is the second most preferred. For PD-L1 negative, either IO combination IO chemo or IO and chemotherapy are three options which you told. For 1 to 49, for me it is IO chemo, IO or IO chemo. Single agent chemotherapy, immunotherapy is avoided because of the data which you showed, that the data, although legally you are okay with giving single agent pembro, it is valid, government has authorized it, but I don't think we'll be doing justice to the patient if we do not add chemotherapy to this subset of patients. Although long-term survival is possible, it is only realized in a subset of patients, that is 15 to 20%. So do not blame the medical oncologist कि हम बहुत महंगे इलाज करते हैं. It is that the 20% long-term survivors will only happen in the non-driver mutation NSCLC advanced if you add chemotherapy. Otherwise, the median survival is around 12 to 13 months. That's it. With immunotherapy, it is jumping to 2 years and 2.5 years, doubling of the OS. And 25% of patients have lived beyond 5 years now. So that is something that is the take-home message. So thank you, panel. Thank you, organizers. Thank you, audience. Thank you.
Thank you, sir. Thank you so much. Now it's the time for the lunch break. I would like to request all our guests to move towards lawn area. Lunch is waiting for you outside. We will resume here at 1:45 p.m. Thank you.
An important announcement to make. In the evening, we are having Women Cancer Symposium at 4:30. So everybody should attend that. There will be 6 famous oncologists of India sitting in a panel and answering your queries. And you can call your colleagues and your friends, female friends, for that Women Cancer Symposium. Another important announcement, that inauguration will be along with that symposium, and Secretary, General Administrative Department, Shri Sanjeev Verma ji has been kind enough to grace the agreeing to grace the occasion. So thank you.
Who have participated in poster competition, their results are going to be announced on the route. Anil. नहीं है सुरभि को बैठा रहे हैं तो पैनल में हो
पैनल में नहीं है सर वो।
मीनू गुप्ता को बोल देना चाहिए पर्सन के अंदर मीनू गुप्ता बोल देना करूँ स्टार्ट मैं कह रहा था बच्चे आ जाते तो हम अनाउंस कर देते हैं ना तो बहुत बच्चों को बुला अंदर
ये राजश्री
यार रविंदर राजऋषि सर से पता करो ना, पहुंचे नहीं राजऋषि सर ने क्या बोला? कवर इट डाउन, टाइम टाइम 3 मिनट डाउन, 3 मिनट तुम्हें कवर करने हैं। बस ठीक है। आया रजय सिंह भाव मीनू मीनू डॉक्टर मीनू चेयरपर्सन। We have an announcement to make. We have got 17 abstracts, and out of that 11 were selected for presentation. And out of those 11, 5 top who will present oral presentation tomorrow at 9 a.m. sharp. They should come at 9 a.m. sharp. They are Dr. Surbi Negi from Himalayan Institute of Medical Sciences, Dr. Anveshi Sharma, GMC Srinagar or Jammu, Srinagar, Dr. Rajeshwar Singh Jamwal, Shri Mata Vaishno Devi University, Dr. Tanvi Mittal, Himalayan Institute of Medical Sciences, and Dr. Varun Mahajan, Government Medical College and Hospital, Jammu. So Dr. Meenu has topped the list.
Welcome back, everyone. I would like to call our chairpersons on stage to grace the chair, Dr. Rabina Mirza, Dr. Sushil Jain, and Dr. Meenu Gupta. Now I would like to call Dr. Sujit Bhatt for discussion on work up adnexal masses. Would also like to call our panelists, Dr. Anil Mehta, Dr. Amandeep Kaur, Dr. Samita Bhatt, Dr. Kanika Batra Modi, Dr. Vikas Heer, Dr. Minakshi Rana.
Good afternoon, everybody. Welcome our chairperson and panelists. Myself, Dr. Sudhir Bhatt. I'm consultant surgical oncology at AII Jammu. We'll be discussing the workup of adnexal masses. As you know that patient present with a variety of cases like can be benign, malignant, or metastatic lesions. So proper workup is very important in these cases. So we'll go to panel discussion, workup of adnexal masses. As we know, it can affect any age group, can be simple functional cysts, benign, primary malignant, or even metastatic tumors. So proper work is So we'll go to case number 1. This is a young unmarried male who was presented with heaviness and distension of abdomen for 3 months. No other significant family history, menstrual history is normal. And on examination, the positive findings, abdominal pelvic lump, which is reaching up to umbilicus, mobile, non-tender. So I'll ask my panelist, what will be your first step, first investigation in this patient? Ma'am.
First investigation, first we will try to elicit other points in the history, whether it is related to food intake or it occurs empty stomach, whether it's associated with nausea, vomiting, or whether it is associated with any heaviness or pelvic pressure. Once proper history is taken, then we'll go for examination and we'll see the type of lump. And first investigation, as we always do, first we'll go for complete blood workup, CBC. And then after that, since it is a huge lump reaching up to umbilicus and girl is unmarried, first we'll go for an abdominal ultrasound.
Yes, ma'am. Very right, ma'am. So the basic investigation should be the first investigation. So ultrasound abdomen will provide you a lot of information, and that particularly young unmarried male. So obviously the first investigation will be the ultrasound. And on ultrasound, what will be the what things we should look for on ultrasound?
According to the latest recommendations, ultrasound is the mainstay. Apart from the other investigative modalities, imaging modalities, ultrasound should be given maximum importance. But it is not like to be done just an ultrasonography to report this much centimeters or solid or cystic. But it has to be under some guidelines that ultrasound, because we have to say that the first thing is ultrasonography, because she is an unmarried girl, probably TVS would not be possible. Had she not been had she been married, TVS would have been first modality. And not only TVS, we now recommend what is known as a double ultrasound, the TVS and a duple ultrasound, TVS and transabdominal. So we, our sonologists should focus on various things. This, I don't know whether it's a solid tumor or whatever, but it has to be under a proper benign malignant scoring system. And we have to have the benign rules and the malignant rules, and according to that we should investigate her, and then if required we should do markers also.
So there's definitely a term model that we look on ultrasonography. There are clear-cut guidelines that what we have to look for: benign features as well as malignant features. So benign features can be that the cyst is unilocular, or there are solid components which are less than 7 mm, acoustic shadows, smooth and multiloculated tumor, and no blood flow on color Doppler. As well as on malignant features, we have to look for any irregular solid tumor, any ascites, at least 4 papillary structures, and multiloculated lesion but with diameter more than 100 mm, and very strong blood flow on Doppler. So based on these this ultrasound findings, can we label a patient as having a malignant or a benign lesion?
See, if we see the on the ultrasound, it's a unilocular cyst and less than 7 mm the largest diameter of the cyst, and acoustic shadows are present there, and there's a smooth multilocular tumor, diameter less than 100 mm. So in such case, we can suspect it can be malignant also. But if we have to differential, we have to keep the differential diagnosis in mind. So most of the times we have to first differentiate whether it is a gynecological cancer, it is a non-gynecological cancer. Because sometimes the mass in the pelvis can be from bowel. So once we did one case, we thought it is an adnexal mass. In ultrasound, even in MRI it came, but it was just, it was a pedunculated gist, it was coming from intestines. So this is to be kept in mind. Second, in adnexal mass, first we can go for, if it is limited to the pelvis, we can go for MRI for further evaluation. And if it is not limited to pelvis, it is coming to the abdomen, then CT scan is the next option. So in addition to it, we have to go for the scoring. If it is a young unmarried girl, so we should go for tumor markers, especially germ cell tumor, rolling out germ cell tumor markers, and then taking a call what to do.
Just to add to the ma'am's comment that the incidence of malignancy in young female are very less. So first we have to suspect the benign pathology and this morphology, and then after doing the markers, and then after doing the further imaging MRI characterization, we can say that it can be malignant, but the incidence of malignancy is less than 2% in young females.
Dr. Sudhi, there is one situation where we can for certain say that this is benign, and that is a completely cystic swelling on ultrasound. We can for sure say, but if there are solid components, then we can't for sure say that it is either benign or malignant.
Yeah, on ultrasonography, if we are having only benign feature and with no malignant features, then there is a highly chance that it will turn out to be a benign.
I think in such cases, we should go for by ORAT scoring. If it
Yeah.
falls in one, which is absolutely normal, and these are functional or cyst or corpus luteal, which is very unlikely because cyst is huge, then we don't have to do anything. Then we have to go to see whether it is ovarian cyst of some physiological cyst, like any hemorrhagic cyst, like that. Or third is if it is pathological cyst, then pathological like endometriomas, like it is having acoustic shadows, it can be proven endometrioma. If it is there no blood flow, they're very less likely to be malignant. And if 4, 5 it shows, then we have to go for further. Only problem comes where it is ORATS 3, where we have to differentiate whether we are missing out on any malignant. In that case, we have to be very, very cautious.
One thing I would like to add is that when we were postgraduates, I think not so many modalities were available, but and the teaching would go as malignancy is very common in after age of 50, and it is very common if the patient is very, very young. So in between, you should not think of malignancy from the outset, but then you should investigate. I mean, you can't rule out a malignancy at any age, but you should rule out with various modalities available. But clinically, you can confidently say that the patient is not having a malignant pathology.
Very right, sir. So we have this IOTA next modern calculator. So we can put all these parameters into the, it's available online, put these parameters and you get a score, and then you be very sure about what is the character of the lesion. So ultrasound showed a uniloculated 18 into 18 centimeter thin walled right ovarian cyst. And also MRI was done, which supplemented the ultrasound report only. And tumor markers were just within normal limits and just mild raise in the CA-125. So what is the India's suspicion of malignancy in this case?
Very evident, the suspicion of malignancy is quite low. I mean, it's not even thick walled that one would suspect anything.
What will be the best approach?
18 centimeter mass in a 24-year-old girl, I think we should go in surgically, do a cystectomy for her rather than a salpingo-oophorectomy. We can spare her ovary as an MRI has been done, and ovarian mapping can be done, and her ovary. Usually in such cases, the ovary is splayed around the cyst. So a laparoscopic, a minimally invasive approach in which we take out the cyst wall intact, and doing it laparoscopically is just good enough.
Yeah, sure. Laparoscopic is the gold standard, provided you prevent any spillage of the fluid contents.
Spillage will happen with such a big mass. It's 20 centimeter mass. It's not possible to bag it also like that. But with a thin wall, because the suspicion is low, we go and do in ovarian masses, especially when you're doing a cystectomy. It is not possible to not have a spillage. You take it, I mean, you go in with a laparoscope only when you know that spillage won't harm the patient. Otherwise, you go in for an open approach.
In such cases, if we can reduce the mass intra-op by directly putting the section into the cyst. But when we are sure, most likely if you see this seems to be endometriotic cyst with borderline raise of CA-125. So in such case, we can directly go inside, aspirate the contents, and then we go ahead with laparoscopy.
So we'll go to the next case. Now, this is a perimenopausal lady, no comorbidities, was presented with distension of abdomen and bloating. On examination, only positive finding you can see is there is presence of ascites. Ultrasound abdomen has been done showing bilateral ovarian solid cystic masses, right 8 into 7 centimeter, left is 5 into 5 centimeter. There is moderate ascites and pleural effusion. So what will be the next investigation in this case you would like to do?
Again, we have to first go for the baseline investigations like CBC. And I think in such patients, we have role of CA-125 levels also, since she's the perimenopausal age group. So definitely I'll go for those markers. And it needs further evaluation also with MRI. And we have to look for any secondaries also if we are suspecting malignancy.
What, ma'am, would you prefer, CT or MRI in this case?
MRI, I'll prefer to see the.
I think this case shows very important features of what should be considered to be labeled as a malignant. Bilaterality is one, the size is another one, presence of ascites is there, presence of effusion is there. We're highly suspicious of this patient having a malignant pathology. So ultrasound is good enough, but it is to be supported by, I mean, two things we have to document: the involvement of lymph nodes and the condition of the omentum. So it has to be a combination of the MRIs and maybe MRI and CT may be also required at the CT has got a edge over documentation of the metastasis.
Yes.
So I think it is a combination. We cannot say one thing is to be done.
So it is a bilateral solid cystic mass. So whenever we have bilateral solid cystic mass along with ascites and fusion, metastatic workup is to be done. GI malignancy to be ruled out. So upper GI endoscopy and colonoscopy should be done in such case. Along with CA-125, CEA should be done. Because CEA to CA-125 ratio will tell us whether it is in ovarian origin or it is in peritoneal origin or it is GI origin. So endoscopy and then CT guided, we can take if it is an omental involvement, we can take a biopsy, CT guided biopsy also.
If I may add.
Yeah.
No, we will just first rule out the source of where from it has come. Then next step will be whether we want to go for surgery or chemo. That depends upon the histopathology.
Yeah, in terms of imaging, when we have such kind of solid cystic masses, so our preference is to do a PET CT if available. And in PET CT, it is very important to understand how much is the peritoneal carcinomatosis index. So we do a radiological, scoring for the whole thing. And it is one of the key decision-making things as to whether one would want to go in for a primary surgery versus neoadjuvant therapy. And a lot of times in the PET CT report, we're surprised to see supraclavicular nodes, involved mediastinal reports, which otherwise might be missed on a plain CT scan, even if you include CT chest for that matter. So for peritoneal mets and extra-abdominal disease, in such kind of cases in which there is already ascites and pleural effusion, PET CT should be, if available, the modality of choice.
Yeah,
Dr. Sudeep, I'm
Yes,
chairperson.
ma'am.
Okay. So very nicely, Dr. Aman and has told, but one has to go for definitely CEA is very important. CA, any bilateral ovarian masses with this, along with the CA-125, CE is a must to check the ratio, and along with the PET CT, still we can't observe the upper GI endoscopy and colonoscopy because sometimes low SUV uptake and we can miss the lesion even on the PET CT imaging also. So simultaneously upper GI endoscopy, colonoscopy, and for PGs are sitting there once any female coming with the emaciated look with this bilateral masses, and one has to rule out from the GI malignancy. But mostly ovaries, they are usually built is well maintained, and you can think of this is a clinical suspicion. So nicely it's
Yeah. So in this case, a CT was done, it showed again bilateral ovarian masses, ascites, mental caking, peritoneal deposits, pelvis, paracolic gutters, pleural effusion, and a bilateral mammogram was also done just to rule out any breast malignancy that we can miss on CT. So it again came to be normal. Any preference of PET CT over CT, only CT?
And if the PET CT facility is available in the center, we can go with the PET CT. If not, PET CT is not available, then we can go for MRI of the pelvis, CT upper abdomen, and CT chest is enough.
Okay. So again, we have tumor markers that were again CA 125 was not markedly raised. CEA was marginally raised, and CA 19 point was normal. So, what is your threshold in doing upper GI evaluation or lower GI evaluation in bilateral ovarian mass? Are you doing every case, or you took some parameters?
Now, in this patient is having bilateral ovarian masses, 45-year-old age, and CEA is slightly raised, but it is raised. So we have to, if the CEA is raised, now in this case, we go for the colonoscopy. And now, and currently also patient having bilateral ovarian mass, so she definitely required upper GI endoscopy to rule out Tukenberg tumor.
Okay. The endoscopy was done, that was negative. Now what? So will you go for a biopsy or cytology?
Biopsy is better because biopsy will tell us the origin of the tumor, and we can do the ISC to pick up the origin, whether it is from the GI malignancy or from the ovarian tumor.
Suppose there is no facility of biopsy by a radiologist. So what do you do then? If you can diagnose it on cytology?
We can do the ascitic fluid for cytology, and we can also do the ultrasound guided biopsy from the momentum caking. That cytology, if comes positive, it is evident that it is patient with bilateral ovarian mass, raised CA 125, and cytology for it's positive for malignancy, it is most likely origin from the ovarian cancer. But contrary to this, we also do the ascitic, this pleural fluid type cytology also.
There was a time when the adnexal evaluation, I mean, needling and taking a sample was a big no. I mean, not to invade, I mean, go inside and ultrasound guided biopsy from the adnexal masses, because it was a concept that it would change the staging. But I think now things are changing. I mean, there are certain guidelines which are now allowing it for the adnexal, we can pick up the tissue under the guidance of ultrasound, and it would not practically change the stage of the disease.
So biopsy is always preferred over cytology. If you don't have facilities for image guided biopsy, then you can do one thing. You can take out the ascitic fluid, centrifuge it, prepare a cell block, and then do all the tests. So biopsy is showing high grade serous carcinoma. Then any role of genetic testing upfront?
So you see, for maintenance treatment, BRCA1/2, we have to do for starting the post-surgical, we have to start with chemotherapy. So genetic is to be ruled out. She's 45 years old. So I think there's a definite role of genetic testing.
Upfront, it may not be required. You can, without that also, the treatment will not change. Upfront genetic testing will only tell us about the prognosis and the risks involved. But I think upfront, it may not be required.
Suppose this patient is actually stage 4A, so we have to do NACT. Then,
sir, just to add, the only benefit of doing upfront genetic testing is if patient responds to chemotherapy and then in final histopathology we get there is no residual tumor, then it is very difficult to do the genetic testing on that tissue. So it is helpful if you do.
I mean, we routinely do genetic testing upfront. And another reason why we kind of feel it is important to do it in the beginning is, suppose we are planning to give NACT to the patient. So we routinely do HIPEC also in them. So in case they are, HRD or BRCA positive, there is an increasing role that, they would do good with PARP inhibitors on the long run. So HIPEC becomes, although the data is still immature,
Ma'am, but we can always do it later on. I mean, we don't have to test it on the tumor. I mean, we are talking about BRCA. It's going to be positive anyway.
I think
Upfront, as in when you're deciding the treatment, when you're giving neoadjuvant, and it is after neoadjuvant at the time of surgery, you would want to decide for hypec or no. So for that, I'm saying.
so you told it is a high risk case. So if they are high risk, then you have to go for the upfront genetic testing.
Hello, am I audible? So in this case, if I say the left side of the fluid in all likelihood is metastatic. So this patient is already metastatic. So in ovary, we usually avoid the term metastatic. We rather use the term stage 4 because the outcome is better. So upfront, we need to do testing in this patient. There are two reasons. It's high grade. It is stage 4. Number 3, very important, is that the mutations are either germline or somatic. So the germline mutation says that the family's children need to be tested. But in 8% of the cases, the germline may be inactive, yet the somatic mutations may be there. So they carry a therapeutic implication, number 1. Number 2, solo trial says that we give, even after we have done a complete surgery after chemo, this olaparib has good PFS benefit. So we have to do upfront genetic testing if the costs afford, if the patient can afford it. So it's not that it's just for genetic testing. It is not only has prognostic, but has therapeutic implications as well. So we need to do upfront genetic testing in stage 4 if the patient has finances for the therapy.
No, the data is available for the upfront genetic testing for the use of these even targeted therapies as the first line therapy.
Very important role of genetic testing in those patients. So that includes our panel. So take home message is in all adnexal masses, a good clinical history and examination is the most important thing. Then comes the role of imaging. You should have a good imaging facilities available. You can repeat the imaging. You can discuss with the radiologist. You can take a second opinion whenever you are in doubt. The role of tumor markers will supplement your diagnosis and always rule out metastasis from the primary. And any suspicion, please refer to the oncology center. Thank you very much. Thank you, panel.
Thank you, moderator, and all the panelists. Thanks. Any question from the audience? Just for, because students are sitting there, your panelists very well told about the significance of the clinical examination. Any case with a bilateral adnexal masses, complete clinical examination is must, especially for the female patient. Breast examination, gynae examination, you see the overall build of the patient, and always rule out GI malignancy. Don't be in the hurry of starting towards the, okay, it is the malignancy, and scare the patient. And as far as the genetic testing is done, genetic counseling, it is very important, not at the first meet, you scare the patient. Go whole of the families or your neighborhoods, all people will run for the genetic testing and counseling. It is again a, another topic of debate. And
first of all, very well spoken, all the panelists. For gynecology, I think it is very, very important for us to, we have to evaluate adnexal masses in all the age group, whether you are in reproductive age group, in premenopausal age group, and the postmenopausal age group. And it's a very confusing topic also, that you have to be very clear when to start treatment, what type of treatment to give, and how for how many times we have to keep the patient under surveillance. So definitely the topic, these two cases they have discussed is very well explained. But I think even we have some time, all some postmenopausal group, if we have some simple cyst also, we are very much confused when to give treatment, whether to go for surgery. So evaluating any adnexal masses in any age group is very important, so that accordingly we can evaluate and give the treatment.
Nice panel discussion. So if we are surgical oncologists, so always think for the malignancy, but that is not true. So, and second thing, if any patient come with bilateral lead in axle masses, so we evaluate properly, and then most of the cases come in stage 3C or advanced. So most of the patient go for neoadjuvant chemotherapy, then reassessment at after third or fourth cycle, and then accordingly we proceed for continue the same chemotherapy or change the line of treatment, or if patient responded very well, so we can do surgery at that time also, and then adjuvant chemotherapy. And afferent HIPEC is not like standard treatment. HIPEC is mainly for the recurrent diseases in most of the cases. And second thing, if disease is very chemosensitive, so then only HIPEC will work. Otherwise, it will not work. So we have to keep in our mind so many factors, patient factor and financial issues and all these things. Thank you so much.
Thank you, Dr. Sujit Bhatt. Chairpersons can stay back. Now I would like to call Dr. Avinash Rajra to grace the dais.
Good afternoon, chairpersons and all the esteemed faculty. So I am told that we are running short of time, so I'll start straight away. So after the part of workup, we start with the management part, the cytoreductive surgery in ovarian carcinoma. How much is enough? So starting with the ovarian cancer overview, it is the one of the most lethal gynecological malignancies. So much so that the overall survival of advanced stage of ovarian cancer is less than 20 months. And incidence of ovarian cancer is on the rise, probably due to the decreasing parenting among females. And there is increase in the gynecological conditions like PID and endometriosis. So when we talk about the ovarian cancers, we usually refer to epithelial ovarian cancers, which form the 80% of the all ovarian tumors. The other less common varieties are sex-called stromal tumors and germ cell tumors. So coming to the patterns of the ovarian cancer spread, there are four major patterns of ovarian cancer spread. First is the contiguous involvement of the neighboring structures or surrounding organs like uterus, other adnexa, rectum, and bladder. Second pattern is the lymphatic spread, which usually occurs to the subperitoneal route. Then third is the along the flow of ascitic fluid. So it is also known as redistribution phenomena. So what exactly happens is when tumor cells, they exfoliate and they flow along the ascitic fluids. So that's why that is the reason that majority of the peritoneal implants in the ovarian cancer, they occur in the either in the pelvis, paracolic gutters, or in the subdiaphragmatic peritoneum. So fourth is the hematogenous spread to the distant organs like liver and lungs. So stages of ovarian carcinoma. Ovarian cancer can be divided into early and advanced stages. The early, on the basis of risk categories, is further divided into low risk and high risk. Low risk is stage 1A, grade 1 and 2. And high risk includes all other stage 1 tumors and stage 2 tumors. So advanced stages include stage 3 and stage 4 tumors. So what kind of survival data we are looking at in the ovary? So most important prognostic factor is the stage. So stage-wise, the survival, the 5-year overall survival in stage 1 epithelial ovarian cancers is around 90%. In stage 2, it drops down to 60%. In stage 3 and 4, it further drops to half, that is 30%. So what has happened in last few decades is that 5-year survival, the overall survival and 5-year survival both have increased thanks to the treatment modalities and better surgical techniques. The 5-year survival has increased from 39% to 45%, and the mean survival has increased from 34 months to 52 months. So how the evolution of this cytoreductive surgery took place, so as we know it today. So first description was given by Meigs, and this description was a tumor debulking, and the intent was a palliative one. So to allow for a symptomatic relief and prevention of complications. Then Pemberton, he recognized in 1940 that omentum is a most common site for tumor deposits in ovary. So he proposed omentectomy as a part of cytoreduction. Then, very interestingly, in 1957, the first description of OS, increased OS by the cytoreductive surgery was given. And interesting fact that it was in patients of Burkitt's lymphoma, abdominal Burkitt's lymphoma, in pediatric patients of Africa. Then came this paper, the paper of Griffiths. It's a landmark paper, and this paper established the role of cytoreductive surgery as a mean of increasing the overall survival. And this paper stated that the residual mass was inversely proportional to the overall survival. As the residual lesion decreases, the overall survival increases. So this was the original paper by the Griffiths. And this paper was often, paper is often credited for establishing the role of cytoreduction in ovarian carcinoma. So subsequent to this Griffiths paper, there was abundance of data which had shown that as the size of residual lesion decreases, the survival goes on increasing. So therefore, there was overwhelming support for use of maximal cytoreductive effort. So these trials I have mentioned here, there are Hoskins trial, trial by Chi group and Du Bois group trial. All these have shown that as the residual lesion goes on decreasing, the survival definitely increases. So there is these trials also establish use of maximal or optimal cytoreduction. So look at this trial by Chi group. When there was no gross residual disease, the survival was 106 months. This is equivalent to the 9 years of overall survival. So when the lesion it grows, residual lesion, it is 5 mm, the survival goes to nearly half, about 66 months. Then came this meta-analysis by Bristow group. This meta-analysis was a watershed event. And in the evolution of cytoreductive surgeries, this was a large meta-analysis. 81 cancer cohorts were included and around 7,000 patients were included in this meta-analysis. And this meta-analysis clearly stated that with the small increase in the residual, the effort of the surgeon, there was huge improvement in the overall survival. The 10% increase in tumor resection was associated with 5.5% increase in the median overall survival. So the management of early stage ovarian carcinoma, in early stage, we manage by staging laparotomy with the aim of removing the primary tumor and upstaging the disease. So what are the steps which are included in this staging laparotomy? It is typically preceded by a laparoscopy, evaluation of the peritoneal cavity, then a midline vertical incision is given, followed by the aspiration of ascitic fluid or peritoneal wash, which we sent for cytology. And thorough examination, very important, to rule out the disease in the upper abdomen. Then THPSO, and intact tumor removal is of utmost importance, so as to not upstage the tumor by causing the surgical spill. So then we typically do infracolic omentectomy as a part of staging laparotomy. Peritoneal biopsy we take from 4 quadrants. Then in the end, it is followed by nodal dissections in the pelvic and retroperitoneal region. So what are the aims of staging laparotomy? First of all, we confirm the histology of the tumor, because most of the cases of ovarian carcinoma, we do not do a preoperative biopsy. Second is to know the accurate extent of the tumor and to guide the further management, whether to give a new adjuvant chemotherapy or not. Then third is the comprehensive surgical stages achieved. Up to 30% chance of their upstaging the disease is there, and therefore it leads to accurate prognostication. Then an advanced stage ovarian carcinoma is managed by cytoreduction. So cytoreduction is done in 3 settings. First is the primary cytoreduction, which is done in upfront setting, interval, which is done after NSCT, and secondary in relapse or recurrent ovarian cases. So what are the rationale? What is the rationale of doing a CRS, or what are the benefits? First are the physiological benefits, which controlling of ascites and elevation of nausea and early satiety by removing the mental cake. Second thing, it increases by removing the bulk of tumor, it increases the tumor perfusion, and it also increases the growth fraction, which in turn increases the sensitivity of chemotherapy. Then third, it negates the development of chemo-resistant clones of tumor cells. So this model is called as Goldie-Coleman model. So what is the definition of optimal cytoreduction actually? So this definition has evolved over last 4 decades, and the first definition was given by Hoskins group, and they describe it as optimal and suboptimal when tumor was less than 2 centimeter or greater than 2 centimeter respectively. What is the GOG definition? It is the optimal cytoreduction is when the residual tumor is less than 1 centimeter. Then third definition is a CC score definition. So optimal cytoreduction is to achieve a CC score of 0 or 1. That is when there is no gross residual tumor or residual tumor is less than 2.5 mm. So regardless of these definitions, the aim of these oncologists, the gynecological oncologists, should be to achieve a no gross residual disease. So what is the CC score or completeness of cytoreduction score? So it was developed by Dr. Glahan and Gilly in early 2000s. And aim of developing this score was to predict the likely benefit from intraperitoneal chemotherapy. So in a study by Veerwal group, the maximum benefit of CRS and HIPEC was achieved when the CC score was 0 or 1. And as the CC score goes on increasing, the benefit of the HIPEC and CRS diminishes. So this completeness of cytoreduction score is also a predictor for overall survival. So what could be the extent of resections in the cytoreductive surgery? These are the procedures which we routinely do in a cytoreduction. But there is really a paucity of data in these regarding the extent of these resections. So what should be the extent of omentectomy? In a macroscopic involvement of the omentum, the total supracolic omentectomy is the standard of care. But when there is no gross involvement of the omentum, what should be the extent of omentectomy? So there is really a paucity of data, though no RCTs are available. there was only a single prospective study by Vidal group, and which showed that there were microscopic deposits in the gastrocolic omentum, even when there was no macroscopic disease. So this study did not report any OS or PFS data. Many institutional reviews, including our own institution, they said that macroscopic deposits over the omentum do a complete supracolic omentectomy. If there were no macroscopic deposits, infracolic omentectomy should suffice. So what should be the extent of peritonectomies? Whether we do an involved field or total parietal peritonectomy, there are two Indian studies in this context. First is the study, a retrospective study by Somsekhar in peritoneal surface malignancies. And in this study, they reported that the overall recurrence rate in the involved field peritonectomy was higher as compared to the 40% in wide field peritonectomy or total parietal peritonectomy. The second study was also an Indian study. It was done by Aditi Bhatt group in the interval developing surgery setting and in stage 3 and 4. And they showed that they reported that platinum resistant recurrence was significantly reduced up to the 7% against an incidence of 11 to 50% in most other studies. So what should be the extent of nodal dissection? So nodal dissection is very important because nodal lymph nodes are often considered as sanctuary sites or harboring disease, and they offer themselves chemo resistance also. So adequate lymphadenectomy up to renal vein should be done. And adequate lymphadenectomy, what benefit does it offer? It upstages the tumor in 20% patients and has a therapeutic value also. So do we really need a lymphadenectomy in patients where nodes are clinical and radiologically inactive? So LION trial is a trial which answers this question. This is a trial in which stage 2B to 4 patients were included, and they were randomized into lymphadenectomy and no lymphadenectomy arm. So these are the LION trial results. The median overall survival was not different in both arms, but the complication rate has increased in the lymphadenectomy arm, 12% versus 6.5%. So very interesting observation in this trial was about 50% of the patients who were clinico-radiologically negative were found to be positive on pathology. So, but still it did not change the overall survival or PFS. So whether to do appendicectomy as a routine part of CRS. So indications of appendicectomy were macroscopic involvement of the appendix or if there are any tumor implants over the appendix. Whether to do appendicectomy in a case of mucinous ovarian neoplasm. So there is no RCT which supports this decision of doing appendicectomy in mucinous ovarian neoplasm. And all the retrospective studies have really conflicting data. So what other organs or structures which can be resected as a part of CRS? So in order to achieve a total no gross residual disease, these all resections can be included as a part of CRS. That is rectosigmoid resections, partial and radical cystectomies, total gastrectomy, splenectomy, colectomies, pancreatectomy, hepatic resections, and full thickness excision of the diaphragm. So when not to operate in a case of advanced CA ovary, or what are the contraindications of cytoreduction? If there are multiple small bowel segments involved, which can risk small bowel syndrome. Second is the involvement of mesenteric root. Then third is the involvement of potahepatic structures. And fourth is diffuse involvement of diaphragm or diaphragmatic muscle. Extra-abdominal disease, which include the presence of inguinal node, supraclavian node, or pleural effusions. Or very important, the poor stage or poor PS or poor nutrition stage of the patient. So what are the predictors of optimal cytoreduction? There are 4 predictors. First is the serum biomarker levels. Second is the preoperative imaging. Third is the laparoscopic assessment. Fourth is the PCI or peritoneal carcinomatosis index. So biomarker, which is the most commonly used, is CA125. And the levels which are greater than 500, they predicted a suboptimal resection in majority of the cases. But to be used for CA125 to be used alone as a predictive value, it has a very low predictive value. Second, coming to the role of preoperative imaging. So CT is the most commonly used imaging modality as a predictor for complete cytoreduction. Then most of the models which we use as a predictor are based on CT scan. So we use Nelson model, Bristow model, Dowdy, and Mears model. So Nelson model is described here. So these are all the points and parameters which are described in Nelson criteria. And Nelson in 1993, on the basis of these criteria, he classified patients into cytoreducible and non-cytoreducible. So in patients who were labeled as cytoreducible achieved cytoreduction in 23% of the patients. But patients who were labeled as non-cytoreducible, only 16 of the 18 patients were able to achieve optimal cytoreduction. So third is the laparoscopic based assessment. This was done by Anna Fagotti group, and they developed a Fagotti score on the basis of all the parameters. The predictive index value they introduced by summation of all the parameters. So importance of predictive index value, when it is greater than 8, there was high chances that suboptimal resection will be achieved. So these are all the features which are included in the Fagotti score, and all these parameters are assessed on the laparoscopy. So fourth predictor is the peritoneal carcinomatosis index, and this was developed by Sugarbaker in 1990s, and this combines the lesion size with the disease in the peritoneal location of the disease in the peritoneal cavity. And the score of the PCI, it ranges from 1 to 39. There is no value which limits the process of cytoreduction in the ovary, but in colorectal cancers and in stomach cancers, there is a value for limiting the optimal cytoreduction. For CRC, colorectal cancer, it is less than 20, and for stomach, it is less than 12. So this is the abdomen is divided into 13 regions and also includes the lesion size. So coming to the long pending debate of primary versus interval cytoreduction. So prior to 2010, what happened was there was all data which was retrospective, and it was somewhat favoring NSCT over the primary cytoreduction. After 2010, 4 RCTs were published: ERTC, CHORUS, GSCOG, and Scorpion trial. So these are the patient characteristics which are well matched in both trials, both groups in all the trials. These are the inclusion criteria and design of the trials. First 3 trials, ERTC, CHORUS, and GCOG, were non-inferiority trials. Scorpion was a superiority trial. So what was the results of the ERTC trial? The overall survival was similar in both groups, but the NSCT followed by interval developing surgery was associated with lower postoperative complications than the primary cytoreduction arm. So one of the major criticism of this study was that only in 41.6% of the patient in the primary cytoreduction arm had a complete optimal cytoreduction, as opposed to 80% in the NSCT group. Then CHORUS results. These are also similar to the EORTC results. Median overall survival was both same in these 2 groups. Again, the same criticism which was of EORTC trial. The optimal cytoreduction was only achieved in 41% of the primary cytoreduction arm. So this was the JCOG trial. The results were similar to the previous 2 trials. Then came this trial of Scorpion trial. It was the first trial which used laparoscopy prior to the performance of cytoreduction. And the primary outcomes which were included in this trial were the superiority, to establish the superiority of NSCT over primary CRS. But there was no difference in the PFS between 2 groups, and NSCT followed by interval debulking surgery had a significantly lower postoperative complication. However, the superiority of NSCT over primary cytoreduction could not be established in this trial. So what were the conclusions drawn from these 4 trials? The performance of CRS as early as possible in the course of disease should be a standard rather than a interval cytoreduction. Interval cytoreduction you reserve for patients with a poor PS, poor nutritional state, and very high disease burden. So what is the secondary CRS? It is the performance of cytoreduction in the recurrent or relapse setting. Most appropriate patients were platinum sensitive and limited value disease. So question here is, where does this secondary cytoreduction stands in the era of bevacizumab and PARP inhibitors? So there were 3 RCTs. First was GOG 213 trial, second was the SOC1 trial, and third was the Isastop 3 trial. So GOG 213, it was a multicentric trial which was comparing CRS and chemotherapy, and bevacizumab and PARP inhibitors were allowed in this trial. So the patient population there was no specific selection criteria, except that patient should be platinum sensitive and a potential surgical candidate. Only 67% of the patient had a complete or optimal cytoreduction, and there was no difference in the overall survival or PFS. So second trial was a SOC1 trial. It was a Chinese multicentric trial. So one of the advantages of the trial is that the well-defined selection criteria was there. That is a Tian score. It was very similar to the criteria which was used in the Desktop 3 trial, that is AGO score. There was significant results of the trial showed that there was significant difference in the groups, and the OS favored the secondary cytoreduction over chemotherapy. So better overall survival also seen in the interim analysis of this trial. So when we compared the subgroup analysis, incomplete cytoreduction and chemotherapy had similar PFS. So coming to the last trial of the secondary cytoreduction, desktop 3 trial, it was an international multicentric trial, and patients were very well defined. Patient population very well defined. First platinum sensitive relapse or positive agar score, and complete CRS was achieved in 76% of the patients after a follow-up of 69 months. OS was significantly better in the CRS compared to the chemotherapy arm, and PFS was also better in this secondary cytoreduction arm. So this is the agar score. I will skip this. So what were the conclusion which could be drawn from this secondary cytoreduction arms? 2 out of 3 trials have reported survival improvement for secondary cytoreduction versus chemotherapy arm. Survival was only possible when complete microscopy, the optimal cytoreduction was achieved. And patient selection criteria were very important with the help of TIAN score and AGO score. And both trials, which have achieved a positive outcome for CRS, had allowed bevacizumab and PARP inhibitors also. So in spite of including bevacizumab and PARP inhibitors, the surgery arm showed a better overall survival and PFS. So coming to the concluding remarks, ovarian cancer is one of the most legal gynecological malignancies. The maximal cytoreduction of the optimal cytoreduction offers maximum survival benefit, and surgery to be preferably undertaken in the centers where there is high volume, high disease load. Primary CRS should be preferred over interval cytoreduction except for few selected patients. And secondary CRS have a survival benefit pool, as a definitely survival benefit in patients who are well selected, as in the desktop criteria, that is the AGO OVAR score was there. So that's all. Thank you very much.
Nice presentation, and this was the overview of surgical management of ovarian malignancy in detail. So I don't think so anything is left behind after this presentation. So only one thing is very important, whether we are going to do primary or secondary, that cytoreduction should be complete. There should not be any even millimeter disease left behind. So that is the best policy.
Yes, very well said.
Yes, very well spoken. Everything we have covered. And we, Dr. Saab is saying that the prime important of recurrence of this tumor is to have as much as cytoreduction it should be done. So everything you covered very well.
Thank you.
Thank you. Any question from the audience? Mike.
Good afternoon. Is there any role of laparoscopy in early malignancy, early established ovarian cancer?
Sorry, in
Early stage ovarian cancer.
Definitely, ma'am. Laparoscopy, when it can be, we can do a complete staging laparotomy. If it can be done by laparoscopy. It is also a possibility, but you have to achieve a complete staging.
So there is no contraindication if we have the surgical expertise that means in early stage.
Yes, yes, you can do. Yeah, in one of the slides, I told that you can do early diagnostic lab to assess the disease beforehand prior to CRS as well as staging laparotomy.
So,
sorry, can you repeat your question again?
So I understood the question. So I think she is asking for definitive treatment, definitive role of laparoscopy. Okay, so I would say that only and only diagnostic laparoscopy we can do in ovarian malignancy. Apart from that, there is no role of laparoscopy in management of ovarian malignancy, whether it is early or advanced.
But even then we cannot do laparoscopy. It has to be a staging nephrotomy.
No, ma'am, there is no role.
In stage 1A1 tumor, if the tumor or adnexal mass is very small, we can go for this laparoscopic staging. We can do this excision, laparoscopic excision of the cyst, and we can retrieve the specimen through this endo bag to prevent the spillage, and rest we can remove laparoscopically. The TH we can and BSO we can do, peritrectomy we can do, omentectomy we can do, and the pelvic and para-aortic lymphadenectomy we can do with
So,
laparoscopy.
thank you. I think we are running short of time. Also, just a final comment, because I can see in the audience, Dr. Kheradi, our teacher, is sitting there. That was the era. Still, that time also, the role of cytoreductive surgeries and all that, only this is a play game. Those time were using the cyclophosphamide and cisplatin-based chemotherapies. So, era changed and taxanes come and VGF and all, these are the drugs, and the role of these reductive surgeries, the lapse of time, and then these are the good literature is there, and definitely quality of life is good with a good surgery with a minimal residual disease. So thank you. Everything has well covered, and thank you.
Thank you.
Thanks, sir. I would feel really grateful if we could have our chairpersons on stage, Dr. Deni Gupta, Dr. Rajesh Singh Bal. Dr. Rajesh Singh Bal. Now I would like to invite Dr. Sandeep Batra from Delhi, and would also like to invite our panelists, Dr. Sunny Jandyal, Dr. Meenu Gupta, Dr. Rajiv Saini, Dr. Archana Chip, Dr. Lalit Sharma.
So I invite Dr. Sandeep Batra to conduct a panel discussion on carcinoma ovary and the role of targeted therapy in this scenario. Dr. Sandeep.
Thank you, Chair. And after that, a very good talk about the CRS. Let's continue with the management of ovarian cancer. And as such, chemotherapy per se, there has not been much change. It's platinum-based chemotherapy, vaccine platinum. However, the big change has happened in the management of the ovarian cancer with the targeted therapies. Just to name, it's VEGF therapy, anti-VEGF therapy, PARP inhibitors, and immunotherapy. Let's discuss about their role in the management. And let me start with my panel. Can we start from the left to right just to introduce your name, because it's your name, so that for me as well as the audience, it is easier to understand.
Hi, my name is Dr. Arjun Singh. I am medical oncologist based at Jammu.
Sir Meenu Gupta, radiation oncologist and clinical oncologist.
Dr. Sunny Jandyal, consultant medical oncology, GMC Jammu.
Dr. Rajiv Saini, consultant medical oncology, Shri Mata Vaishno Devi Narayana Hospital.
Myself, Dr. Lalit Sharma. I'm a medical oncologist at Manipal Hospitals, Jaipur.
So thankfully, the topic is not involving much of the surgery, and we have medical and radiation oncologists. Just to set the things into the motion, we have a significant number of ovarian cancers diagnosed per year. And despite the best possible cytoreductions treatment, 70% of the women relapse. So requiring a very good management as well as continuous improvement upon the strategies to treat so as to decrease the chances of recurrence and improve survival. So this is the typical way recurrences happen, and this is the typical time span between different recurrences, which keeps on decreasing with the every further recurrence. So your first shot is the best shot when you need to have the best possible modality of treatment to improve the survival outcomes. And obviously, once it is a recurrent ovarian cancer, then obviously cure is unlikely to be a possibility. And the idea of treatment is improvement of progression-free survival and trying to improve the overall survival. These have been significant milestones in the development of the ovarian cancer. As you can see over the last 5-6 years, the main have been the introduction of the PARP inhibitors, which have changed the outcome of the ovarian cancer patients significantly. So just to start, so we will not go into any discussion about the diagnosis of the ovarian cancer and the chemotherapy backbone of the treatment. The main treatment discussion will be these 4 buckets that I've already defined for you. So for the sake of the discussion, assume that finances are not a bar. This is a completely academic meeting. And we have a newly diagnosed ovarian cancer who has undergone a cytoreductive surgery. And now the patient, you can start with it. We can start with the diagnosis, and after the surgery, what is the management that is going to help the patient. So these are the 4 categories. HRD, for the convenience of the audience, HRD is heterozygous deficient, homologous recombinant deficient. It is unknown or not known when the patient has not undergone the testing. Then one is HRD positive, BRCA wild type. Third subgroup is HRD positive, BRCA mutated, and 4th is HRD negative. So 4 subsets. So to start the discussion, Dr. Arjun, let me start with you. Don't imagine yourself working at a secondary or a tertiary practice. It's an academic setup. Now the patient has been newly diagnosed. Do you routinely do the HRD testing, or you do the BRCA testing, or you wait for the surgery to be happened, chemotherapy be finished, or recurrence to happen to do the test?
No, so for me, if there is no financial bar, then I go with the directly HRD. Best way to go with HRD, along with the, if HRD done, that include BRCA also. But if not, then HRD also. HRD should be done at least.
Definitely, in today's scenario, we have to go for the BRCA and HRD testing at the time of diagnosis, because good data is available even even low risk cases, not only in the high risk cases. The studies are well and data is available, and we have to go for this testing at diagnosis.
Sir, I usually do germline mutation first. If it's negative, then I will definitely do HRD.
Any difference of opinion?
So in the ideal scenario, we definitely should do HRD testing, because 25% of patients we miss if we are not doing HRD testing. And since we have the data of maintenance therapy with olaparib plus bevacizumab in this subgroup, so ideally we should do. But in my institute, I usually do germline BRCA mutation testing in every patient, and only those patients who are HRD, who are BRCA negative, in those patients I am doing HRD positive.
Totally.
Ideally, yes, but practically less than 25% patients are getting.
Okay. So, so that's a fair point that if we go by the theoretical recommendations from all the big guideline houses, then it is to be done at diagnosis, and absolutely all patients should undergo this testing. But practically, as Dr. Lalit, Dr. Sani, Dr. Minu, etc., mentioned that it may be done later on also, once you are completing the treatment or if the patient is having influence. So let's come to first targeted therapy, because HRD percentage is 50%, right? Of that HRD percentage of 50, 10 to 15 are BRCA. So that means 50% of the patients will never be eligible for any sort of PARP-based maintenance therapy. So we cannot forget this drug. This was there for almost about 7-8 years to add to the armamentarium of treatment of ovarian cancers. So we start with Dr. Arjun. Do you routinely use, can we have one more mic, please?
Beta mic यहाँ
So do you usually routinely use bevacizumab in your practice?
Uh,
Don't go for the settings, routinely.
Not in Jammu right now, less likely, but yes, some patient I will start with the bevacizumab adjuvant setting.
Activate.
Yeah.
Okay.
In stage 3, stage 4, high grade serous and endometrial.
Quick, yes or no?
We are using routinely in our institutional practice nowadays for the last 1 year and 1.5 year, and maintenance also. Most of the patients.
Sir, it depends if upfront we have planned 3 cycles, then in the first 2 cycles, I'm giving Bev, in the third, I'm not giving. So we are giving, usually plan to give perioperative 6 weeks of bevacizumab. I mean, when we have.
You are using. Let's come to that.
Yes, absolutely, I'm using. Off label we are using.
Sunny.
Sir, we are using, but not on every cases. In those cases which are advanced stage 4, 4A, particularly those who have mild pleural effusion,
Lalit.
in those patients.
Ascites, yes, but not routine.
Okay. So 4 out of 6 told that they will be doing HRD testing at the diagnosis. Okay. Now, suppose HRD testing shows your HRD is mutated or BRCA is mutated. Will you still like to start bevacizumab in such patients?
Yes, sir. Definitely, sir. I will go with the bevacizumab also. If I can use it as a parallel trial, there's clearly mentioned this bevacizumab along with olaparib as a maintenance and also in adjuvant setting as bevacizumab.
Okay.
Yeah.
So, Dr. Sani, you said you will be doing the germline BRCA1/2 testing. Okay. So, bevacizumab, you have not done the HRD testing. BRCA1/2 comes out as negative. You will be using bevacizumab?
If I have not done HRD testing, then yes. If I'm doing testing, then still I'll be giving bevacizumab.
Still missing that information of HRD, as Dr. Arjun said, that if you are going to use the Paola data, then you need to have the HRD information with you before you can develop on what is the final strategy for treatment. Okay, so these are the 2 main trials, ICON 7 GOG in the neoadjuvant, the adjuvant setting. There is not much change that has happened to the use of bevacizumab per se for the indication wise, but per se when I come from the setup I am working, the use of bevacizumab has been restricted only to the HRD negative patients because we do the testing at the baseline diagnosis itself. And as Dr. Arjun pointed out, stage 3, 4 or other panelists also advise for the same, that whenever there is a significant ascites or pleural effusion, that is the wet patients, wet ovarian cancer patients. These are the patients we usually think about using the bevacizumab.
But sir, most of the time, surgical oncologists are not very comfortable with the use of bevacizumab in neoadjuvant setting. Or
not very comfortable.
They are not very comfortable.
So obviously there is a gap which is required between surgery as
Time
Sunny
period
pointed
for
out.
the surgery and.
Yeah. So as Dr. Sunny pointed out that first 2 cycles. Yes.
But still they are very comfortable if the gap is around 12 weeks. That means you have to miss
As per the
8 to 12.
guidelines, the
This is
gap
8 to 12 weeks.
Gap is 6 weeks, and that too for a major surgery. If you are thinking about doing a diagnostic laparoscopy, biopsy, then even that gap is not warranted. The gap is only indicated when it is major surgery. So Dr. Sani has rightly pointed out that 1 cycle before and 1 cycle after you need.
Even in US, the insurance companies, they reimburse a patient if the bevacizumab is given in adjuvant for 15 maintenance doses. I mean, we are talking of 3C advanced only, not of early stages. And if even in America, if we give it in neoadjuvant setting, it is not reimbursed. So Dr. Rajiv is also right in a way that the use is actually off-label use. We have taken the liberty and we have devised a protocol.
We have done
Yes, absolutely.
So it depends on.
It's an off-label use, but I'm using it.
Now, the main juggler in the treatment outcome. So about one of the targeted therapies, that is the bevacizumab. Although we know we have been using in the past, we know there are specific situations where its use is going to help us more vis-a-vis situations where it is unlikely to help. Now, patient newly diagnosed has undergone a CRS, completed taxane platinum-based chemotherapies, HRD unknown or not done. So this situation, we don't have the tissue.
Okay.
There was some tissue which was only used for the histopathology IHC. After the surgery, it is the arterial section and there is a pathological CR, so we don't know what is the HRD state.
Okay.
What will be your advice for maintenance in such patient, first line patient?
This is first line, sir. I go with bevacizumab only, HRD negative, bevacizumab maintenance.
So it's not HRD negative, HRD
Unknown, it's bevacizumab, sir.
There is a difference
Ah,
HRD
yeah.
unknown and HRD negative.
It's I go with the bevacizumab, sir. And this paclitaxel along with the paclitaxel complete and that done, and then
Now it's time to decide about the maintenance in the
Uh,
absence of HRD information.
sir, there is a recently there is a lot of controversy regarding the PARP inhibitors in the maintenance setting, the first line, and there is a lot of indication they've withdrawn the especially rucaparib and the niraparib, and still there is olaparib indication in maintenance. This is a recent guidelines in the US, and for me, I go with only bevacizumab in this case.
Only Dr. Meenu.
Definitely VGF, we have to use this BEVA and know the latest literature came even for the role of the immunotherapies along with this such scenario. There's a new data that is, but VGF we have to go with this patient.
So I assume that you will be continuing PGF if you started in the adjuvant setting. It's not that once you complete chemotherapy and then what is the need? HRD unknown.
So I'll give,
Only did the germline BRCA one to start with, and now there is no tissue for HRD.
now there is no tissue left. I'll go with bevacizumab maintenance.
So you will not think about Paola one subset, which was HRD not known, and they showed some benefit, although subset analysis showed some different findings. Dr. Rajiv.
If we have used bevacizumab preoperatively, then definitely continue to bevacizumab maintenance. But still, I'll give patient benefit because we have the chances of 50% chances of that patient has HRD positivity. So I'll definitely go with that.
Arjun. So I have a different contrapoint. He's right in saying maybe as of today, right, in future, don't know whether he's not. HRD known or not done status, 50% patients are HRD positive. So you are removing the benefit of PARP inhibitor if you are not giving PARP inhibitor.
Again, sir, I am okay with that, but 2 to 3 months back, there is a later lot of data is there. If upfront we use maintenance of PARP inhibitors, but on second relapse, there is a less likely chance with the platinum with that patient.
But the third slide, you have to decrease the chances of relapse.
And we any drug, it's okay. Any drug without any evidence use such an expensive drug in a patient, it is not. I think for me, it's for me. POP for yes, POP still is expensive as compared to olaparib.
So if I have labeled it as a bucket, HRD negative, you are very right in the absence of that information, HRD unknown. I would also agree with Rajiv at this moment that this is, you should probably add PARP. What's your viewpoint on?
So I won't be very convinced adding PARP inhibitors. Agreed that 50% would lose out on the benefit of PARP, but 50% would be getting unnecessarily a drug, which is not only going to cause their just a financial toxicity. These drugs around at least
not a bar.
No, finance is not the bar, but at least 1/3 of these patients will have at least grade 3 to 4 toxicities. And maximum benefit
will be there with the HRD and BRCA mutated patients also. And
so
those
that is what I'm
patients who
trying to,
accept the
that is what I'm
toxicity and
trying to,
interest-
had she been positive, definitely I would have gone with the
That
maintenance.
going to come.
So that is
This
what I'm
the
trying to take.
situation and we
Say
definitely
50%
find the
of these
situation that issue
patients,
is not there.
50% of these patients will suffer unnecessary toxicity.
So that's the glass is half full or empty.
Yeah.
As Ajib said that maybe 50% they are positive. So you
So
would like
moreover, say if even if we look at the half full glass and we are giving additional advantage, we are improving the PFS, maybe overall survival also. We are not altogether eliminating the disease. It is not what cure which we are achieving after this therapy.
create some sort of controversy so as to incite the audience interest. So this is the most controversial. HRD unknown or not done, no one knows what is right. So you have to then take into consideration platinum sensitivity of the disease, any family history of first degree, second degree relatives, and then you can probably think that this patient might be harboring a BRCA or genetic mutation. So coming to the next. So Dr. Arjun, HRD known, unknown or not done, and negative. Niraparib based on prima data, rucaparib based on ethena mono data. Okay, these are the phase 3 trials
Yeah.
in which they did not do the BRCA or the HRD upfront to find out whether these benefit. Obviously, subset analysis is there. Niraparib on the basis of PRIMA is approved by the FDA for the first line maintenance for all comers.
Recently,
All comers,
recently.
irrespective of the HRD. BRCA.
So,
It's not approved by any of the agencies, but it is a poor man's cashew nut. It is to be given in place of the Oraparib or Niraparib when you have the requisite.
So before, I think 4 to 5 months, there is everything's clear on this PARP inhibitors. But recently, if you see the OS data of the PARP inhibitor as a first line maintenance, there is no any added benefit to the patient. As Lily sir rightly said, there is a toxicity mode to the patient, but no OS benefit of the PARP.
Now you are doing a cross trial comparison.
Yeah.
So that trial is with the Olaparib, bevacizumab combination. We are talking about Niraparib
And now come to this slide.
Then probably you are right. But if you go by the phase 3 trial and the evidence, since they are approved for the all comers, one cannot take a
And
stand against.
now come to this slide. I will go with this. If there's a HRD unknown or not done, then I go with the Niraparib as a prima. I will go with this.
But this is not available.
Yeah, this is not available in India. If available in India, then I go with the third option. So Olaparib, bevacizumab.
Yeah, about Olaparib as maintenance. HRD or BRCA negative patient.
BRCA negative, straightforward, no.
BRCA negative and HRD negative straightforward.
In adjuvant setting, you're
In the
talking.
adjuvant setting.
Adjuvant
First
setting
line.
for maintenance.
Maintenance.
No.
Okay, but you have these two trials, PRIMA as well as the Athena mono. These are all comers. These are without the HRD or BRCA status there.
If I remember it correct, the overall the scenario was unselected, and in the subset analysis, when we saw that it was actually the BRCA positive or HRD positive was deriving the benefit mainly, and in the negative settings there was no convincing data
That is the Paula 1 and the Solo 1 data. Na? When you talk about the PRIMA data and the Athena mono data. So the trial was positive for the all comers. Obviously, the quantum of benefits was different.
So the quantum of
Quantum of
benefit
benefit
was not that much over there. Plus, the thing is, we are talking about the targeted therapy setting. So I would be more convinced for the data to mature.
When you have invitation, you have a HRD high status, obviously the chances of benefit are high. Okay. HRD negative almost goes hand in hand with the HRD unknown or not done. Coming to the HRD positive but BRCA white. So let's start from Dr. Meany. HRD is positive, but BRCA 1, 2 are negative. Now you have to decide about the maintenance. Are you going to continue with the BEV if you started with and add on Olaparib to this, or you are not going to?
We can add Ola with the Beva in this case.
Okay. Any taker for a single agent PARP inhibitor in such patients? If the BEVA was not.
We have the data with the combination. They are the good PFS also and studies.
Takers for the single agent PARP inhibitor.
Yes,
positive.
in case Niraparib is available, yes. And if not, even in that setting, not that as comfortable as with Olaparib and BEV combination, but yes, Sucaparib.
So if I understand it correctly, correct me if I'm wrong. So a patient who is HRD mutated, if was started on bevacizumab because HRD status was not known. Now if HRD is positive, then based on subset analysis that we have, we will add PARP inhibitor to this. I'm right in my conclusion? Fine. Even I am also right as observation. Now come BRCA mutated. Obviously, when it is BRCA mutated, the HRD becomes positive. Now, this is the subgroup where you have all the choices. You are spoiled by choices. So you have Solo 1 data, you have PRIMA data, you have Athena mono data, and you have the Solo 1 data. So let's start from Arjun. Which drug, which combination?
This is Olaparib and bevacizumab, sir. I will go with this and bevacizumab. Yes, sir.
Okay. So Paula 1 Olaparib plus BEV was compared with the Olaparib. It was not compared with BEV. We exactly don't know what was the quantum benefit. And if you go by the cross trial comparison, the single agent Olaparib versus Olaparib plus BEV, they did not have much difference between the PF and the OS curves. Now, if you bring the cost into picture, now this is clearly BRCA mutated. Okay. Will you pass on the cost of BEV also? Sir?
Not likely, but in this, there is no any option of Olaparib. That's why I put on Olaparib plus bevacizumab.
Okay, so my fault, solo one should have also.
Sir, I think this is a much more simpler equation. You can use either of them. You can use olaparib as an.
Can, but you are going to use.
Sir, I am using the combination. I am using single agent rucaparib, sir. Yes, absolute. I have three patients. No, sir, I'm not giving the cost of bevacizumab. There is not much of a choice in that. It's a very simple equation. In our scenario, rucaparib is such a cheap drug and you have a target for it.
With the Beva as I started maintenance.
And will add.
Will add.
So all the panelists agree for Bev plus olaparib in this.
So I believe data wise, we can't kind of compare here. It would be all a cross trial comparison. It boils down to logistics. Logistics niraparib is out because it's not available. We are
Started with saying logistics and finances are not a challenge. You have these 3+1 single.
okay.
agent
Then my other logistic challenges not having an experience with the molecule. So now I am more comfortable with olaparib and
Okay,
rucaparib.
let's
So
leave out the niraparib and rucaparib. Now you have olaparib alone and olaparib plus bevacizumab. The question, the answer to this question, even I don't.
So if high volume disease to start with, olaparib plus bevacizumab definitely. Otherwise, maybe olaparib alone.
I think that's a simplistic view. A high volume disease or a wet disease with the infusions started bevacizumab. continued
For
and
more
added-
simple answer is that if we have used Bev initially, then continues the Bev plus olaparib. If we have not used Bev, then olaparib only.
then
I think
olaparib.
only.
Sir, I must share my experience that I have three patients, similar patients who have come out to be HRD positive, and they were all BRCA mutated as well. So BRCA mutated as well, but actually the BRCA report came later. Before that, the surgical path report came as HRD report. So my logic of using was that although it was a wet disease, I thought that maybe the patient gets a PFS benefit of maybe 3 years at that time. He or she will still retain the sensitivity to the original drugs as well as PEV. So I thought because we have a very limited armamentarium in ovary, so I thought I may re-challenge the patient with the same set of drugs. I mean, bevacizumab maybe 3 years later. If I'm continuing right now, it may be giving me a PFS benefit, but OS we don't know. Like the same story we say in fulvestrant plus what you call checkpoint inhibitors in breast. Whether we use letrozole followed sequentially by a palbociclib with the checkpoint inhibitor, I mean, the OS difference is not much. It's only a PFS difference of 17 months. Am I right? So from that analogy, I thought ki I'll rather save a drug for use in future, which may retain the sensitivity to the original drug.
We have already discussed directly or indirectly. These were the curves that I wanted the audience, the separation of the curves between the PFS and the OS benefit for the either olaparib as a single agent or olaparib plus bevacizumab as combination. We quickly move forward to the recurrent ovarian cancer. So we have already managed beautifully the first line. Now it's a recurrent. Recurrent, they are defined into two types: platinum sensitive, platinum resistant, based on more than 6 months or less than 6 months of the last platinum treatment. Now, platinum resistant, it doesn't make a difference HRD or BRCA wild or mutated, because you have already tested the platinum sensitivity. They are platinum resistant. So let's start from that side. Platinum resistant never had a chance to use PARP inhibitor, but is BRCA mutated. Would you be comfortable giving, after giving the chemotherapy, a PARP inhibitor? Imagine BRCA mutated. Theoretically, yes, possible. Practically, we have only 1 or 2 quad patients. I will mention more of them. Now, it's a platinum resistant. Within 6 months of last platinum exposure, the patient had a recurrence, but never has been exposed to PARP.
So platinum resistant, BRCA mutated. So I would be tempted to use it. In fact, I will use it, but with the explained this thing scenario that the volume or the degree of benefit might not be as good as in a platinum sensitive.
So that will be an individual decision. There is no data to support that. Okay, because in a recurrent setting, use of PARP inhibitor as a maintenance is after you prove the platinum sensitivity of the disease with a PR or a CR, which in case, as it is platinum resistant, you are not going to use.
my this choice is secondary to an anecdotal kind of scenario wherein I'm using it in one of my patient and somehow she's doing really good. So maybe I'm biased.
We were
So
playing
Dr.
with this
Sandeep,
question.
3-4 minutes left.
Okay, fine. So we were playing with this question, similar patient, BRCA mutated but platinum resistant. Then we sent the NGS to find out why this disease is platinum resistant despite being BRCA being there. So there was a BRCA reversion mutation, which nullifies the effect of the BRCA. And then you had to give something like everolimus to break that pathway so as to improve the sensitivity. And then you gave the platinum along with the everolimus, and then the disease becomes sensitive. Okay, coming to the last time, platinum sensitive, we have only 3 minutes left. HRD positive BRCA wild versus HRD positive BRCA mutant. Okay, guidelines are very clear. All of us know. You have to give a platinum-based chemotherapy, and the patient is put into CR or a PR with the platinum base. You are justified using a PARP inhibitor based on the phase 3 trials. Are you using it, Dr. Arjun? PARP inhibitor in the second line?
Yes.
Question is, you did not use PARP inhibitor in the first line.
Yes, I will use after platinum with that's maintenance with a PARP inhibitor in this setting. So
we have the first scenario, no prior PARP inhibitor, you will be using,
Yeah.
right? PARP inhibitor was used for 2 years and now the disease has come back, is platinum responsive. You are going to re-challenge with the PARP inhibitor?
yes, somewhere yes.
And third scenario, recurrence or PARP inhibitor. You put the disease back into platinum response. Now you will use it. Patient had progressed to PARP.
Definitely, sir, if platinum responsive disease, then I can put the PARP inhibitor in future also. If there is again response to the platinum drug.
Okay, but the patient progressed while on PARP inhibitor. Traditionally, in medical oncology,
In
a patient who has progressed on a drug, we usually do not use
Yes, we do not use
unless
that.
until you have Dr. B.
That's what, before just at the start of discussion, I mentioned about the role of the immunotherapies these days, and data is still coming for the. Okay. In our practice, as the question first two, we are using adjuvant PARP and but for the recurrence on PARP, still we have the immature data and experience also. OLA, they have recurrence, and because our patient got exhausted with the use for the one time, and with the coming years, definitely we have our own experience.
Just few more things.
We have, sir, second line, third line chemotherapy. So rather use them rather than again.
No, the question is very clear. Platinum, you have induced a partial or a complete response. Maintenance PARP, these 3 unique situations. No prior PARP, I think all of us will
Yes.
give it. Prior PARP more than 2 years.
Yes.
Logistically more than 1 year of last exposure, give it. This is the last which is still not answered. Depends on PARP. I may well not give it.
I'll not give it, sir.
So Dr. Lali, Dr. Rajeev,
I will not give.
I think with this, probably we are well in time. Thank you. Thank you, gentlemen. Thank you for your interaction. Thank you, audience. Thank you.
Thank you. Excellent discussion by Dr. Sandeep. We well played around HRD and BRCA and around the trials associated with it. All the panelists have discussed very well. Thank you.
Thank you.
I think bottom line is that we should do this HRD or BRCA testing, all the patients of ovarian cancer, irrespective of stage group. And some sort of maintenance needs to be given. Maybe PARP or bevacizumab, depending on what we have discussed. Thank you. Next in line. The talk is on relapse CRABECON.
Thank you, Dr. Sandeep. I would like to invite Dr. Nadeem Shaukat on the dais.
Good afternoon. First of all, thanks to Dr. Deepa, Dr. Satyanka for giving me the opportunity to present here this relapsed refractory ovarian cancer. And already a lot has been said about the ovarian cancer. As Dr. Rajra has, quite extensively explained about the cytoreduction. And then this panel discussion, it was very nicely conducted. And that too, quite extensively, every thing has been touched upon. So my talk will be focused more towards on the relapse case. So looking at the Global 2020 data,
So as we are, well aware how common is the ovarian cancer in the Indian scenario. So presently, Indian scenario among female, ovarian cancer is the third most common cancer. So it comes next to breast and cervix. So if we talk about the recurrence, so practically speaking, whenever I get to see a patient of a stage 3 or 4 ovarian cancer, it is at the outset, I just counsel the patient regarding the recurrence. Because recurrence is almost, so common, we can say that, roughly you can remember the figure of a 70%. So 70% of the patients you will get to see in stage 3 or stage 4, and so out of that, 70% will recur. So what is the common time duration at which they recur? They most of the time recur in about, say, 18 to 24 months. So, but then, although we do counsel them most of the time that this will recur, but that doesn't mean that people don't get cured. Even stage 3 also, they have got a quite good survival. In fact, many a times I have seen patients survive for 8 years, 10 years, even many a times they got cured also. So, this slide must have been repeated quite a lot of times, as we are well aware, how over a period of time, the moment the recurrences keep on happening, the progression-free survival starts decreasing. So, the same has been, that in this slide, as you can see that first line, we get to see median PFS of 18 months, then slowly that PFS keeps on decreasing, 10 months, 6 to 8 months. So, I think at the outset, whenever we get to see advanced ovarian cancer, our counseling should be like that. So now there are important variables we have to take into the account while we treat this recurrent ovarian cancer. The first thing that comes to our mind is the obviously platinum-free interval, and then as previously in the last panel discussion, they just pointed out that at the outset we have to do this BRCA mutation as well as HRD. At the diagnosis only. And then next step, we have to look for what previous chemotherapies patient has received and what is the amount of toxicity that is produced and what are the residual toxicities here. And then most important factor, that we have to see is this patient performance and then vulnerability. And then of course, patient preferences are also very important, and then physician choice. What are physician preferences? What are the physician experience? So that's all determine that what we have to go for a second line therapy. So, this is the conventional definition as we are well aware. What exactly constitutes the platinum sensitive, what is the platinum resistant, and what is the platinum refractory. So refractory, we say that whenever the disease recurs in, say, in next 0 to 3 months. But if anything less than 6 months, we call resistant, but 6 to 12 months, we can say partially sensitive, but if it is more than 12 months, recurrence has happened, we can call it a fully sensitive. So whenever we have a platinum sensitive recurrent ovarian cancer, we have a data for chemotherapy in the form of that we have those 3 trials, ICON-4, EGO-OR, as well as CRABECON. So ICON-4 constituted of this platinum plus conversion, platinum plus paclitaxel, same what has been what we generally do in a first line. And then another option, we have this GemCarb, and then we have this carboplatin plus PLD. So see, looking at the frequency, this all has to be explained to the patient. That how frequently patient is supposed to come, what are the expected amount of toxicity which can happen with those drugs.
Dr. Nadeem, I think you are not clearly in the.
Okay. So what are the expected toxicity, and so this all is to be explained to the patient, and more about the frequency also. If we look at this PLD carboplatin, here the frequency is quite long, say 28 days. But rest of the, rest of the 2 options, patient has become a bit frequent. So looking at the overall response rates, when we talk about with those 3 regimens, so if we see that ICON-4 as well as CRABECON, that is Paclitaxel as well as this PLD plus carboplatin, both produce almost similar kind of a overall response rate. But this GemCarb has got slightly lower overall response rate. But then if we talk about the median PFS, yes, again, the median PFS also stays same with the Paclitaxel as well as the lipodox carboplatin. But with GemCarb, the median PFS is slightly lesser as compared to the other 2 regimens. So we can say that progression-free survival and the response rates, we are almost, we find similar in the Icon 4 and Calypso. That means Paclicarb and this Lipodox carboplatin. So now the next important, concern remains the safety, because in a relapse setting, in a recurrent setting, the important remains the quality of life also. So for this reason, we need to be well aware of the, toxicities which are seen generally with those regimens. So that are to be explained beforehand to the patient. So many a times we have seen that like patient has previously got this alopecia with a Paclicarb. So most of the time we have seen that patient don't go for a Paclicarb, rather they choose to go for with the PLT carboplatin, because the alopecia seen with PLT carboplatin is quite less. So then besides that, neuropathy, this is one of the very big factors which limits us to use again the Paclicarb. And then other than that, but yes, PLT carboplatin has got altogether separate toxicities in the form of there you can get more of a mucositis, hand-foot syndrome, and then myelosuppression. So overall, if we talk about the safety comparison, Paclicarb cannot be given if patient has got already baseline neuropathy and it adds on to the neuropathy. Yes, alopecia remains a big concern with Paclicarb. And then in such patients, we can choose other agents. Gemcarb is relatively easy to tolerate, but if this patient has got a poor myeloid reserve, in that case, again, Gemcarb is expected to produce a lot of toxicity. So then coming on to the PLD carboplatin, yes, it has a big advantage over the other two regimens. Like you get to see less of an alopecia, but the bigger problem remains that this myelosuppression, and then besides that, mucositis and hand-foot syndrome. So now the question arises, as previously has been talked about, that in a newly diagnosed setting, yes, bevacizumab adds to the response rate, bevacizumab adds to the and this progression-free survival. So does the same applies in a relapse setting? Yes, we have answers for that in the form of a Oceans trial GOG 213 or AGO-OR 2.21. So in this, as you can see, different regimens have been chosen. Like in Oceans, they combined bevacizumab with a Paclicarb. With GOG 213, they combined bevacizumab with a Gemcarb. While AGO-OR, they used bevacizumab with a PLT carboplatin. And then one thing is to be remembered. Bevacizumab is to be used only when you have used it in the initial setting with chemotherapy, and then only you have to carry on with in maintenance also. Discontinuing it, using it only with chemotherapy and then discontinuing later, it won't add on extraordinarily. And moreover, starting it just in the later stages only, again, as a maintenance, again, it won't add on to the PFS. So what if just look at the median PFS? Median PFS was almost same in all the arms. So like with Ocean, it was 12.4 months after the addition of a bevacizumab, better. The difference was 12.4 months, and similar was the GOG 213 and AGO-OR also. But then if you talk about the median OS, although median OS was different 33.6 months, then with GOG 213 42 months, while AGO-OR 33.5 months. But one notable point here is, it was statistically significant. Only AGO-OR 2.1 showed that there is a statistically significant improvement in the OS with the bevacizumab. That has been to some extent, bevacizumab here has taken a sort of a backseat. Because no one trial could properly demonstrate the amount of OS, and considering the amount of cost involved in giving bevacizumab. But yes, if you talk about recurrent setting, recurrent ovarian cancer, here the priority remains also the quality of life. With bevacizumab, you get to see a quite a good quality of life, particularly regarding the ascites. Ascites formation, we have seen, to improve a lot. Now, the point arises that, okay, till date, we talked about the chemotherapy. Till now, we talked about this bevacizumab. So what about PARP inhibitors? As already has been said in the last panel discussion, yes, in a lab setting also, you can consider the usage of a PARP inhibitors, particularly in a maintenance. In fact, initially only the amount of a benefit was proven in a lab setting only. Later only in a newly diagnosed cases, they showed the benefit. So for that, we have evidence in the form of a solo trial, NOVA, or Ariel trial. So So one here notable point here is that in all of the trials, the primary endpoint they took progression-free survival. So as you can see in solo 2 trial, so here one notable thing is that as you can see that more than 2 lines has been previously exposed and they all included platinum sensitive cases. So what they in one of the arm they gave olaparib, another placebo. So with the primary endpoint was taken progression-free survival. Besides that, there was some secondary endpoint in the form of a OS or health-related quality of life. So, I mean, as you can see, curves are very, very much convincing. As you can see, there is a remarkable difference in comparison to the placebo this olaparib has produced. PFS is, I mean, 19 months, almost 4 times better than a placebo. So I think this is good enough evidence to convince to use those PARP inhibitors, particularly this olaparib. Then for a niraparib, we had another evidence in the form of a NOVA trial. Again, here a notable point is that yes, patient was a recurrence, this platinum sensitive recurrence. What they did, they stratified the patients in as per the germline BRCA also and no non-germline BRCA mutation also. So here you can see with the germline BRCA mutated patients, there was a remarkable difference in this progression-free survival. It was almost 4-5 times. But even if you talk about the non-germline BRCA mutated overall patients, again, there was a difference. But if you talk about the HRD deficient as well as the BRCA mutated, the difference is quite remarkable, quite high. So, I mean, as you can see the figures that here the median PFS in a HRD positive is 12.9 months with a niraparib, while with placebo it is just 3.8 months. And here also in a germline BRCA mutated, it is 21 months versus 5.5 months. So, I mean, those after looking at those figures, I mean, they do convince a lot for the usage of this niraparib. So coming on to the rucaparib evidence, for rucaparib evidence, we had a Ariel 3 trial. Again, we had all those patients who have been having high-grade serous or endometrioid ovarian cancers who have been exposed to more than 2 prior platinum regimens, and they were sensitive to the penultimate regimen of this platinum. So in one of the arms, it was a rucaparib, in another arm, it was the placebo. So again, the primary endpoint was similar, that it was progression-free survival. So even if you risk stratify it in terms of I mean, BRCA mutation or HRD deficient, as you can see, I mean, there is a remarkable difference in the curves that rucaparib is producing much benefit as compared to the placebo. So similar is the case as you can see the figures also. I mean, median PFS 13 versus 5, 16 versus 5. So practically speaking, in a, I mean, nutshell, you can say that roughly around 3 to 4 times is the amount of a benefit in comparison to the placebo with the usage of those PARP inhibitors. Now, I mean, as previously in the panel discussion, a lot of, debate was going for the usage of a combination treatment, like in the maintenance, combining bevacizumab with a PARP inhibitor. So we have a, I mean, similar evidence in this recurrent ovarian cancer also. So for that, again, as you can see, this patient was a high-grade serous endometrioid platinum-sensitive recurrent ovarian cancer. So here they combined niraparib with the bevacizumab, and the arm contained only niraparib. So if we look at the, I mean, median PFS, again, with the combination arm, it was around double almost in comparison to the niraparib. It was 12.5 months with the combination arm, while with niraparib, it was just 5.5 months. While if we talk about the median OS, there was not much of a difference. It was just around 2 months. So with on a median follow for 24.7 months, overall survival event and maturity was 52%. So this was all regarding the platinum sensitive recurrent ovarian cancer. But then if we talk about the platinum resistant, I mean, honestly speaking, we don't have much of options. I mean, whatever option we talk about, response rate is hardly around 10 to 15% or somewhere around maximum 20%, 25%. So we have whatever regimen you talk about, even if you talk about topotecan, you talk about PLD, you talk about gemcitabine or paclitaxel, docetaxel. So everywhere, I mean, progression-free survival is somewhere around 5 to 7 months, not more than that. So
Dr. Nadeem, just 2 minutes left.
Okay. So, I mean, there is definitely some kind of unmet need for the platinum resistant, this recurrent ovarian cancer. So that option was explored in the form of folate receptor. It has turned out to be a promising biomarker in ovarian cancer. And what it has been found that its expression is limited on the normal cell and more seen on the upregulated on the several cancers, particularly about the ovarian cancer. So if you look at about the usage in the ovarian cancer, as you can see that folate receptor was expressed in around 76 to 89% of the epithelial ovarian cancers as compared to the other malignancy, it was slightly less. So that was the reason why it was tried in this. And here the agent used was mirvetuximab soravtansine, although it's a tongue twister, I mean, difficult to remember, but still you can remember that folate receptor alpha inhibitor. So it was a fully humanized monoclonal antibody. It consisted of a maytansine derivative with a antimicrotubule activity. So similar like that of a TDM1, what we see. So it was just phase 3 study has been carried out in a single arm. And as you can see that the patient they included all those who have been previously exposed to around 3 regimens of this chemotherapy. So all those patients and even those patients, they have been exposed to previously bevacizumab, also PARP inhibitors, also they took all those patients. So they exposed them to mirvetuximab. The criteria for that taking patient was only that there should be high expression of a folate receptor. So that high expression constituted those patients who had a more than 75% of the cells staining positive. So just look at the CR. I mean, even in a refractory setting, forget about the CR. I mean, you hardly get to see any response. But here, CR was also seen. As you can see, I mean, although quite less, but yes, there was CR seen. And overall, if we talk about the overall response rate, it was around 35.3%. And even in those patients who have been exposed to more than 3 lines, there was around 30.2%. So whatever, whether you have used PARP inhibitors or a bevacizumab, there was a response rate seen. And moreover, more better response rates was seen in those patients who had been exposed to PARP inhibitors. So besides that, new approval has come up in the form of pembrolizumab, although I mean, it is just on the basis of those umbrella studies. So they did for all the solid tumors. What they found that MSI high or MMR deficient tumors, you can consider the usage of a pembrolizumab. So overall response rate in non-colorectal cancer patients, they found around 46%. So regarding role of a surgery, I mean, it has been already well elaborated by Dr. Rajra. I mean, it's a sort of a case-to-case basis. You have to take into account the role of a surgery in a recurrent setting. So although there are conflicting data by those 3 trials, so but it is only as per the case you have to take the decision. So with this, I end up my presentation with a summary that yes, paclitaxel and carbo-PLD are equally efficacious in relapsed ovarian cancer, and regimen is to be selected on the basis of previous therapy and safety profile. And yes, addition of a bevacizumab can be considered, which adds on to the response as well as progression-free survival. And then maintenance therapy with the PARP inhibitors has to be strongly considered, particularly in setting up a BRCA mutation or a HRD positivity. And option of a surgery is to be explored on case basis only. Thank you.
Thank you, Dr. Nadeem. Any question from the audience? So it was excellent talk. And I think platinum-free interval is the sort of a predictive marker when we have relapsed recurrent carcinoma ovary, because we know that whether platinum is going to work again or not. So PFI is the key word, whether we can use again or not. And in fact, once we have recurrence, so role of maintenance is definitely there, as here clearly shown with the newer emerging PARP inhibitor. We are already practicing 2 molecules, that is olaparib and rucaparib. So we should consider maintenance if we achieve some response in relapse refractory setting. Thank you. So over to next session.
Thank you, sir. I would like to call our chairperson, Dr. R.C. Sharma, Dr. Archana Parihar, Professor and Head, Dr. Amandeep Kaur, to grace the chair. Dr. R.C. Sharma. Senior gynecologist, Dr. R.C. Sharma. I would also like to call our panelists, Dr. Aman Sharma, Dr. Kanika Batra Modi, Dr. Avnash Rajra, Dr. Sejal Goyal, Dr. Sandeep Kaur, Dr. Paras Khanna. I would like to call Dr. Deepak Abrol on the stage.
With permission of chair, I start. Welcome panelists. I am actually a stopgap arrangement in it because Gautam Goyal has to moderate it and due to some unavoidable reasons he couldn't come. So forgive me because I had just made this presentation in just 5 minutes. So you have to take over everything. So we know cervical cancer basically textbook writes it's a bread and butter of radiation oncologist. But we have kept it a case where role of radiation is little bit not so much. And surgeon and chemotherapy, immunotherapy have come in a long way. So advanced cervical cancer, I'll first ask Sajal Goyal, Dr. Sajal Goyal, how will you define advanced cervical cancer?
Sir, first of all, thank you for the bouncer which you threw at the beginning. Now, considering those advanced cervical cancers, do you want us to restrict to locally advanced or more advanced, metastatic?
Basically advanced
Yes.
means metastatic.
So one of the thing is metastasis of the disease is there. Then definitely the para-aortic nodes, if a cervical cancer patient is there and she is having a para-aortic nodes, which are technically not means they cannot be radiated. They are above the renal hilum. And that's what I consider.
Can anybody take it in a another postgraduates are also sitting to define it in
So cervical cancer, we can define it into advanced, into basically the one that is locally advanced also. So locally advanced is anything that is 1B3 or 2B2 onwards. And advanced cases, the definitely advanced cases are the metastatic ones, and stage 3 and stage 4 are definitely advanced. But this bulkiness of the tumor, that is once it becomes more than 4 centimeters, it becomes locally advanced. That is how it is defined, locally advanced cervical cancer.
Paras, can you add?
So while there's no debate as to when we talk about a metastatic or a non-metastatic setting, but I think when it comes to choosing the treatment, I would like to just give my input here that probably the watershed of 2B of parametal involvement is where we would easily shift the algorithm in favor of our primary RT treatment as against going in surgically. So probably yes, I get the point where a bulky disease at 1B3 is being counted as advanced, but then maybe taking into account the parameter spread, where now the primary modality changes would be a more pragmatic.
Aman, Paras is saying 2B.
Yeah, I think first we have to see, I would like to divide it into three. Say it's a early cervical cancer, then it's a loco-regionally advanced disease, and then it's a advanced disease. I think what you're talking about. So advanced disease, if it is not loco-regionally advanced, then probably it's a metastatic disease. And because now there's a paradigm shift in how we are treating the metastatic disease. So I think we can further divide, if we are talking about the metastatic disease, into a oligometastatic disease and a polymetastatic disease. Also, I think we can further stratify them based whether it's hematogenous spread or it's non-loco-regional lymph node metastasis, say inguinal, para-aortic or supraclavicular. So I think even the metastatic, I think what I understand is that you're talking about the metastatic disease, which itself is very heterogeneous. And there is some data which is emerging up and showing that addition of curative treatment is improving survival. So if it is a metastatic disease, then also it's important that we stratify them into a oligometastatic and a polymetastatic. And also whether the metastasis in the lymph nodes alone, lymph nodes plus bone, and also maybe brain. So again, it's a very heterogeneous disease. If I understand correctly, then probably it is an M1 disease.
So before we go on to listen to words of wisdom of Dr. Sameer Kohl, Dr. Avinash, can you add something in it?
Disease is locally advanced when when it is a very bulky disease greater than 4 centimeter, or starting from the 2B where parametrum is involved. So it is the cutoff where the radiation oncologist takes over. So I would preferably call a locally advanced as a bulky disease greater than 4 centimeter and parameter invasion or invasion of other organs.
My basic point in keeping this question was, when Satyankar kept it as advanced, I was telling him to keep locally advanced or something like that, or metastatic. But there are certain things, there are certain places where we find this word advanced cervical cancer. So what should we discuss in it? Locally advanced and metastatic, or metastatic only?
So if you classically go by the definitions, whether you want to follow the FIGO classification or you want to follow the NCCN guidelines, ultimately, there is a lot of debate as far as this word advanced cervical cancer is concerned. Now you ask me a question, why? A parametrial invasion in a non-metastatic cervical cancer would possibly be more advanced than an operable cervical cancer with an oligometastatic disease. Because now you are able to unearth small distant metastasis with advanced imaging modalities. You are able to pick up, and you have realized with clinical trials that the results you probably get from a metastatic, oligometastatic disease is perhaps sometimes better than what you may get with a locally advanced cancer like parametrial invasion. So slowly and steadily, ultimately, the classifications, whatever they may be, are moving towards outlook with the current treatment modalities. Which one has a better outlook? Now, anything that has a better outlook as on today, as far as cervix is concerned, because even 2B in breast cancer would be considered early, whereas in cervix, it would be a late cancer. So there is a difference between the organs that you're talking about, and ultimately stage, slowly it's coming to that. There are many classifications, there's debate, but it's about the outlook, the overall survival and the median survival with the current treatment modalities that are available at the present moment for cervical cancer. So it's a wide variety.
So, well, everything has, for presenting symptoms, everything has been discussed right now. Would you like to add something? What are the presenting symptoms when patient comes to us and we label it as advanced cervical cancer? It's same question, something you want to add?
The most important symptoms which I feel as far as cervical cancer is concerned is postcoital bleeding. But in this scenario, it will be a persistent bleeding. That is more of importance.
I mean to understand for postgraduates and registrars, senior residents, whoever are sitting here, in a metastatic setting, mostly what we see, we don't have a medical oncologist in our panel.
I'll tell you the thing is that patient who is having a disease that is advanced, she is likely to come with abdominal pain, low backaches, which actually they're bothersome backaches, and the patient is not completely comfortable with
I'll
that.
frame it in another way.
Yes.
What are the sites we frequently see metastasis from cervical?
So considering from top to bottom, you see the supraclavian lymph nodes are there, then paraiotics are the one, and the definitely the pelvic nodes, then the local disease which is there, and the disease that is very much advanced, and because of persistent bleeding, patient is likely to have symptoms of anemia. And the other thing is inguinal lymph nodes cannot be ignored even.
Yeah, I think already very rightly explained that they can come in only lymph node metastasis, which are non-regional. It can come as then lung metastasis, hematogenous into the bone. Also, I think I would like to divide the patient based upon the performance status. So if I feel that it's a very advanced patient and then cachexia has set in, so maybe a metastatic disease with the cachexia set in, it's probably loco-regional, it's very, very advanced. And I feel the prognosis would be dismal, but that's my own gut feeling. And if the patient is well preserved and then it's a metastasis, I think the prognosis would be different.
Next, we're just focusing on what are the main sites where we see metastasis from cervical cancer?
As gynecologists, we are mostly seeing advanced cancers, sometimes presenting as severe constipation only. And when we do per vaginum, it's all nodularity, rectum is involved, ictria center case. And then there are extreme discharges. There can be bladder involvements. There can be retention of urine. They
Yeah.
can present with these
Local
symptoms.
pelvic
Yeah.
metastasis and
Yeah.
plus supraclavian lymph node we are frequently seeing in cervical cancer. Kanika ma'am, you want to add something?
Yeah, like, ma'am has already said, a lot of times they come with anuria also, retention, and also because there is uremia because of the hydronephrosis that occurs, pelvic congestion that is there, backache becomes severe because of the local disease. And also if there is lymphadenopathy, they press onto the nerve roots once they enlarge. So a lot of backache is what advanced cervical cancer patients face. Then apart from this, we also see in advanced cases peritoneal metastasis, and they often present with, abdominal symptoms and sometimes even with ascites when there are enough peritoneal deposits. So abdominal distension, omental deposits, all of them are there. And then obviously site specific with once there is pulmonary metastasis, you would have those kind of symptoms as well.
Sameer sir, you want to take on from here?
Can I add
Peritoneal metastasis?
I think we'll talk about the peritoneum in my lecture a little bit later, but yes, the local peritoneum does get involved. But more importantly, I've seen obstruction of the ureters in the parametrial space and the symptoms then emanating from that, which means urinary disturbances, lumps. Secondary symptoms related to the obstructed urinary tract and back pain would perhaps be the most common ones.
I want to add to it, patient with advanced disease can have fistulas as well. So the symptoms will be pertaining to those fistulas. The means the urine is actually coming out from the wrong route, and the patient is likely to have urinary tract infections as well.
Dr. Paras, what will be the diagnostic modalities you will use when such type of symptoms come to you? A patient with such type of symptom is coming to you with low back pain, hydroureteronephrosis. What do you want after suppose an ultrasound we are seeing? Or how will you evaluate such patient further?
So the first examination has to be a good clinical examination with a pervaginal and a perrectal examination. Any relevant involvement of the parametrium, the pelvic side wall is very well evident on a good clinical examination. There and then in an advanced case, you can pretty much make up your mind that this is the locally advanced presentation. And thereon, to be very honest, the patient will primarily go for a tumor board discussion if the biopsy has already happened. And that is how the further management will have to be planned. These patients will not just, like sir pointed out, if there's a pelvic side wall involvement or there's involvement of the ureters, I think something very important is to initiate a PCN at the earliest point in time. Otherwise, the patient may not be eligible for any kind of intervention in few weeks. So I think before embarking on any diagnostic algorithm in a patient of advanced disease, it is wise enough to subject the patient to a good tumor board discussion as soon as possible.
Dr. Avinash, anything you want to add?
After a good clinical history and examination to rule out the parametrial involvement and advanced disease, the first diagnostic modality, after a biopsy, first diagnostic modality we would use for local staging is the MRI of the pelvis, and to stage the further disease, CT of the abdomen, and the staging of chest is also important.
And in some cases, PET scan is even recommended for such kind of cases.
I think a pelvic examination would perhaps be the first thing. Most advanced cancers are clearly explicit on a pelvic examination where, if possible, punch biopsy right there from the OPD would be in order. Apart from that, obviously, hematological, biochemical analysis is important as for any other case. And ensuring if there are any comorbidities, because those investigations would also need to be included in the hematological and biochemical things that you analyze. But more importantly, imaging. Whether you do a contrast enhanced CT scan of the abdomen and pelvis and the chest, or you do a contrast MRI of the abdomen and pelvis, or you do a PET CT. And in perhaps in my setting, the one that I prefer, because I have it available, is a PET MRI, because I see that really is the most sensitive in detecting early parametrial disease. Now, because that changes outlooks. So a PET MRI, these are the and of course when the biopsy is taken today, unless you are sure that it is from the cervix, where up to the endocervix, that is where the primary is, you would certainly go in for a PD1, PDL1 today, and IHC, possibly by Ventana, if not DACO. But if you are not sure and you feel that it could be the lower uterine segment being the primary, then you might be in order even asking for a comprehensive genomic analysis today, because there is targeted therapy and other things available, which change the outlook in cases.
Paras want to chip in?
Just wanted to re-emphasize that probably in an advanced disease, which is evident on a pelvic examination, I think, as sir pointed out, probably a biochemical screen to know the serum creatinine becomes very important. Any kind of contrast evaluation will fall flat if the patient is already in anuria or some kind of renal damage.
But if it's locally advanced, we have examined and we are sure that it is advanced CA cervix, and at least locally advanced, because pelvis we can examine. Would you prefer CT scan or PET scan? Straight away. Investigation of choice.
So a single modality, I think PET would be really beneficial, because the question now is no longer surgery. The simple question is, are we looking at M1? Is it M1 or not? So the PET would score
My
over.
question is, if it is locally advanced, we have examined and we are sure that it is inoperable, because on examination you can see, you got an ultrasound basic investigation, then you are sure that it is locally advanced. We are not going to operate upon it or something like that. Would you prefer CT scan first and then PET scan, or as somebody was telling that contrast and CT, or straight away we should go for PET?
So let's take this question in two parts. So the distinguishment between parametrial involvement, are you trying to ask that whether it would be a clinical judgment or
Clinically judged after, I'm saying after clinical judgment,
if the parametrium is frankly involved?
Would you like to be radiologically sure that whether PET scan is needed or not, or would you go for a PET scan?
Single PET scan would suffice for a M1 setting, sir. If that is the question I want to answer.
But I want to add something. Whenever we are treating a cervical cancer, the role of MR cannot be underestimated, because T2 weighted images which are seen on an MR, they will make the pictures more clearer, and they will actually tell you the local extent of the disease. And in fact, when you are planning brachytherapy, so when most of the centers have been following MDAS-based guidelines. Yes.
That's what I was telling. Suppose we don't have MR LINAC or MR PET, but at least we can go for MRI first, and then see, and then proceed with PET scan.
Yes.
So that is the.
Basically, how we would concur is for understanding the local spread. MRI, even if we do pelvis, it's good enough. And beyond that, for ruling out metastasis, if you have the availability of PET, that should be the one-stop shop. But in case you don't, then you can get for a CT of the upper abdomen and chest.
So now we come on to the management part of it. We have diagnosed a case of.
Ma'am wants to say something.
Yes, you're absolutely correct, but it's not available everywhere.
Centers, because our institutional protocol MRI pelvis with the MRI abdominal screening is another side by side at the same sitting. No doubt the PET is another option, but this is the other going parallel with all
Yes,
those
point
investigations.
taken, sir.
No, I'm completely, because we've realized that obviously my colleague here is completely right. The MR images, the contrast MR images, because of the surrounding fat densities, much clearer for earlier parametrial invasion. In fact, they are on the side of overcon. They go a little bit tip. But if you are in a situation where you can combine an MR with a PET, which there are only a few centers we have, but if you have them, then believe me, it's the best.
Now,
expensive though.
So now we got a patient, 44-year-old female with locally advanced CA cervix on examination. And then we went for MRI. It was totally, parametrium was involved both sides.
we got a PET scan done, and we got supraclav lymph node and a 2 centimeter lesion in lung, which is FDG avid, and SUV uptake is say 18 or 20. So how will we proceed for the treatment?
So my question to you is, in this case, since she's at 44 years age, do we not want to give her advantage of living life? Maybe neoadjuvant chemotherapy can be considered in this case?
I personally feel that what you're talking about, and if the FNAC from the left supraclavicular node is positive, then you're looking at stage 4 disease. And stage 4 disease, I think imagining regression to an operable stage is a little bit
Possible.
fantastic.
Not possible.
So not possible. It'll be fantastic. So I think you've resigned to the fact that you're going to treat this patient with systemic therapy. Now, what systemic therapy would
Chemotherapy of what will be the
would
chemotherapy?
depend on either conventional chemotherapy, or if you're able to now use immunotherapy or targeted therapy.
So we'll come on to the immunotherapy afterwards. What are the chemotherapy options with us? Is there any medical oncologist sitting in the Dr. Sandeep Batra, sir?
Dr. Sandeep Batra, sir. Please be kind, sir. Sir, what are the options for advanced cervical cancer chemotherapy options? I think paclitaxel is one which
What are the
is regularly being
in
used.
case of CA cervix, locally advanced, diagnosed, got a PET scan done, there was supraclavicular lymph node and a 2 centimeter lesion in the lung, sir. So our panel says that we have to offer chemotherapy. What chemotherapy, sir?
As panelists have already said, chemotherapy wise, paclitaxel carboplatin is the best option. If you are going to put surgery into perspective at some point of time, okay, and want a response, I think there is nothing better than a doublet. But when surgery is not going to play a role ever, then you can add bevacizumab to improve the response rate, and then you continue as a maintenance bevacizumab to sustain that response. So chemotherapy wise, first line, taxane, platinum, there is nothing better for me.
And platinum cis or carbo?
So I would say both are equivalent drugs. With this cisplatin, especially in the CA cervix patients, when you have sometimes hydronephrosis, etc., cisplatin becomes a challenge. So we use carboplatin. There is a caveat that those patients who have been exposed to radiation in the past, it's a metastatic recurrence subsequently, metachronous, then probably carboplatin becomes a challenge because thrombocytopenias do occur. And in those situations, if the kidney function is affected, we use this as platinum. But per se, paclitaxel carbo is a well-tolerated.
Thank you, sir. And one more, sir, for you, role of immunotherapy.
You know, the commonest thing, just to interrupt you here, when we deal with advanced cervical cancers is that one of the ureters is invariably blocked. So the first thing that you ever do is put in a damn stent. That you should continuously look for, because once you put in the stent, there, and you are able to do it, because quite often you are not. So if you're able to do it, that should be the first step. If it's obstructed, invariably it is. But the other thing is that platinum, like he's talking about, platinum doublet therapy would be the ideal thing. Whether you add, I'm not sure how much of value adding a bevacizumab to that.
The NCCN guidelines say to add bevacizumab.
That's what I said. If you are not planning the local control by surgery or radiation cover, then it's better to use bevacizumab because that improves the progression-free survival. But if you are planning a local control, like you said, there is a lung lesion, a lymph node, and the cervix. Subsequently, if you are going to remove the cervical lymph node dissection, the lung metastectomy, and give local control with radiation surgery, then probably bevacizumab or bevacizumab should not be used in this surgery. Because then the question will haunt you after you have done the local control and the systemic control, whether to continue bevacizumab. So in the absence of a target, there is no use of target.
But can I just mention here that I've seen some fantastic results with TIP also.
So we used to use TIP as a neoadjuvant chemotherapy approximately 17 years back while I was at Rajiv Gandhi. Excellent response. But they were being used at that point of time as a neoadjuvant chemotherapy prior to surgery. Okay. Subsequently, the trials have come in which has shown neoadjuvant chemotherapy followed by surgery will not give an outcome which is better than the radiation. Okay, so tip, since subsequently also once the patient fails on the standard taxane practice, you have to reserve something. In the absence of something like a very much significant visceral disease, we only go with the combo with the doublet rather than.
Sir, a role of immunotherapies?
So I would say not very well established in cervical cancers out of all the gynecological cancers. In the subsequent lines, that is second or third line, when you have nothing else to offer, then you do the PD-L1 testing, MSI testing, and based on the approvals you get those. Per se, these are not hot tumors for the immunotherapy response.
Dr. Sunny?
I agree with Dr. Sandeep Batra. We are using immunotherapy if the PDL positivity is there or if there is MSI stability, instability. But nevertheless, cervix, once it has relapsed, is a very poor responder. It's a very poor responder to whatever we try. And once it is metastatic, like say in the lungs, it may be the only station. We never call it oligometastatic cervical cancer. It's never tough. So we treat it as a palliative intent only. And no matter what we try, one more option which we have used many a times in a resource concerned setting is a metronomic chemotherapy. That has been tried, and with the anecdotal response rate is anecdotal. I mean, maybe 5-10%. Celecoxib, cyclophosphamide, and this metformin.
So because of time
I
constraints,
think, no, just a quick, but one of the things that in advanced cervical cancer should be at the back of our mind is whether to treat at all, because stage 4 cervical cancer, squamous histology with the kind of handcuffs that you have to be really sure that you want to treat them, because what are you really achieving? What are the results like? They are deplorable.
so without asking presenting a case, without presenting a case scenario, I'm asking you because we are short of time. What are the surgical interventions in a metastatic setting?
In an advanced setting,
In a metastatic setting.
metastatic setting.
Suppose a patient is coming.
So suppose like, the
bladder and rectum are involved.
Yeah, bladder and rectum is involved. Role of surgery, I mean, apart from, relieving the ureters, as Dr. Kaul has already mentioned, first of all, that is one surgery you need to do. Then apart from that, doing extensive surgeries in the form
of pelvic exentration.
pelvic exentration. So pelvic exentration is mostly reserved for cases of cervical cancer, advanced cervical cancer, and in whom we have given chemoradiation and there is local recurrence after that. That is the indication. Whether we want to combine it with, anterior exentration or posterior exentration depends upon the extent of the disease. And we also have extensive procedures, the lateral extended endopelvic resections. They're called layers, to take away all the muscles also in case there is local infiltration. And obviously there are big surgeries. They do have therapeutic advantage. When everything else fails locally, radiation is not working, and there is a local disease that can possibly be resected out. And the patient, choice needs to be made according to careful patient selection, that they can undergo such an extensive surgery and then live their life with an ileal conduit after that. All these are very important aspects that need to be made. But yes, these extensive surgeries are possible, and the overall survival improvement is there in about 40-50% cases.
You are working in a center, ma'am, in Delhi, where people might be coming to you with such
Yes.
type of cases. How many time patient agrees to your this thing offer of pelvic exentration?
So
percentage wise, how many % patients agree and how many doesn't agree when you say that there will be ileal conduits and all that?
So about 50% of patients do agree for such procedures when we explain them that they improve your overall survival.
And Paras in our setting here, and Avinash also you check.
Choosing a patient for pelvic exentration is more about patient choice, as ma'am pointed out. There is a big difference between a salvage setting where CTRT has been given, the cervix is still in situ, and the disease is there. This bulky disease would invariably be going into the trigone. And even with the, like Sunny pointed out, this is a bad group. You operate on it, and within 2 months, you're staring at a recurrence. So you're going to question yourself: is this my right patient for an exentration?
Avinash, you?
Ideal patients are in my opinion. I'll let Avinash.
So a role of surgical intervention in such an advanced case. would be only in a salvage setting when in case of.
Don't go by that case. We are saying if the patient has come with the CS cervix, locally advanced involvement of bladder and rectum. Maybe recurrence with bladder rectal involvement.
Not upfront, but only in a salvage setting when chemoradiotherapy after recurrence of after a chemoradiotherapy, I would go for it in only a central disease.
Paras.
So not only a central disease. What is important is there is a difference between a patient who has undergone a cervical surgery prior, may have had the chance because of Sedlis criteria to receive RT, and then has had a metachronous recurrence centrally. This patient is different from a patient who has underwent CTRT and has a residual disease in the pelvis.
In your practice, how many times you have seen patient getting pelvic exentration?
No, I think they're increasingly less over a period of time now. They have, I mean, obviously, apart from the fact that they wouldn't feel comfortable, because issues of pelvic exentration impact very heavily on quality of life. So as a treating surgeon, I have to be first convinced that whatever I'm going to deliver at the end of the day, is it compatible with desirability in terms of quality of life? Because ultimately quality of life issues are becoming increasingly important. So increasingly less in today, and depends a lot also whether you treated this patient with the regimen of neoadjuvant chemotherapy, then a reassessment, then added converted to concomitant chemoradiation. That point, that discussion is very important when you reassess after the first 3 or 4 cycles, whatever you decide, as to what you're going to do next. Are you going to do concomitant single agent concomitant chemoradiation, or are you going to, at that point of time, I think clinical decision is increasingly important so that you choose the right. So bringing pelvic exentration a little bit upfront may make some sense in selected cases. But you have to be very sure, look at all aspects. It's a decision that needs to be arrived at in consultation with the patient, his or her family, and being convinced yourself. But yes, over a period of time, there are less and less exentrations there.
So a case of advanced CS cervix, metastatic setting, 1 centimeter lesion in lung, oligometastatic, and SUV uptake is 18. How will you treat?
And there is a lesion in the cervix as well.
Your medical oncologist in tumor board will say for chemotherapy, what will would you offer SBRT or not?
No, so that can be offered, and definitely means SBRT to a lung, the lesion is very small, that can be offered, as well as you can offer local treatment as well in that scenario.
सुबह से लगाऊं 5 मिनट दे दे. Aman.
Yeah, I think first coming to your previous case, you said that there was a small residual disease.
This case, please, yeah.
I think it's important because I think if it is a residual disease or it's a recurrent disease, there are 2 settings.
Okay.
If it's a residual disease and you have given 7 in 3 sessions of brachytherapy, I would add 1 more session of brachytherapy. This has happened in a clinical settings and we have got encouraging results. So you can escalate the dose by giving 1 more session of brachytherapy, and it helps. It's a small residual disease. If it's a recurrent disease, you have to see the extent of the disease and also see you require anterior exentation, posterior exentation, or total exentation. I think maybe it's, I'm not a surgeon, but I feel this is to be divided into 3 parts. For the lung metastasis, I think first I'll prove it, and we have to see if it's a synchronous metastasis or it's a metachronous metastasis. What is the DFI? So according to that, if it's a metachronous one, because it could be a second primary lung also. So you have to first differentiate between the metastasis and the second primary lung.
Differentiate between metastasis.
Biopsy.
If
it comes out to be squamous, then also we are in a mess.
Dr. Sunny?
If it comes to be adeno,
suppose 2 centimeter lesion is there in lung, and in tumor board radiation oncologist say I want to do SBRT in this case, would you straight away agree with him, or you will say whether it's a lung primary, we have to assess as sir is saying?
Sir, the first station apart from the nodal status is the lung only. Lung is the first trap, systemic trap where the metastasis reside. And in the natural course of the history of the cervix, the first site of metastasis is lungs.
That's what
If I know the patient is a lady and a never smoker, and the lesion is not peripheral, So I'll rather say it is most likely a metastasis rather than a primary. Having said that, there is one more say, Dr. Saab has said that we indeed have done a biopsy. In the biopsy, sir, we have to do P16.
Yes.
P16, if it is positive, we can say it is from the CA cervix, which was originally P16 HPV positive. If it is negative, we can actually say that it may be a primary. But in a lady who is a never smoker, although the adenocarcinoma you may see anywhere, but if it turns out to be squamous, so squamous usually does not never occur in a non-smokers. Small cell cancer and squamous cells, usually the non-smokers have adenocarcinoma lung. So if it's a squamous and it's matching, it's most likely to be a metastatic disease, number one. Number two, there is no such concept as oligometastatic cervix.
I think
A
there
single
is
site
there,
of
there is
metastasis is
single site
worse
of-
enough to
there is a
This is not
concept.
oligometastasis, but it's a single
Recently,
site of met.
I think Stenger has done an analysis. It's published in JAMA, and they've analyzed 3,000 patients. And in these patients, they have added a radical radiation plus brachy, and the median survival, I think, is 10 months versus 20 months. So it's a big series, though it's a retrospective data. We are slowly moving to it. It's not a prospective data, but of course, there'll be a subset of patients that will benefit. I'm not saying it will cure, but it will prolong survival. And if there's a single metastasis, the dictum is, oh, you always prove it.
So, okay, sir, then I may be behind literature, but as of now, it's not a standard of care. So, I mean, what sir is saying may be right, and maybe anecdotally we can use that experience.
We'll discuss it in the tea session. And though we are talking everything grim, but there is silver lining on the clouds that we are progressing. Medical science is progressing, and maybe in the next year CRABECON, we can discuss certain immunotherapy drugs which are curing these patients. As India is moving to moon, we will also come up with certain drugs which will help patients. Thank you. Thank you, my panelists.
Congratulations,
Thank you,
Dr.
Chairperson.
Deepak, for such a flawless conduct of this panel as you always do. Your execution is so good, and thank you, panelists, for such a